All right. Good morning, everyone. Hope you are well. Thank you so much for joining our regional symposium. My name is Sandra, and I'm the nurse educator for our regional program here at the Heart Institute. I'm co moderating this day with our chairs, Dr. Ian Burwash, Dr. David Masika, Lisa Milanchuk, as well as Cindy Cross. We have almost 180 participants registered from all over Ontario, as well as Quebec, and with representation from various healthcare professionals. So we're very excited everyone's able to join and is interested in our topics today. Our symposium is going to be focused on heart valves and heart failure disease. And before we begin our day with our opening speaker, I'd like just to run through a few details for the day. All our sessions will be recorded for ongoing educational purposes. The plan is for 5 minutes for questions after each presentation. If you're virtually, if we don't have a time to get to your question, please post it in the chat and indicate who the question is for, and we will follow up with an answer as soon as possible. For those in person, please raise your hand if you want to ask a question, and someone will pass the mic to you to ask the question. Our first break will be around 10:45 to 11, followed by lunch around 12:30 to 12:55. And lunch, of course, will be provided for in-person attendees. And then our afternoon break is from 2:30 to 2:45. We're also going to be giving some amazing prizes today, some gift cards to Amazon, Starbucks, and Tim Hortons. And we encourage you to participate in our 2 feedback surveys for a chance to win these prizes. And these surveys can be found in our digital event guide. So as you can see on the slide there. And finally, just a very special thank you to our sponsors, Abbott and Novartis, for their generosity, providing breakfast and lunch, as well as supporting the prizes throughout the day. So thank you so much. They do have some tables on the side of our auditorium that you can visit during our break periods. All right. So I'd actually like to now introduce Dr. Terry Masana, who is the President and Chief Executive Officer of the University of Ottawa Heart Institute. So under his leadership, the Institute's surgical program, and particularly the valve repair program, has really expanded dramatically to become one recognized as one of the best in the world. Dr. Masana has published more than 350 scientific papers from mitral valve repair techniques and outcomes to artificial heart technologies, regenerative cardiac cell therapies to coronary bypass and artificial valve durability, and as well as refining surgical treatments and guidelines. So although Dr. Masana wishes he can be here in person today, he does have a special greeting for us to begin our symposium.
Good morning. Also, I was seeking this to give you this message, this importance of heart failure and heart valves. For those who know, heart failure and heart valve have been very close to my heart all my life. I started my career to do a lot of research in heart and investing valves. I was surgeon, I performed a number of heart implantation and artificial heart implants. And here, of course, one of my passion for that disease, it's the complex mitral valve disease, the mitral repair, the bone replacement. But I think beyond that, as a CEO, I want to tell you how important is the work of these teams that we have at the institute that take care of heart failure patients, patients battling with heart disease. I'm very proud of those teams. The heart failure team is doing phenomenal things for various patients that are most of them at the end of their life and give them hope, prolong their life, or even have a second life. And for valvular, even if as a surgeon I have taken care of the patients at the end of their valvular disease, but they require surgery, I think it's very important that the heart valve team and the leadership of the CDAP has a bigger view on valvular disease looking at all the public health history predated by the viruses, how we can detect earlier the disease, how we can prevent the disease progress, and how we can actually avoid surgery, which seems weird from surgery to say how can we avoid surgery. Yes, it's better not to have a need for surgery than to have surgery for sure. So I want really to thank you for being there. It's very important for the Heart Institute to disseminate the extraordinary knowledge that we have accumulated as faculty, patients, and the team and the staff that is taking care of those patients. And today, I'm sure you're going to have a great day, and we're doing a lot of things, and we were excited, ask questions, and benefit from the teaching over fantastic team. We have the Heart Institute, which is, as you know, the biggest heart center in Canada, and one of the biggest center and program to that with us. Thank you so much.
Well, good morning, everybody. My name's Ian Burwash. I'm the director of the Echo Lab at the University of Ottawa Heart Institute, and I'm one of your co-chairs for the symposium today. I think this is a great symposium to have. We've got lots of important topics here, and we've got some great speakers. So I'm definitely looking forward to this morning, this symposium on valve disease. As Sandra mentioned, I've asked the speakers to talk for about 15 minutes, to leave 5 minutes for questions. So for those of you who are here in the room, we'll just get you to put up your hand. We'll get you a mic. You can ask your question directly. If you're in the virtual world, if you could just type your question into the chat, we will try to get that and get our speaker to answer that question. It is my pleasure to introduce our first speaker this morning, Dr. David Mesika-Zeytoun, who is a professor of medicine, an echocardiographer, and the co-chair for the symposium this morning on valve disease. Dr. Mesika-Zeytoun is the director of the Heart Institute's Center for Valvular Heart Disease, and he's really been pivotal in making this symposium happen this morning. So thank you very much for that. And this morning he's been tasked with addressing the topic unmet needs in valvular heart disease. And David, you could take it away.
Thanks, Ian. Thanks, everyone. Welcome. It's our pleasure to have you today. So I've been tasked to give you a broad picture of the unmet need in valvular heart disease. And also, how can I move the slides?
Remote in that computer, but I cannot. Maybe I'll do it in break. Yes.
I don't have the same slides here and here.
Do I come to you, or do I just go directly? Go there, but I can go with you. Okay, I'll be there for the break. Thank you.
And it didn't work.
Okay, maybe here.
Up here.
Yeah, double check.
I hope it doesn't count in my 15 minutes.
3 years of pandemic and we still have trouble.
If you have any question. So you have it, but I don't have it.
Yeah.
Okay. Okay. So first, valvular heart disease are disease of the elderly. We have seen a marked decrease in the prevalence of rheumatic heart disease now in Western countries. And what we are seeing now is mostly degenerative valvular heart disease that's related to age. I will also allude to that. We have also emerging new valvular heart disease. So our population is aging. Okay. Okay, you know the pyramid of ages, and in Canada, it was estimated that we have 7 million of people more than 65 years old in 2016, and we expect that number to double in the next 30 to 40 years. And valvular heart disease prevalence increase with age. Prevalence for patient between 65 and 74 is around 4%, and it's more than 10% above 75. And the most two common valvular heart disease are aortic stenosis and mitral regurgitation. Regarding the prevalence of valvular heart disease, we have the OXVALV study. They screen 2,500 of individuals more than 65 referred to primary care, and they perform a transthoracic echo to all of these patients. And they found that the prevalence of valvular heart disease was around 1.5 million in 2015 and expected to be more than 3 million in the UK in 2056. So more than double, and there is no reason for Canada to be different. And we have COVID, of course, but we have also new valvular heart disease that are coming and are more and more often seen, like calcific mitral valve disease, tricuspid regurgitation, and atrial functional mitral regurgitation. So prevalence of TR has been recently reassessed in the community. You can see that the prevalence overall in the population is very high. 0.55% of patients have significant TR in the community. It's more prevalent in men than in women, as the other valvular heart disease is increasing with age, and it's estimated that the prevalence of TR is very similar to the prevalence of aortic stenosis. In terms of mitral regurgitation, we usually classify patient with MR as patient with functional MR or primary MR. Primary MR when you have a disease of the leaflet or the chordae, and functional when the leaflet and the chordae are normal. And usually functional MR was repeated due to LV remodeling that you see in patients with ischemic cardiomyopathy or dilated cardiomyopathy. But there is a new entity that we are seeing more and more often now. No, you cannot see it. Okay. Okay, you have it. So it's atrial functional mitral regurgitation. Instead of be due to LV remodeling, it's due to left atrial remodeling that you see most often in patients with AFib, but also in patients with diastolic dysfunction. And the mechanism of atrial functional MR is left atrial remodeling and annulus enlargement. The prevalence of atrial functional MR has been also recently assessed in the community, and it estimated that we had a one-third repartition of etiology. One-third primary MR, one-third ventricular functional MR, and one-third atrial functional MR. And atrial functional MR as tricuspid regurgitation is related to atrial fibrillation. We know that atrial fibrillation is also the next epidemic. So we will see more and more patients with atrial functional MR and tricuspid regurgitation as well. And the third epidemic that we will probably see in the next future is calcific mitral valve disease. It's calcification of the mitral annulus that extend into the leaflet, causing mitral stenosis, mitral regurgitation, or a combination of both. When we did this study in the lab, we find that patients with severe mitral annular calcification represent more than 0.5% of all TEs that we have seen in the lab. In this study, we identified 167 patients with calcific mitral valve disease, so it's MAC plus a valve dysfunction. And we find that many of these patients had symptoms, and despite being symptomatic, most of them were conservatively managed. So clearly, valvular heart disease is the next epidemic. It's degenerative, but it's not passive. Most of these valvular heart disease have an active process going on, causing the disease. And despite having a better understanding of the pathophysiology of valvular heart disease, so far we have no medical therapy that can prevent progression. And as Dr. Messana mentioned, what we are doing now, it's a valve replacement or valve repair, either by surgery or by transcatheter. And if you don't do so, the prognostic is very bad. Most of the patient will die, but we know that if you perform an intervention, you markedly improve the prognosis, as in this study with patients that were at prohibitive risk for surgery. If you perform an intervention, you markedly improve the prognosis. So valvular heart disease are lethal, and if left untreated, and there is no medical therapy. But the good news is that we have less invasive therapeutic options now for aortic stenosis, mitral regurgitation, and as well as tricuspid regurgitation. In this study, we collected all patients that had an aortic valve replacement for aortic stenosis in France. You see that the number of replacement has more than doubled between 2007 and 2019 with a linear increase. And this increase was mainly due to the increase in the number of TAVI performed, which now is a dominant form of aortic valve replacement in most of the countries. And TAVI was used at the beginning to treat people that were denied any intervention, but now it's used as a first-line therapy in patients, especially elderly people that have aortic stenosis. So the transcatheter therapies has completely revolutionized the management of patients with valvular heart disease. If you want to have a good management of your patient with valvular heart disease, you need to have the 3 pillars. You need to be aware that your patient has a valvular heart disease. You need a careful follow-up, and you need to perform a timely intervention in the centers with experience in the management of patients with valvular heart disease. Are we doing great in clinical practice? And the answer is no. First, if you ask people in the streets how they consider valvular heart disease or they are aware of valvular heart disease, the answer is that very little know what is valvular heart disease. It's far after stroke, Alzheimer, or cancer. The prevalence was 2%. We have campaigned for breast cancer, you have campaigned for Alzheimer, we have campaigned for a lot of important disease, but there is nothing on valvular heart disease despite the high burden of the disease. The first line was the most cost-effective way to diagnose patients with valvular heart disease is auscultation. But if you ask patients how often their GP is listening to the heart, you can see that most of the time it's either very rarely or never. It's both in men and women. It's a missed opportunity to diagnose patients with valvular heart disease. And we know again from the Oswald study that more than half of the patients with valvular heart disease are undiagnosed. So clearly, valvular heart disease are undiagnosed. They are not only underdiagnosed, they are undertreated. In this study from the Mayo Clinic, patients had mitral regurgitation. They have been diagnosed with severe MR. They had an echo. They have access to care at the Mayo Clinic. And despite having a class 1 indication for intervention at the Mayo Clinic, only 20% get a mitral valve surgery. So patients are undertreated. And we have a very similar result in France. We collected more than 1,000 patients that have been admitted with MR in France. And you can see that only 8% of these patients get an intervention within a year. You can also see that the population is very different from the population you see in surgical series. Mean age was 77. You have more than 10% that were 90 years old or older, and many of them had significant comorbidities. And the outcome of this patient is poor, 1-year mortality 14%, and outcome at 1 year for mortality or readmission for heart failure is 1/3. And it's true for patients with primary MR and secondary MR. And the STS, you see the same. Patient collected between 2011 and 2016, you see that the percent are presenting very late in the course of the disease. 50% had already heart failure, 50% had a reduced EF, and 24% had elevated systolic pulmonary pressure, so late presentation. In AS, it's the same. We collected almost 1,200 patients with aortic stenosis in this multi-center study, mostly elderly, frail, with comorbidities, and the rate of patients with severe symptom and LV dysfunction was high. Same for TR. We collected more than 17,000 of patients with TR in France, 2014, 2015. Mean age was 75. Half of them had a heart failure. Ischemic or dilated cardiomyopathy was very common. And only 10% of patients admitted with significant TR get an intervention within a year. Even patients referred for an intervention for mitral valve. So they have mitral valve regurgitation and they have tricuspid regurgitation. 1/3 did not get any intervention on the tricuspid valve at the same time. And the prognosis of the patients that are conservatively managed is poor. In hospital mortality is 5%, and 1/3 again of the patients are either readmitted for heart failure or died. And despite the high prevalence of TR, we look at the number of tricuspid valve surgery performed in France. Only 120 tricuspid valve surgery isolated for TR were performed in a year in France. In the US, it was slightly higher, but the population is higher. We have seen a slight increase in the number of tricuspid regurgitation for isolated TR performed in the US, but still the numbers are very, very low, especially when you compare to the prevalence, which is expected to be 1.6 million in the US of patients with TR. So valvular heart disease are undertreated. Patients as we feel late in the course of the disease. And one of the reasons is probably in some parts, the knowledge of the physician. They are not aware of the natural history of valvular heart disease. They are not aware of the risk-benefit of performing an intervention. So if we want to act, we need to improve the knowledge, and that's why we are all here today, of physicians taking care and medical care provider taking care of patients with valvular heart disease. We looked at intervention now performed in patients with mitral regurgitation, both functional and degenerative MR. And what is striking is that if you look at the rate of mitral valve repair on the lower line, I don't have my mouse, I'm sorry. The rate of repair, even in patients less than 60 years that have a very low Charlson score, so 0, rate of repair is only 80%. Is decreasing with age, and we know that repair is also the best treatment also for patients that are elderly. And there is a marked disparity between the rate of repair for men and women. And it has been called the lottery of mitral valve repair surgery. You get a repair depending on where you get your surgery done. And there are also some inequity according to countries. In these studies, they compare access to TAVI between the state of New York and Ontario based on the ICES database. And you can see that access to TAVI was markedly lower in Ontario compared to US. And we have also sex disparities. You can see on the right right part of the slide that the mortality of women is significantly lower than the mortality of men. And one of the reasons for that is that the rate of referral for intervention in women was significantly lower than the rate of intervention in men. So we have inequality in the treatment provided for valvular heart disease based on age, sex, and country specific. So in conclusion, we are doing poorly. Valvular heart disease is clearly the next epidemic. If you don't treat them, patients die. We have now new option to treat patients that were previously denied in intervention. But despite that, there is a low awareness of valvular heart disease in the population. Patients with valvular heart disease are still underdiagnosed, undertreated. They are left late in the course of the disease, and we still have no medication to prevent the progression of the disease and avoid an intervention. So clearly, there is an urgent need to improve the management of patients with valvular heart disease. We need to improve our screening strategies. We need to improve the way we are referring patients and organizing the care of patients with valvular heart disease. And when an intervention is done, it has to be done in a valvular heart disease center of excellence. In 2022, we create the Canadian Cardiovascular Society Working Group on Valvular Heart Disease that I'm chairing, and we mandate Institute of Health Economics to provide a white paper regarding how we should develop a strategy to improve the care of Canadian patients with valvular heart disease. And if you're interested, we have recently published 2 papers, one editorial in Canadian Journal of Cardiology highlighting this strategy, and a state-of-the-art review in the European Heart Journal. And I think I'm on time. Thank you.
Thanks a lot, David, for showing us some very sobering data and giving us an idea of the landscape. Is there any questions in the audience? The chat.
Just for IT, we don't see the slide on this screen, which is quite difficult for the speakers.
Maybe I'll ask the first question then. You know, something that's been a real problem with valvular heart disease is the fact the lack of medical therapy, despite the fact that, you know, we see that as an active disease. You know, if you think about aortic stenosis, like it's an active process going on, yet we don't seem to be getting anywhere. We've looked at statin medications. They haven't been shown to be beneficial. Do you have some thoughts on other medical therapies that maybe would be of potentially of value in this condition?
No, it's a very good point. It's sobering that we have no medical therapy. So we are testing two drugs here. We are testing the colchicine, which is an anti-inflammatory drug, which is probably has an effect against apoptosis as well. So we are trying that. There is also ongoing RCTs with LP-little-a reducing agent. So we have strong evidence that LP-little-a is associated with the prevalence of AS. We don't know for sure if LP-little-a is associated with progression. So in all the studies you mentioned, just to give you a background, what we have seen first is that all cardiovascular risk factors were associated with the prevalence of AS. So based on that, we thought that if you treat the cardiovascular risk factors as statin and cholesterol, you might decrease progression. And it was wrong. And our understanding of the pathophysiology of AS is that you have two different phases. One, which is occurrence of calcification, and one is progression. Occurrence is related to cardiovascular risk factors, but progression probably not. Despite that, we are still testing LP-little-a reducing agent to see if it has any impact on progression. But I agree, compared to medication in atherosclerosis or heart failure, we are far behind.
Cindy, anything in the so POCUS, point of care ultrasound, being used everywhere. Everybody's got a device and scanning people. What about it as a way of screening for valve disease?
I think it's a very good tool. We got a small grant to try to implement POCUS at bedside in GP offices. It was just before COVID. And after that, COVID came and nobody was doing in-person visits, so we stopped. And it was very difficult to restart. One of the reasons is that it's not reimbursed. And so if you ask a family physician to spend 5 or 10 minutes on top of his regular duty to do a POCUS to screen for valvular heart disease, it was very challenging. I don't want to go too far away with that, but Kate will present our next program using POCUS and how we can improve the screening in the community.
You wonder, because as we do guidelines on how people should be using POCUS, we specifically say to them, oh, you should not be assessing valve disease. You should be looking at LV function and RV function or pericardial effusion. But I wonder if that's maybe the wrong approach, that we should be, as part of the training, really telling people, to look for an abnormality, not necessarily quantify the severity, but looking for the abnormality as part of the assessment.
No, I agree. I think it's a very good tool. I don't see why not looking for the valve. You use your stethoscope for looking for a murmur. So why you cannot use a POCUS just for the same things? So I think we should look for abnormality. We cannot perform any quantification because we don't have the Doppler with the POCUS. But if you see something abnormal on the mitral valve and the aortic valve, it's an incentive for doing a comprehensive transthoracic echo, and we send you the referral after.
Thanks a lot, David, for the sake of. Oh, sure.
The Charlson Index is a comorbidity index. It's taking into account age and other factors like COPD, kidney dysfunction, a lot of different factors. It's a comorbidity index.
Earlier intervention or earlier diagnosis is useful. And then you're also showing slides how in Ontario, our access to treatment seems to be lower than in other places. So if, the efforts should be on earlier detection, earlier referral, but we have great limitations on the system in terms of management of the disease, how do you reconcile that? What is the Heart Institute doing to improve kind of that process of accepting more referrals if the expectation is to refer people earlier?
So there's 2 points in your question. First is access to technology, and second point is treatment. Access to technology is a different issue. We need to work with the government to improve access to new technology, increasing the number of TAVI that we can perform in every center. In my opinion, we should not have limitation in the numbers. Patients should get what they need. regardless of any numbers provided by the government. At the Heart Institute, we don't have much limitation regarding numbers, and we are providing either TAVI or surgery based on patient need and not based on current recommendation. Regarding early detection, it's very important if you want to perform a timely intervention. And we have more and more evidence as well. You can argue why doing early detection if you don't have medical therapy. We have also more and more evidence that if you treat patient early, even in some subset when they are asymptomatic, you improve the outcome, either by surgery or by transcatheter.
We'll take one of Cindy and then we'll move on.
Yes, good question. They are mainly shortness of breath, dizziness, chest pain.
Yeah, we better move on for the sake of time. Thanks a lot, David.
Thank you.
Did you want to introduce?
Yes. I don't know who is the next speaker. Oh, so Dr. Lowe is our next speaker. Dr. Lowe is a cardiologist at Heart Institute. His main clinical research interest is on infective endocarditis. He's an echocardiographer, and he will present the role of the endocarditis team that we have developed at the Heart Institute. Lawrence.
Good morning, everyone. Thanks to the organizers for having me talk about a topic that I'm quite passionate about. Just to, I think it's working. Out of curiosity, just to take a quick poll of the audience, can you raise your hand if you work in a tertiary care, like a hospital setting? I'm just kind of curious. Okay, great. And then if you work in a hospital outside of the TOH, is anyone perfect? Okay, thank you. So I'm going to be presenting on what's new in endocarditis, as well as kind of how that pertains to the heart team. Oh, okay, same issue. So to begin with, I'd like to offer some illustrative cases that I thought were kind of contrasting. So consider this case. A 50-year-old man comes into the emergency department. He's otherwise healthy, comes in with a month of infectious as well as heart failure symptoms. This is in the background of having recent dental cleaning. Blood cultures are positive for Viridans strep in multiple bottles, and this is his echo here. Basically, it shows this is the transesophageal echo of the aortic, zoomed into the aortic valve, and you can see there's severe aortic regurgitation. The valve is completely destroyed. There's multiple large vegetations on the valve. So of course, this is endocarditis. Pretty straightforward diagnosis. This person should probably go to surgery sooner rather than later. Okay. Oh, I see. Okay, so contrast that to this case. It's actually a case that we talked about on our endocarditis heart team a couple weeks ago. A 35-year-old woman who came into a hospital outside the TOH, history of multiple skin and soft tissue infections, active injection drug use, presented to the hospital with altered LOC and was found to have a polymicrobial bloodstream infection. And then her transesophageal echo is shown here. This is, you can kind of spot the abnormality right away. This is a large vegetation on the pulmonic valve, which is not something we commonly see. Her pulmonic valve is completely destroyed. There's severe pulmonic regurgitation. Her RV is severely dilated and dysfunctional. And then on top of all that, her capacity was kind of it was tricky sort of to ascertain. So a lot of complex medical and social issues there. So I just wanted to highlight with those two contrasting cases that endocarditis can be complex. It's a spectrum of disease. We've all seen the Duke criteria. It's a relatively simple criteria to use where we combine microbiologic data, clinical data, and echo data to define endocarditis relative to, how certain we are about the diagnosis. So definite, possible, and rejected. In reality, we all know that it's not that straightforward. Um, but and so when we do make the diagnosis or consider making the diagnosis of endocarditis, I would argue that taking the spirit of the Duke criteria, we do think about it in a spectrum of definite, possible, and refuted, incorporating all these different factors, the clinical factors, microbiologic factors, as well as echo and imaging data. But when we talk about these cases on the team, we think about each of these different factors on this spectrum. For instance, if we have a patient who presents with a subacute course, with a typical organism with multiple blood cultures, that's the infectious diseases specialists on our team are more likely to say this is clinically endocarditis as opposed to someone who clears their cultures quickly. Similarly, when we look at echo, there are like the first example I showed, when there's clear vegetations on the echo, it's, slam dunk, but sometimes we see things like thickening of bioprosthetic leaflets, which, can be endocarditis, but also can represent other disease entities. So when we take these different factors, we consider them along the spectrum. Endocarditis can certainly be complex to treat as well. And this is a fishbone diagram that you commonly see in quality improvement studies, highlighting kind of all the factors that go into what determines morbidity and mortality in these patients, including delayed transfer, delayed diagnosis, delayed surgery, and sometimes when surgery is not offered, and then lack of follow-up. And kind of to address each of these issues, there are key players, who have a role in this patient. And in the middle of all this chaos is the patient themselves, and kind of what their wishes and goals are. So this is just to highlight how complex it is and how many players there are, in the care of these patients. Moving on to kind of what's new in endocarditis. Endocarditis is not a new disease. It was first described a couple centuries ago, and really was a diagnosis based on autopsy. These patients tended to die. That's shifted then to patients who have had dental procedures and then have viridans strep and a subacute course. You all remember subacute endocarditis as a diagnosis. But nowadays it's more, they're older patients with previous valve surgery, a lot of sort of prosthetic material who come in with Staph aureus, a very acute course. They come in very, very unwell. That's sort of one population. And then the other population that we see is our younger patients with intravenous drug use as well. So with that, the microbiology has shifted too. But thankfully, fortunately, we do have more tools to use in making a diagnosis of endocarditis. As you saw, echo is sort of the workhorse, but more and more we're using CT and PET, which I'll get into in a bit. And then on top of that, we have more therapeutic options as well. So the first population I wanted to highlight was the population of intravenous drug use associated endocarditis. I'm sure a lot of us have taken care of these patients and understand the challenges both medically and socially with these patients. I think the heart team, in conjunction with addictions medicine, has been a powerful tool that we have to treat these patients. This one study looked at just that and found that incorporating addictions medicine on the heart team reduces time to addictions medicine consult as well as uptake of opioid agonist therapy. But again, these are small studies, sort of pilot studies, looking at this. In contrast to that, I guess, sort of echoing what Dr. Masika has said about our aging population, this is, also a population that we more commonly see in patients with endocarditis. These patients, come in quite unwell with previous sternotomies, and studies show that they, when surgery is indicated, they don't get surgery as often, and they do tend to do worse as well, compared to patients who are younger and don't get surgery when indicated. I mentioned kind of a multimodality imaging as a tool that we can use. Um, you know, I would say that echo is probably still kind of the mainstay of diagnosis, because there's uh, uh, temporal resolution is excellent with echo, but especially with equivocal cases, CT has been helpful to evaluate for things like pseudoaneurysms and abscesses. And then PET can be useful. PET and SPECT are useful to give us metabolic information when we're not quite sure if structural defect is indeed infected. Of course, access is an issue as well. This is something we're fortunate to have. These modalities are we have at the Heart Institute, but kind of this highlights the need for a referral center for endocarditis, especially for these complex cases. In terms of the therapeutic options we have, AngioVac or vacuum-assisted removal is a tool that we've used, several times now in the last couple months to debulk large vegetations. Basically, it's a large bore cannula that's connected to an ECMO machine, and it's basically as it sounds. We suck out large vegetations that are prone to embolizing. This is a case of Staph aureus endocarditis on the tricuspid valve that the team was able to remove with AngioVac, and you can see the pathologic or gross specimen there. So just briefly, in the last couple minutes, the heart team is a tool that we can use in endocarditis to talk about or kind of how to diagnose and treat these difficult cases. It's a team that consists of cardiology, cardiac surgery, infectious disease, as well as a nursing specialist. But we also have access to radiologists, neurologists, addictions medicine specialists as well when needed. The meetings occur weekly on Microsoft Teams. And basically, the case is presented with imaging as well, and we're able to kind of talk about the case and interpret the imaging in the context of the patient's presentation. And then afterwards, coordinate transfer the patient or any other testing or treatment as necessary. Importantly, the heart team is not meant to replace consultation with these specialties, but rather to supplement as an added opinion. Heart teams have in endocarditis have been shown to improve outcomes, especially when they're systematic and fully protocolized, and have been shown to reduce mortality. And on the flip side, we know that poor guideline adherence leads to poor outcomes, particularly as it revolves around surgery. Patients who have an indication for surgery but do not receive surgery do much worse. Some of the advantages of having the heart team are we're able to kind of discuss these cases in a synergistic way, incorporating all data kind of in one place, having a lot of expertise in one setting. And then on top of that, we're able to implement systematic checklists so that we don't miss any sort of details. For example, one of the important things about endocarditis is searching for a source, making sure the patient, has had adequate dental care, and also adequate follow-up, and we're able to coordinate that. Some of the limitations, as you can imagine, are difficulty with communication sometimes, where we've this is something that has been an iterative process. We've learned a lot as we've kind of had more experience with the heart team. We don't want to duplicate any work. We don't want to delay the care of any cases that are very straightforward, such as the first case I presented. But for difficult cases or equivocal cases, I think that's where our heart team, where the advantage lies. So just summarize that portion, the goals of the heart team are really to assist the treating team in making a decision that involves nuanced interpretation of data, and also ensure systematic guideline-based medical and surgical care and follow-up. And then we'd also like to provide expertise to healthcare teams outside of the Ottawa Hospital. We've been largely based within the Ottawa Hospital, but more and more we have cases from Montfort, cases from Renfrew, and even Pembroke Hospital, because we share kind of the Echo Lab in these centers as well. We read echoes in those centers, so we have access to that data. And then also on top of that, to grow our collective experience and expertise. So thank you for your attention. If you have any cases you'd like to bring to the heart team, you can contact either Amy Charlebois, who's the advanced practice nurse involved in the team, or myself. This list should be much longer than it is on this slide. There's about 20 individuals that are key in this team, including Dr. Masika Zaytoun and Dr. Kwan Chan, who you'll hear speak. But this is just the contact information there. So at this point, I'd like to take any questions or comments.
Laurence, do we have any questions in the chat? Said who?
Yeah. Yeah, so there's two types. We discuss cases that are challenging diagnoses, sort of equivocal diagnoses where things just don't add up, or where there's a high suspicion of endocarditis, but the imaging may not necessarily show that, or cases where the treatment is challenging either medically or socially. The benefit is that we can bring in, expertise in addictions medicine, for example, if indicated, or neurology when they're, say, systemic emboli to the brain with hemorrhage. Those cases are often quite challenging to deal with. The purpose of the heart team is to help again. So, it's a lot for one physician or one healthcare provider to manage all these moving parts on their own. So this is just an opportunity to get a lot of different opinions in one sitting. Yeah, so the best way is to contact Amy Charlebois, and you can see the email there, and she will, coordinate the imaging, gather the imaging that's required. It's very helpful for the treating team or someone from the treating team to attend as well to provide that context. But yeah, if you contact her, she will, let you know what needs to be done. Thank you.
It's finished. I have one question. We have some time. Yeah, the boss. Okay. Can you tell us a little bit more how many patients have been discussed, or and what you have some kind of preliminary data regarding the impact of the Heart Institute endocarditis team here?
Yeah, it's been a little while since I've looked at the data, but based on, we did a before and after kind of QA study, and we've shown that the time to surgical consultation has definitely been reduced. And then there's a trend towards improved outcomes, improved like heart outcomes. We've talked on our heart team so far. I'd have to ask Amy because she tabulates all the numbers, but we talk about, we discuss around, I would say 80 cases a year, 80 to 100 cases a year, both for diagnosis and management of these cases. Not all of them end up being endocarditis. But yeah, I think even in those cases, we do help the clinician kind of, to make that diagnosis.
Agree. Refuting the diagnosis of endocarditis is also very useful because
Yeah.
you don't treat the patient for 6 weeks for nothing.
Yes, exactly. Yeah.
Thanks, Lawrence.
Great. Thank you.
Yeah, as someone in the system here, I've certainly found the endocarditis team to be extremely helpful in the management of these complicated patients, because as you say, it's well beyond the medical problems. There's the social problems as well. We're just going to do a little bit of a change in the order of the sessions. Yep. Okay. Are you good to go? You're not huffing and puffing? Okay. So our next speaker this morning is Dr. Hassan Al-Fredi. Dr. Al-Fredi completed an echocardiography fellowship at the Massachusetts General Hospital in Boston and joined the Ottawa Hospital back in 2021. Where he's an assistant professor of medicine. He also works as a physician in the Center for Valvular Heart Disease Clinic, and he's going to talk to us about mitral regurgitation, mechanisms, anatomy, and natural history. Sam.
Okay, good morning, everyone. So it's a pleasure to speak to you at the meeting today. I'll speak about mitral regurgitation. I'll go through the mechanism, anatomy, and natural history of mitral regurgitation. I have no relevant disclosure. My screen here doesn't match what you guys see. I have two different screens. How can I turn it together?
We don't see the slide on the screen here.
We don't see the design project. Okay, let's do that. Or okay, so sorry for the interruption. So the objective today is to talk about the epidemiology and the natural history of mitral regurgitation. We'll go through the relevant mitral valve anatomy and etiology and mechanism of mitral valve. Overall, the valvular heart disease in general are so prevalent. So this data from a primary care screening program in the UK showed that half of the individual over age 65 comes with valvular heart disease. 6% of them would be diagnosed with severe or significant valvular heart disease. Most commonly is aortic sclerosis, followed by mitral regurgitation. The same, and this is expected to double over years. The same data reproduced in the United States, where 2.5% of the population is estimated to have valvular heart disease, with mitral valve disease is now exceeding the aortic valve disease. This come with cost either from a mortality standpoint and with also cost on the health system. In 2017, 23 billion was the cost of valvular heart disease. 14 billion of them is mainly related to mitral valve disease. In Canada, we know that hospitalization due to valvular heart disease is increasing, and that death related to valvular heart disease, mitral valve disease, represent a quarter of the mortality. Regarding the mitral valve anatomy, so mitral valve is a complex structure. There is a mitral annulus, mitral leaflet, chordae, and papillary muscle. Also, to have a normal functioning mitral valve, you need to have a normal LV and a normal left atrium, as you see in this. So for the mitral annulus, it's a ring of fibrous tissue that circumscribe the valvular orifice itself. The anterior aspect of the mitral annulus is in continuity with the aortic valve, as you see in this image here, while the posterior, which is less anchored and it's thinner and is usually attached to the myocardium only. Normal mitral annulus is between 4 and 6 centimeters square, and it has a saddle-shaped appearance. It's not a flat, and this is important to reduce the stress on the leaflet. And the mitral valve continue to deepen the saddle shape and flatten it during the cardiac cycle. It's also important to remember that the anterior mitral leaflet is a bit higher, while the two commissures are the lower part of the saddle shape. Regarding the mitral valve leaflet, there are two leaflets, anterior and posterior, as you see in this view. This is a surgical view where you look at that mitral valve from the atrium. The anterior leaflet is the bigger, covers 2/3 of the orifice or the valvular orifice. The posterior leaflet has 3 scallops based on an indentation on these leaflets, while the anterior leaflet matches this without specific indentation. There is a normal leaflet coaptation of at least 7 to 9 millimeter, and any reduction in the coaptation between the two leaflets will result in some degree of mitral regurgitation. And it's important to keep in mind the concept of mitral leaflet area to the mitral annulus. At least you want to have a 1.5 ratio between both, and the reduction in the mitral leaflet area to mitral annulus also give us a clue in understanding atrial functional MR. Pap muscle, there are two pap muscle, the posteromedial and the anterolateral. It's important to know that the anteromedial, the anterolateral is single head with dual blood supply, while the posteromedial is double head with single blood supply based on the coronary dominance. Chordal is important for echo to remember. There are 3 kinds of chords: primary, secondary, and tertiary. Primary attached to the leaflet edge, while secondary attached to the body of the leaflet. In terms of etiology, so we look at mitral regurgitation and by dividing them into primary and secondary based on whether the mitral leaflets are normal or not. So disease affecting the mitral leaflet, it's a primary, where diseases affecting the LV or the left atrium. Its secondary, other name is functional as well. So common causes of primary is myxomatous, this disease like mitral valve prolapse, degenerative changes or calcification, as we see in mitral annular calcification or radiation injury, infection, and we just had a talk about it with Lawrence, inflammatory as a rheumatic heart disease, and lupus. Secondary, the basic understanding was it's only related to the LV, but now we know more, and it's related, could be related to ventricular functional MR, where the LV is the disease, and atrial functional MR, where the problem with the mitral annulus and the left atrium. Another way of looking at also mitral regurgitation, not only from a pathological or etiological standpoint, is look at the function. And this was the first time that Carpentier came up with the classification. And it's relevant from a surgical standpoint to look at the mitral valve function and know what exactly is the problem to plan for the operative technique. And accordingly, he divided he classified the mitral regurgitation into normal leaflets as in type 1, with excess leaflet motion as in type 2. And a classical example is a prolapse flail spectrum, and when there is a restriction of the leaflet motion. And until now, since 1983, I believe, we still use Carpentier classification. And this is just reproduction of the same concept by adding more, dividing the functional into atrial and ventricular. So all comers with mitral valve regurgitation, this data from Mayo Clinic, were all comers with moderate to severe mitral regurgitation. Third of them have organic mitral valve disease, primarily degenerative form eczematous, where 2/3 has functional. And the function also divided into 2/3 have ventricular functional and a third has atrial functional MR. Outcome for all groups. Sorry. So the outcomes for all group are poor, worse in the ventricular functional MR. People with organic mitral valve disease end up having surgery more often, up to 40%, where the need for surgery was less than 4% in ventricular, in both functional MR. So a bit about mitral valve prolapse. It was first described in 1887. This was the first also publication by Parlos about when he described the click murmur syndromes in addition to demonstrating MR and the LVgram. It could be sporadic or familial. It's associated with some syndromes like Marfan syndromes or Loeys-Dietz. By definition, mitral valve prolapse is a superior displacement of the mitral leaflets of more than 2 millimeter during systole. Usually, we diagnose it in a long axis view, but also you could use apical tree as well. Classical mitral prolapse is associated with leaflet thickening of more than 5 millimeter. Non-classical comes with leaflet thickening of 2 to 5 millimeter. A flail is an extreme form of mitral valve prolapse where you ruptured one of the cord and the leaflet tip turned upward as compared to just leaflet above the baseline, with otherwise the tip is inferior. This is an example of a primary mitral valve prolapse in a patient with Barlow's disease. As you see, this is a TEE images where both leaflet anterior and posterior are thickened, and there's a central mitral regurgitation, and a 3D representation of that shows multi-segment involvement with predominant prolapse of the posterior, of the middle aspect of the posterior segment, which is B2. And if you compare this to patients with fibroelastic disease, as in this patient, where this patient in this view, you see that the anterior leaflet is relatively not thick, while the posterior leaflet is a prolapse and flailing. And you see here an anteriorly directed MR-JET. And in a 3D, you see the flail segment in the lateral aspect of B2. So mitral valve prolapse in general, either it's a Parlos disease with a multi-segment involvement. Usually it's a disease of young age, middle age, with a long-standing history of a murmur or a mitral regurgitation, as opposed to fibroelastic disease, which is a disease of elderly, usually shorter clinical history, more tend to have ruptured cord and a localized myxomatous degeneration as opposed to diffuse. Prevalence of mitral valve prolapse is 2.4% based on the Framingham heart study. And in patients with asymptomatic mitral valve prolapse, mortality is up to 20% in 10 years. However, if you have high-risk features like moderate to severe mitral regurgitation or EF less than 50%, the outcome will be worse. Our role as a clinician is to identify patients with high risk and intermediate risk as well in this disease. For secondary functional MR, the way you look at it is it's a disease with a relatively normal mitral leaflets, but abnormal LV or left atrium. resulting in either a central or eccentric mitral regurgitation, depending on the tethering force of the mitral leaflets. For secondary functional MR all comers, this data from Australia, they have a good data, national database of more than 500,000, and they identified all patients with functional MR, and 60% of them have ventricular functional MR, while 40% have atrial functional MR. And outcomes, although they, after adjusting for pulmonary hypertension and EF, remain similar. So the main mechanism of mitral regurgitation in functional MR is dilatation of the left ventricle with displacement of the papillary muscle. And it either comes with symmetrical tethering if there's no regional mole motion, but there's a global LV systolic dysfunction, and it could be also associated with asymmetrical tethering in ischemic MR. So this is an example of secondary ventricular functional MR. This is a TEE image, and you see here the LV is hypokinetic, and there is symmetrical tethering of both leaflets with central MR. And you could even in the 3D here see the coaptation gap secondary to the LV dilatation. Ischemic MR is a specific entity within functional MR, ventricular functional MR. It is MR due to coronary artery disease and not associated with, because you might have mitral valve prolapse with an associated coronary artery disease. It occurs acutely post-MI, but also chronically with regional wall abnormalities affecting the mitral valve coaptation. Both acute and chronic ischemic MR is associated with worse outcome. And in patients with acute post-myocardial infarction MI, the presence of any degree of MR is associated with worse outcome. In chronic ischemic MR, if you have the more severe the MR, the worse the outcome, and they identified an effective regurgitation harvest of 0.2 to be associated with worse outcome. Last is atrial functional MR. It happens in the context of atrial fibrillation and heart failure with preserved ejection fraction. It's quite common, and they are interconnected. You'll have always 40% overlap between AFib and HFpEF. The mechanism is solely related to left atrial dilatation with insufficient leaflet adaptation to that and growth. You will have central mitral regurgitation. I'll skip this two mechanism. So this is an example of a patient with atrial functional MR where you see the left ventricle contracts very well, it's small, but the left atrium here is quite dilated with tethering of the posterior leaflet, overriding of the anterior leaflet, and central to posteriorly directed MR. Recent consensus paper by Dr. Zogby and his colleague defined atrial functional MR as MR in the presence of normal leaflets, normal LV size and function, with the presence of mitral annular dilatation and left atrial enlargement. And they make a note of evidence of tethering, as you see in normal echo here. The mitral leaflets are concave toward the LV, but in MR, it's the opposite. This work I done during my fellowship studied atrial functional MR into different phenotypes. The outcomes for all group is bad. 40% is a mortality rate at 5 years. Worse if there's associated HFpEF and atrial fibrillation at the same time. Better outcome if it's only AFib with AFMR. So I'll finish here. Just overall, the mitral regurgitation is not a benign disease. It progresses with time, and LV will adapt to that by dilatation, worsening MR, and at one point, the LV ejection fraction will drop. It's important to try to catch the patient before there's adverse LV remodeling where treatment will be useful. Okay, so overall, MR is the most common valvular heart disease. Mitral valve prolapse is associated with, if associated with reduced EF and with moderate regurgitation, is associated with worst outcome. You should always consider early intervention in mitral valve prolapse before advanced LV remodeling. Functional MR accounts for more than half of MR. Optimal medical and device therapy is essential in the treatment of functional MR, and transcatheter mitral valve intervention is a promising technique to try to treat patients with symptomatic functional MR despite medical therapy. And thank you for listening. So ready for questions.
Thanks, Suzanne. Okay, we'll just look at the chat here. Is there any questions in the audience here? So you've kind of shown us that it's really important to know the anatomy, what's causing the mitral regurgitation that affects the outlook. So is this something we can get from transthoracic echo? Is this something that requires TEE? What's your feeling about that?
Yeah, I think transthoracic echo is very useful. It can give us a lot of information about the LV, about the left atrium, and about most of the mechanism of mitral regurgitation. I would only go to TEE if the mechanism is not really clear, if there is a concern about an intervention, either a surgery or a transcatheter approach. But transthoracic echo would be my first go tests, of course.
Yeah, and I think it's important we kind of demand that of our echo labs where you refer to your patients, that they come back, you know, they don't just give you the severity of the mitral regurgitation, but they tell you what the mechanism is or what they suspect the mechanism is. You know, sometimes obviously you can't figure it out, but where you know, often you can, and I think that's important that our echo labs are providing that data out to you. What about stress testing? Where does stress testing fit into the management?
Yeah. So as I showed in the natural history is whenever you have severe MR, you always want to find a reason to intervene because you don't want to go into advanced remodeling where intervention is not helpful. If patient remains asymptomatic and he has severe disease, stress testing like exercise echo would be useful to assess pulmonary hypertension, assess even the degree of mitral regurgitation. So in an asymptomatic patient where you think the LV is progressing, but not progressing enough to require a surgery, I think stress testing or any functional assessment is very useful.
I have one. We have so the classical indication for intervention or surgery is to wait for LV dysfunction, AFib, symptoms. But we have more and more evidence showing that if you wait, when you get that triggers for intervention, you have to pay a price, which is higher mortality. Where are we at with evidence regarding what we call prophylactic or early intervention for primary mitral regurgitation?
Yeah, so that's why I mean careful assessment and routine echo for this patient is very essential. So if you establish severe mitral regurgitation and patients remains asymptomatic, so the few things we look at is, as Dr. Mesiti mentioned, is there advanced remodeling manifested by low EF or dilatation with an LV in systolic more than 40 millimeter. So these two numbers are essential because we know if we intervene past these numbers, the outcomes intraoperatively and long-term is not good. So, but if the patient remains within the safe zone and prophylactic is not indicated as a class 2A or 2B, then exercise testing is important to push them, you know, one way or another.
Another important point is the probability of repair and the risk of surgery. If you have a very low risk and high risk of repair, I think it's reasonable to perform early intervention and prophylactic surgery. I think Munir agrees with that.
If you're an experienced center where the mortality is less than 1% and success rate is good, that's also another way to go.
Yeah, absolutely. I just want to echo that. I think although we look at populations in terms of how they behave over time, the decision is made at the patient level. And at the patient level, you are weighing those risks specific to the patient of intervention versus medical management. I had a question about this entity of atrial functional MR. It's relatively new, not something that was on our radar, 5, 7, 10 years ago, but it becoming much more cognizant of. You showed in your data that atrial functional MR appears to have better prognosis, I guess accounting for MR severity compared to other etiologies. So does that translate into your threshold for intervention in these patients, or are you using the same triggers for intervention in atrial functional MR versus, primary MR or ventricular?
Good question. Overall, the classical intervention is based on primary mitral valve regurgitation, which is mitral valve prolapse. Secondary, usually we tend not to intervene before the introduction of transcatheter options. So there are different, they will have dilated LV irrespective to the MR because of disease in the myocardium itself. So if someone with, let's say, ventricular functional MR who are in optimal medical therapy and despite that have severe MR and he's symptomatic, we favor transcatheter option compared to operative options. Atrial functional MR is a new entity. I don't think we have long-term studies on surgery. We usually tend to treat them medically. So we know that if you treat AFib, if you restore sinus rhythm, they do better, the MR get better. So intervention would be only offered, I think, on a transcatheter options basis, not surgical.
What is important is that we don't have the triggers for intervention because LV is normal and they have AFib, which used as a trigger for prolapse, but because it's the cause of the MR, we can use it. So I think it's a very relatively new area. I think with transcatheter options, it's a relatively easy and safe way to fix the problem. But maybe now we do clip. Maybe in the future when we'll have a transcatheter mitral annuloplasty that are easy to use and reliable, it may be the best option.
Thanks a lot, Dr.
Thanks, Hassan. Next speaker is Quan Chan. I don't think Quan needs an introduction. He's a guru of echo. He's our master. When you don't know something about echo, you go and say, oh, I've seen that one since 1975. And you can cite the papers. So thanks, Quan, for being here today. And your presentation is on tricuspid regurgitation. And we try to help you with the slides.
Slide, yeah.
Oh, that's good. You go from the next slide here, but you can see it here.
But the mouse doesn't move though.
If you
just do this. Okay, okay. It is a great pleasure for me to speak to you today because valvular disease has been my clinical and research interest for many, many years. Now, the title of my talk is The Tricuspid Valve Not Any More Forgotten. What this title means is that up till now, tricuspid valve has been forgotten. So what I'm going to gauge my talk is to try to tell you why the tricuspid valve has been forgotten for so long and only receive attention now. And maybe talk to you a little bit about how common this condition is. And I think I'm going to repeat some of the slides that Dr. Messica has shown, but it's important to repeat the important messages. And maybe talk to you about the significance of tricuspid regurgitation. Why should we bother? And finally, maybe end on what we can do about it. So why have we forgotten tricuspid valve until now? And I think the best case is just to illustrate it by a case of my own. This is a 73-year-old man. He had aortic valve replacement for AS 3 years ago and had a pacemaker put in because not uncommonly, when you do aortic valve surgery, it can be complicated by complete heart block. Of course, related to the intricate relationship of the conducting system to the aortic valve. And he's doing very well. 73 years old, follow him, no complaints. He just say, well, I'm getting older, I'm slowing down, right? No complaints. And this is a surveillance echo. How come my echo doesn't run? Oh, yeah. And you can see that this routine echo in someone who's doing well, following aortic valve replacement and a pacemaker insertion, he indeed has torrential tricuspid regurgitation, and yet he has no complaints. So this case illustrates the difficulty of recognition of TR, not only by physicians, but by the patient. It's not forgotten is forgotten for a very valid reason. So, tricuspid regurgitation, it is hidden in plain view. We just don't recognize it. Why do we not recognize it? Think about it. What are the symptoms of tricuspid regurgitation? Can we name some? You say, well, peripheral edema, ascites. Those are very late signs. By then, it's way too late, right? And what are the clinical findings? What are the clinical findings? How comfortable are you in looking at the JVP? And how common are you in detecting the murmur of tricuspid regurgitation? I'll submit to you that in severe tricuspid regurgitation, the murmur actually is silent. Why? Because the right atrium and right ventricle is a common chamber. They're very little pressure differential. So severe TR is silent. That is why it's so difficult. And also, as my case illustrated, many times, in over 90% of the time, tricuspid regurgitation is secondary to left heart disease. And we all know left heart disease. You heard about mitral regurgitation already. The features, the findings of the patient is dominated generally by left heart disease. So we don't think of the right heart. We don't think of tricuspid regurgitation. And to make matter worse, the symptom of TR is very non-specific. In fact, I will submit to you the most common symptom that you should watch out for is dyspnea. Now, I will let you think about it. Why should severe TR present dyspnea? That is the most common symptom. And clinical findings, very subtle, very, very subtle. So you really have to be looking for it, thinking about it. So that is why it's forgotten for so long, because we didn't appreciate it, the patient didn't appreciate it, and over 90% of the time is dominated by left heart disease, just as my patient demonstrated. So very, very important. So you have to be thinking about it, you have to be looking for it. Now, maybe just a quick word about two new concepts. And one is that there's this new idea about classifying the tricuspid valve. And this classification basically break the tricuspid valve into bileaflet, trileaflet, quadricuspid, and even 5 cusps. My point is, this is a functional classification. It's not exactly an anatomic classification, but you see that. I bring it up so that you are aware of the classification. When someone talks to you about 3B, you know what it is. But I will emphasize, this is not an anatomical classification. In the vast majority of cases, the tricuspid valve is trileaflet, right? This is a functional classification. Very important, right? But you'll hear about that. And the second new concept I want to impart on you that the grading of tricuspid regurgitation now is getting to be a little bit more complex. They are going to be grading beyond severe. And such as the patient I show you, the tricuspid valve hardly touch each other. When you listen to the patient, there's no murmur because it's a common chamber, right? The right atrium, right ventricle is common chamber. It will be silent. So therefore, this now is getting traction in literature. Beyond severe, we now call massive, and then there's a torrential. And I think that the only thing to remember would be the effective regurgitation office area is listed here. If it go beyond 0.4 centimeters square, you get severe. Beyond 0.6 centimeters square, you go to massive. Beyond 0.8, the hardly touch is torrential. So just so that you are aware, when we in the echo report that you receive from us now, when we say torrential, you know what it means. It doesn't mean that we're just impressed by it, because there's now a new gray, right? So when you see our report, when you say massive, beware. When you say torrential, get off your chair. Now, this slide you already seen, right? Dr. Messinger showed it. What this is the Mayo Clinic study showing that TR actually, significant TR defined by at least moderate severity is quite common. As we get older, it's common. So you have to be thinking of it. You'll be watching for it. You say, well, how about in people with left heart disease? And I just picked one slide to show you, right? You look at this patient mainly with with mitral disease or aortic disease, look at how frequently in people with left heart disease that you see moderate or severe TR. It goes anywhere from, from 10% to 20% to 25%. So when you have patient with left heart disease, be it aortic stenosis, be it mitral regurgitation, think tricuspid regurgitation. Very, very important. I already said it's a disease that's tough to detect both by the patient and by yourself. You don't think of it, you'll miss it. And what's the impact of it? Why should we care? Well, you may already seen the slide. This shows that if you have heart failure, your prognosis is worse if you have TR. Right? Very, very important. So TR not only is a bystander, but appear to add to the risk of the patient. Right? So very, very important. People with left heart disease always think the impact on the right side and on tricuspid regurgitation. And you heard a lot about atrial fibrillation. I think this is a reasonable, interesting study from Mayo Clinic. They look at people with new onset atrial fibrillation that are doing quite well. And now, being Mayo Clinic, be careful, it's all retrospective, right? But nonetheless, they have large database. You have, when you look at a paper, you have to think about it, look at the design, very, very important. So they look at these patients and they look back, and those who have been followed for some time, hey, for atrial fibrillation, new onset, you follow them, they will develop TR, significant TR. 1/3 of them will be isolated, 2/3 of them may be related to development left heart disease. So now again, raising issue, not only do you have to worry about TR in people with left heart disease, if you're a patient who developed new onset AFib, you have to think about TR as well. Very, very important, right? But the other message is also in people who develop AF, you also have to think that this may be a harbinger for left heart disease, right? So you have to follow those patients, think about left heart disease, think about the emergency of tricuspid regurgitation. Well, the impact of tricuspid regurgitation may be more severe than you think. Again, this is a Mayo Clinic study, right? A very large number. And I'll remind you that this is retrospective, very large number, 13,000. And the important point I want to drive to you is that in a median follow-up of 6.5 years, but look at the 5-year mortality. This is all cause, right? So this is now secondary TR and primary TR, all lumped together, all undifferentiated TR, so to speak. So you have moderate TR. What's your 5-year mortality? 53%. Worse than any cancer that you can think of. If you have moderate to severe TR, 63% at 5-year mortality. And you have severe TR, 71% mortality. Now remember, this undifferentiated TR. So remember what I said already, the vast majority, 90% of them are likely with left heart disease, meaning that the left heart disease may drive the prognosis, right? But what are the risk factors? And they look at it. Now the risk factors are age, male sex, renal dysfunction, heart failure, lung disease, liver disease, tachycardia relatively, and the severity of TR. Now remember those risk factors because we'll come back to it. These risk factors are actually quite important. I remember that. And we'll come back to it in another study that we're going to look at. Well, how do we treat it? This is you all should know about this now, the ACC/AHA guideline, right? The guideline is very clear cut. If you have primary TR, are you trying to tell me that my time's up?
No.
When you have primary TR and symptomatic, obviously grade 1, and then of course when you go to left heart disease surgery, you have significant TR. You should also have something done to the tricuspid valve too. So the indication for intervention is quite clear, right? But you already seen this, and I'll show this to you again. And yet, look at how frequently is tricuspid valve surgery done. In 2004, how many have been done? 300. 300 tricuspid valve, isolated tricuspid valve surgery done in the US. In 2013, you say, well, this how many? 800. In a big country, US, where they are very interventional, right? You come to Mayo Clinic for question of mitral valve disease, you get surgery. I'm telling you. And yet, for isolated TR, in 2013, only 800 were done in the US. What does that tell you? That tells you A, is not being understood. B, is that people are hesitant to do isolated TR. Why? Look at what the mortality is. Over the same period of 10 years, the mortality remained 8.8%. It's very high risk surgery because routine bypass surgery, what are our mortality? 1% less. And yet you do isolated TR surgery, almost 10%. That explains why surgeons are hesitant to do tricuspid valve procedure. And this is again collaborated by this meta-analysis, looking at tricuspid valve replacement and tricuspid valve repair. Now, what we can see is that both in repair or surgery, the mortality is high. Although the mortality is a bit better repair, but still high, right? And you look at lay mortality, even with repair, is 13%. And with replacement, 17%. This is high risk surgery. Why is that the case? Why is that the case? And I think, why is that the case? This illustrated. This is a collaborative study done in France, and actually is a paper by our chair here, Dr. Messica. So they look at 466 isolated tricuspid valve surgery, and look at how high the risk is, the surgical risk. The surgical risk is very high, but they also break it down to say, what are the risk factors? Interestingly, it's the same risk factor, very similar risk factor as reported by the Mayo Clinic. What are they talking about? Age, heart failure, right-sided failure, right? Increased dose of LASIK use, right? And liver failure, right? Illustrated by elevated bilirubin. Very similar risk factors. And the important thing I want to draw your attention to is that if you have the risk score of 6, your operative mortality is only 22%. You go beyond that, the operative risk is astronomical. What does that tell you? It tells you that we are intervening too late. We're recognizing the TR too late. You wait until the patient develops liver failure. By then, the ship has gone. The ship has gone. So can we do better? Can we do better? I already tell you that surgery is high risk, right? Partly driven by the fact that we don't appreciate the condition well. But the other thing that drives what we do now is that could we do simpler procedure, maybe lower risk procedure that would be more suitable? And there are now an explosion of different percutaneous procedures, and I listed many of them here. Many of them here. Some target the annulus. Remember what the talk about mitral regurgitation? The different aspect that give you tricuspid mitral regurgitation apply in the tricuspid regurgitation. So you think about the annulus, you think about the leaflet, you think about the subvalvular structure, you think about the ventricle, right? So all these different technologies are targeted to different aspects of the tricuspid apparatus. How good are these? So I'm showing you, this is again a meta-analysis of 771 patients. Now this is largely mitral tricuspid valve clip, but some are the other technology. So it's really kind of heterogeneous group, but nonetheless, it shows that percutaneous intervention largely is reasonably safe. It generally can reduce tricuspid regurgitation. It doesn't take away all tricuspid regurgitation, but generally reduce the tricuspid regurgitation to some degree, and generally lead to improvement in patients' well-being. Now, this meta-analysis is now supported by the randomized study, the TRILUMINATE study that some of you may know about. which show almost the same thing, that it improves patient well-being, but does not change mortality or repeat hospitalization for heart failure, right? It's interesting, interesting. So let me leave you with the final words. Tricuspid valve, no, not anymore forgotten. I'm not so sure. I think we still don't take tricuspid regurgitation serious enough. I think the key is that one need to know the limitation of clinical examination, right? The key is think about it. Proper use of imaging, very, very important. And know that tricuspid regurgitation is very common in the setting of any left heart disease or atrial fibrillation, right? And also recognize that tricuspid regurgitation is not just an innocent bystander. It's not benign. It actually adds to the risk, right? Unfortunately, tricuspid valve, isolated tricuspid valve surgery remains underutilized and high risk. And I think we need to keep an open mind about percutaneous procedures. It shows some promise. It's still evolving. We should think about it. It's an option. Whether that is our final answer, I'm not quite sure yet. But the most important thing is that, remember, early detection is the key, and early referral is the key. Thank you for your attention.
Thank you very much, Kohan. Any question from the audience? Yes.
Thank you. So if it's too late, whenever they're showing signs of heart failure, when is the optimal window to refer to surgery or intervention? And how closely should we be following severe asymptomatic isolated TR?
Excellent question. I would think that if the RV becomes severely dysfunctional and you develop ascites or you develop significant liver hepatic failure, it's too late. There's no doubt about that. I think both the study that done by Dr. Messica and the Mayo Clinic retrospective study confirmed that. So in people with severe TR, I would think that I generally follow them every 6 months. And the problem is that there's no really, I think if there's left heart disease, it's quite clear that you want to optimize the treatment of left heart, which would impact on the tricuspid regurgitation. But in isolated TR, particularly in people with atrial fibrillation, I think the tendency now is that I try to establish rhythm control early. I am now considering ablation more early on, because I know the AF left untreated, the TR will get worse with time. And so think about intervention early. And I already tell you that in our center, we are doing tricuspid valve clips. So in the suitable patient, so that's something also to consider. So I would say early recognition, early referral, and I would follow them closely. But if you wait until they develop peripheral edema, ascites, hepatic failure, that I think is too late.
You have a question?
Thanks a lot, Kwan. So following these, back to the mic.
You said you thanked me already. That generally means
thank you for the talk.
Done. Yeah.
So tell me your follow-up of these patients. Echo, MRI, like the assessment of the RV is so challenging, by echo. I think it's also challenging by MRI. What do you use to follow your patients with severe TR?
That's a excellent question. RV is a complex, structure, because it is really not like the LV, just kind of a conical shape. What I do, I think, is that echo is still my basic screening tool, but if I concern about really my judgment of the RV volume and size, then I probably will go for MRI. But I think for most cases, until and unless the RV become significantly impaired, echo probably does a pretty good job, I would think.
I have one or two. One of the issue with the clip is that you mentioned that we decrease the degree of TR, but we don't correct it completely compared to surgery. We may have in the future transcatheter valve replacement that will be completely fix the TR. And my question is that if you have a patient at low TRI-score with a severe isolated TR, what will be your primary approach? To send the patient to surgery or to try a clip?
That is a very difficult clinical question, and I've done both. I think in young patient who's otherwise well, and I want to be sure that I get rid of the TR, I probably would send a person for surgery and asking for tricuspid valve replacement rather than a tricuspid valve repair. That's my own feeling, and nowadays I'll probably ask them to put in a prosthetic valve. And if the prosthetic valve degenerates, we can do a valve in valve. So I'm thinking down the road. So in a young patient, otherwise good risk, that's what probably I would do. Because I think the way that the percutaneous procedure is done, we seldom abolish the TR. We just reduce the TR. You look at the paper critically, right? If you go from torrential to severe, it's classified as a major success. But as we already said, severe TR is not benign, and it will progress. So it's a kind of difficult clinical judgment call.
So Quan, a question from the chat. So the outlook is, is sometimes grim with surgery, intervening when it's severe TR. Questions come in from the chat. Should we maybe start intervening on moderate TR, intervene even earlier?
Well, I think if you're talking about the setting is important. If you're talking about moderate TR in the setting of left heart disease, I would say the emphasis is still optimally treating left heart disease. In isolated moderate TR, it's generally well tolerated. So I probably will wait. I would kind of observe them. If it progressed, then I will intervene. So for moderate TR, I would not recommend intervening at this stage because we have no perfect tools.
Thanks a lot.
Thanks, sir.
So it's my pleasure to introduce the next speaker, Dr. Vincent Chan. Dr. Chan is a cardiac surgeon here at the University of Ottawa Heart Institute and a professor of medicine at the University of Ottawa. He's an expert in mitral valve repair, both surgical repair as well as transcatheter edge-to-edge repairs. And he's been tasked this morning with addressing the topic, new developments in mitral and tricuspid valve interventions. Vince? Excellent.
And Vincent is
Enable the camera. Look, share, go here. So probably select from your. Which one? Yours. Okay. And turn on the camera.
Okay. Thank you so much. Yeah. All right, listen, thanks everyone for having me here. Thanks so much for all the IT support and Ian for the introduction. Over the next little while, I'm going to discuss a little bit of what's happening in the Heart Institute. There's a lot of pictures, a surgeon's talk, so there's a lot of photos and pictures to make it real simple. There's so much happening in the transcatheter and innovation space in the terms of management of valvular heart disease. But I won't go into all of that here. I think Omar Abdelraza gave a fantastic grand round the other day that really encapsulated this. So, when we talk about intervening,
what's the slide here and you look at here.
Okay, I see. Okay. Is it running?
No, it's not running on the screen. No, it's just a tip.
Yeah, for whatever reason, it's not advancing. Okay, so go down. Okay, there you go. So basically, when we look at risk of results, this is actually published from the STS database approximately 4 or 5 years ago, and this was about 1,000 hospitals that contributed to the STS. When we look at mortality from surgery, we can see that anything involving the mitral valve is jacked up in terms of risk. There's a little more bad stuff that can happen with mitral valve disease. So certainly catheter-based procedures that address atrial ventricular valve dysfunction is something that may be useful. So when we look at percutaneous approaches, what we have most commonly is transcatheter edge-to-edge repairs. We have the MitraClip is the dominant device. Edwards has the Pascal device, which is presently available, although there's a worldwide shortage of manufacturers for that device, so it hasn't been as widely implemented in Canada yet. And there are basically 4 different sizes for the MitraClip. You have the NT, you have the XT, and they have different widths and lengths that allow you to kind of get to where you need to go. So when we look at the MitraClip procedure, this is usually done through a femoral venous puncture. A catheter is placed up into the right atrium. There's a transeptal that's performed. Then you position this clip that kind of goes and grabs the anterior and posterior leaflets of the mitral valve in a position that confers stability. And this was based off the surgical principle from Ottavio Alfieri, who found out that you can sew the anterior and posterior leaflets together to get stability. And the idea from this came, in the afternoon case where the morning case he had a congenital connection between the anterior and posterior leaflets. So in the afternoon, he was struggling with this surgical mitral and decided to copy what God had done. So this is the transcatheter edge-to-edge device, the MitraClip device. What you can see here is you can see the steerable guide, which is the bulky thing to your left, and through the steerable guide, you place a clip. When we look at the tip of the clip, what we see is that there are these metal tines called grippers, and what happens is that you try to engage the mitral valve leaflets, and you basically want to sandwich the clip with the grippers. And then once you're able to grab it, then you drop the grippers, engage the leaflets, close the clip, and then you confer stability. And this is Gen 4 of the device. What you have here is you can have now independent grippers, more innovation that has happened in the space. The next generation, or Gen 5, is probably going to be available in the next dozen to 18 months. Again, there's 4 different sizes. You have the NT, you have the XT, you have different widths with this. You have different length measurements depending on whether or not you're open to 120, 180, and all these numbers we use to kind of guide as to what kind of clip we want to use. You can envision that if you have a larger clip, it's easier to grab. So an XT is really easy, but it's also tricky because you want to get all of the leaflet tissue into the frictional element. So sometimes your grab may look good, but it may not hold with an XT. So in general, we'll try to line up the putt to use an NT if we can. But if you have redundant leaflets, as in a case of degenerative disease where you have over about a dozen millimeters in length, then an XT may not be a bad option. So I thought I'd go through a couple of the cases that you kind of look for. So, this is not a very atypical case. Let's say the 84-year-old individual referred from Dr. Burwash, Dr. Masika's clinic. They have severe MR, some symptoms. They're a little bit older, so their kidneys aren't 100%. A little bit older, maybe they don't like eating 3 square meals a day, so they're a little bit lighter in terms of weight. So you think through the different options. You treat them with pills, you treat them by cutting them open, do you use a catheter-based procedure? So I won't go through all the echo images here because we have experts in the room that can read this, but certainly the leaflets look very redundant. Certainly a wide area of prolapse involving the posterior leaflet. And in the hybrid or cath lab, what happens is you do the transeptal puncture, so you drop down on the septum with a nice bend on the Baylis needle, and then using an in and out view via echo, you want to make sure you're not too inferior. You don't want to be super in the inferior third of the septum, and you want to make sure that you're quite posterior without going through the interatrial septum and then into the pericardium. Once you are across the interatrial septum, a balloon septostomy is performed. Usually we use a 6 millimeter balloon, and then we feed that cerebral guide. That's a 34 French catheter. So certainly it's a little bit big. And then once you get in, you steer down to the valve. We go more medial, and you just want to engage the mitral valve leaflets where you can, where there's a good grab where the leak is. And then you grab it, and then you grade it. You then deploy the valve, and you see if you have any leaks. Sometimes having the action of the clip still attached to the guide confers some stability, and the leak may look a little better with that. This is a different kind of patient, a little bit younger, 57. In this individual, there was a history of AFib, acute CHF requiring mechanical ventilatory support. There was some question about medical compliance. They had severe MR. The LV is not awesome. So when we have a patient like this, we always talk about what are the heart failure options. With the issue of medical compliance, maybe transplant, LVAD is less part of the decision tree. They have significant MR. What do you do with this? Well, a clip may not be a bad way to round the corner. Where you go in, you can lower the degree of MR, maybe you increase forward cardiac output. These are usually a little bit smaller in terms of the MVA, so you want to be mindful of the gradients across the valve as well. So when we look at what has happened in the United States, this was published in JACC a couple of years ago, is that because of the Everest 2 data, CMS really funded CLIP for degenerative MR. When you want to look at it, really, it was purely for the treatment of degenerative disease. But in Canada, the opposite happened, where 9 out of 10 or 8.5 out of 10 patients that came from MitraClip were more of functional etiology than degenerative. But certainly there's been a lot of research and innovation in this field trying to figure out which types of patients should be treated with either strategy. So there's 2 trials that are underway. Both of them actually are run here. One of them is run by Abbott. This is the Repair MR trial. This is a trial with Saibal Kar and Pat McCarthy as lead PIs, multi-center study looking at dialing down the risk of who gets a clip with degenerative disease. So, an STS predicted risk of mortality of more than 2% is actually in the 90th centile for risk of mitral valve repair. So these patients will actually be qualified as being intermediate risk, and there's a composite primary outcome we're presently enrolling as per Repair MR. There's a separate trial which we are also part of here called Primary. This is run through this Cardiothoracic Surgical Trials Network, and again, this is a multi-center trial. It's a little bit different from Repair MR in the sense that we have allowed enrollment of patients across the risk spectrum. So if you're over 65 years of age, even if you're low risk, you might be able to be part of the study. Now, this is really tricky. As a surgeon trying to get surgeons to enroll in this trial, the conversations on the phone are usually very brief. But what I would say is that if you look at what's happening outside of Canada or the United States, this is happening in Germany. So you have low-risk patients in Germany coming in, they're shunted towards a CLIP strategy. So with the international enrollment, it may be such that we can have a regional representation where perhaps more of the lower intermediate risk patients may come from Europe, and then less so from Canada and the United States. This is a summary pivoting now to TMVR, and this was written up in JACC now a lifetime ago, 6 years ago in catheter valve disease. And I like this image because it frames different kinds of tech in which TMVR can happen. You can have a transcatheter mitral replacement with an apical tether that could be annular winglets. You can find a way to engage the mitral valve leaflets. You can envision having a device where there's extensive radial forces that actually push against the AV groove in order to confer seal. You have also mitral annulus clamping, and then the concept of external anchors. Now, the bottom left one with mitral annulus clamping, it's not widely known, but certainly the devices that have employed this technology had lent to high incidence of AV groove aneurysms. So in fact, that tech is actually less done. It's more used now for perhaps management of right-sided AV valve disease, i.e. tricuspid valve disease, with the thought that the pressures on the right side are lower and it would be safer, but all of this is unknown. But I like this image because 7 years have happened, and really, it's not as if all of these devices have now been commercially available, they've Health Canada approved, where there's a ton of data to show that it's actually beneficial. I'm going to focus really on one device, and this is a device that has the best results in the world, and actually one that we've implanted here. This is the Tendyne device. It's a tri-leaflet porcine pericardial valve, good MVA. This is a massive valve. It goes through a 34 French delivery system, apical incision over an 035 wire. You know, when you look at the outer frame, the septolateral and inner commissural dimension, I mean, it's a good size thing that you're putting in the AV groove. This is a trial that has come with the Tendyne device. It's a SUMMIT trial run by Abbott. And it's a little bit of a busy slide. I basically took this from the Abbott website, but what it involves that you have a patient with severe symptomatic MR that you think would be a candidate. They have to be a candidate for both clip and Tendyne, and then you randomize them 1-to-1. So it's a bit tricky because then, you know, a lot of centers that do clip like the notion of clip and they feel that clip's safer. Now they have to basically qualify for both to be able to be randomized. There was a separate MAC arm, which actually has finished enrollment, where if you have severe MAC and you didn't think they can be a clip candidate, but you really like the notion of Tendyne, then you could actually go into that arm. Now, the tricky piece with this is with all catheter devices is that the anatomic review is key. The LVOT obstruction is insignificant. Certainly leaflet calcification is tricky as well. But early data with the use of Tendyne and MAC is actually quite interesting, and there's a composite endpoint for that trial. The Tendyne device, the initial publication for the global feasibility study had about 100 patients, and a couple of years ago they followed those 100 patients out, and about half of those had 2-year follow-up. And based on the selection cohort from their early feasibility study, that they estimated mortality at about 1 year was about 27% in this cohort. That went up to about 42% at 2 years. But when you look at the number of hospitalizations that happened before they got this thing and then after this thing, they did better after this thing. Pivoting quickly to tricuspid valve intervention, Juan, I heard him just briefly talking about TIRA. I'm going to again go back to another patient that we have managed. It was a patient actually that was referred from out east. 2017 had a permanent pacer lead for tachybrady syndrome. They're symptomatic class 2-3 heart failure on Lasix, still significant right heart valve symptoms, a little frail with low BMI and iron deficiency anemia. There's a pretty big gap in the tricuspid valve. So this is something where I'm going to go through a couple slides of this, but it's tough with TIRA in this context. But what would you estimate this risk? So there's not a lot of tricuspid valve surgery that happens in the STS registry. A lot of this is due to the fact that people don't know how to manage it. Patients were referred late. So the ones that actually do get cut open, they don't do awesome. You know, there's about a 2 to 10% mortality risk, depending on what risk calculator you want to use. So certainly there's impetus for using a catheter-based option. And Becky Han, who's going to be giving rounds here shortly, had this paper where now you're parsing mild, moderate, severe TR, but then you want to look at the very gross end of TR, which I'm sure Juan discussed. Now you have massive, you have torrential TR. And the whole point is that can you make things better by 1 grade, right? Can you make torrential down to massive? Can you make massive down to severe? So these are the kinds of things that are happening in the TIR space. So the Triluminate trial is the dominant trial that was published recently, basically looking at managing patients with TR randomized to transcatheter edge-edge repair in the tricuspid position with medical therapy. There was a hierarchical primary endpoint and then a variety of other secondary outcomes. And the important thing was that there were anatomic criteria for who got enrolled in Triluminate. Now it's tricky because if you look at the what's published in the clinicaltrials.gov, the leaflet anatomy says that if the gap is up to 2 centimeters, maybe they'll swing at that pitch. In truth, when you look at the trial, the gap really was not as wide as that. But certainly one can envision a good result. There's no transeptal involved, still right femoral venous puncture, position the tri-clip guide up towards the SVC, and then you steer down the tricuspid valve. The goal is to try to grab the anterior and septal leaflets, and then you grab laterally, and then you march centrally. So then what ends up happening is that if you can zipper A to S, then what you may have is most of the coaptation is really just this tiny posterior leaflet that kind of goes. Now, that being said, there are some centers that will take different grabs where they'll try to grab the posterior and septal leaflets together. But certainly it's a bit tricky because sometimes it's hard to get out towards the commissure. Tricuspid valve towards the commissure is more cord rich than the mitral valve. The analogy that we use is that you imagine trying to play a round of golf with only 1 club. So this is what can happen. But certainly with transcatheter edge to edge and certainly with supportive industry, results can be quite good. This is data from the Trilumina. This is the New England paper that came out last month. So if you look at the hierarchical composite endpoint of death from any cause, tricuspid valve surgery, hospitalization for heart failure improvement, more than or equal to 15 points in the KCCQ score at 1 year, that the TIER group certainly did much better than the control group. Now, that being said, if you look at the data, most of this is driven really by the improvement in the KCCQ score. So that's something to consider. So those are kind of the broad transcatheter approaches that we have that are available at the Heart Institute. As a surgeon, I'm going to talk a little bit about the surgical piece. We certainly do have an MIS program where we'll do operations through right mini thoracotomy. If we have complex valve disease or multi-valve disease, we can still get away with a pretty small midline sternotomy. So this is a case that we did a few years ago as a young lady that basically came in with severe symptoms of heart failure. You can see here on echo is a huge anodilation. I don't even need to get the calipers out. The annulus is pretty big. There's bilethal prolapse largely because of the anodilation. Turns out there's going to be some stuff that maybe is a medial commissure. This is we do this operation with a 30-degree scope, and this kind of helps facilitate some of our exposure. You saw the aortic cross-clamp going on here to kind of see the mitral valve. Sometimes we'll put sutures within the body of the left atrium just as a form of retraction. And then we start by pulling the leaflets towards the center of the valve, and then putting sutures, Ethibond sutures, in the annulus of the mitral valve. And we try to go from trigone to trigone, and then the annuloplasty system will go from there. So hopefully I can jog through this. Surgery is always more interesting for the person doing it than the person watching it. Yeah, so I put a lot of sutures in here, and then we tied this thing, and then basically the final result is something like this. So this was actually a photo that this patient's mother sent me. It was a small incision. You can see here some of the bullet holes you see on the side. You have where we have the cross clamp that goes really just in the axillary area. There's a kind of a vampire bite up in the neck where we put a small IJ cannula to get on the heart-lung machine. Now, we don't actually do that as much now, just because usually a femoral venous line's pretty good. If they're a little bit big, then sometimes what we'll do is that we'll now put a small 24 French cannula through the chest like a chest tube, and then we save about 30 minutes of time for that extra line. We used to do double lumen ventilation. Now we're moving away from that. We just make the thoracotomy incision, open the groin, heparinize, and then we get on with the day. So including thoughts, I think that when we look at new technologies for valve disease, what really is important is working with others. These things are really difficult in terms of just deciding who gets the stuff. And then once you're in it, you want to climb the mountain with people that can kind of show you what you need to do and to help you actually traverse these difficult things. So less invasive surgical options are also evolving in patients with mitral valve disease. Percutaneous technology is improving, and no doubt percutaneous therapy will have an expanding role with time. So really appreciate you bearing with me being late, IT issues, and your attention today.
Thanks a lot, Vince. Maybe I'll just ask the first question. So, I mean, I've definitely been impressed with the results that we've been getting with the mitral valve clips in primary disease. And like, are we at a point now, like you would consider doing that in, a 40-year-old who, let's say had a nice just P2 prolapse, obviously it's going to get a great surgical repair, but who wants their chest cut open?
Yeah.
What's your thoughts on that? How are you handling that in your discussions?
That's a fantastic question. I do think a lot of patients are more informed. They're asking for these things. Now, my bias, and you tell me, I'm like, you, David, Kwan, have a lot of experience in this, but my sense is that when patients come in that are that young with degenerative disease, it's not always just P2. It's always like P2 plus, right? There's more excess tissue. The annulus is a little bit dilated. There's going to be other areas that are going to be less supported. So I think those things kind of factor into the discussion that happens even at our structural rounds, right? So like to your point, you want to get A+ out of this thing. There are certain widths to the clip. So it's not as if say you had a very wide P2, P1, and P3 are normal, and then you just grab everything, bring it to the anterior leaflet, that it's not as if that would always work. So I do think that to answer your question, that you want the best result, maybe this one tech won't get you everywhere you need to go. Certainly the data is evolving. But, you know, when I see trials, you know, if you look at TEER and you look at surgery, like even if it ends up being similar, or even if surgery is a little bit better, like the one thing I would go back to is that which patients are you taking? So I do think that the anatomic screen is really critical, deciding which step is the one that you would move forward with.
And related to that, so you mentioned the 2 trials that are ongoing, patient more than 65 years old. I think for primary MR, what is important is to correct and have no residual MR. How do you do that? It's more a technical aspect. But on the trial, you need to have centers that are very good in both. So when you send a patient for surgery, you want to be sure that he will get a repair. And when you send a clip, that you will leave the operating room with 1+ or less. In all those trials, how the centers have been selected, but if you have a bias that you have clip centers and low surgical centers, you will get benefit from the clip and vice versa.
Yeah, that's a really tough one. I mean, you know, I certainly think that enrolling in these trials is really critical. I think at the steering committee level, that's going to be the dominant thing. I like what you said at the very beginning about how it's about correcting the valve disease. And I actually really believe that. I think whether or not you go catheter-based procedure or surgery, the ultimate best way forward is the one that gets the best echo at whatever time point. And I think that's the thing that should drive how we move forward with anything that we do. So, you know, I think that with TEER or other transcatheter devices, you want to make sure you get good quality. You also want to, you know, make sure you do right by people if you're doing the surgery, especially since the upfront investment by the patient is a lot more. But I certainly like the way you frame that.
I have another one regarding tricuspid regurgitation. Do you think the clip is the way to go, or you would go to a replacement?
It's a safe procedure. I'm not sure if that's the device that's going to get you to where you need to go. Like, you know, there's a question earlier about, do you intervene in moderate disease? I mean, the tricky thing is that once you have severe MR, the AV groups have been dilated, the annulus has been dilated, the RV, depending on what it's like, depending on how early they get referred to your clinic, may not be perfect. So using TEER in that setting, I feel will have its limitations. The leaflets are not super strong. You know, even if you get good bites out of this thing, you can put tension on the leaflet tissue. But who knows? Like if you get better primary care, better tertiary care, and you can intervene on patients earlier, then maybe TEER would be good. I do think that the kinds of patients that are around now, kicking around now, severe RV dysfunction, pulmonary hypertension, dilated annulus, torrential, more than torrential TR, you know, it's difficult to envision that a tricuspid edge-edge repair would get you to where you need to go in terms of complete TR resolution. And a TMVR strategy is attractive. But again, this could be a long thing about everything that's happening with TMVR, because not all of it is great, but certainly people are trying.
At the same time, if you just do replacement of patients that are in stage disease, you might kill the technology. So we have some people from industry. If you want to have a good result with replacement, you need also to have the good patients.
100%.
If you have ascites, you can do whatever you want.
Yeah, it's never good.
Vince, can you just give us a comment about, so if the clip's done and the clip fails, like what your chance then of a surgical repair after that? Can you know, where you're kind of got these people, you know, I don't know which way to go. Oh, I'll do the clip first, but then if it fails, what's your chance with a repair?
Yes. So for both, you know, I think tricuspid, it's once you put multiple clips in place, like it'll be a tissue tricuspid valve, like that'll be what it is. In the mitral position, there's not a lot of cases that have failed here post-clip. We repaired one patient that had a clip that was done early. There's a lot of fibrosis that happens. You know, I showed that picture with the tines, you have all this polyester. There's a lot of fibrosis that happens. And I think that if you want to repair a mitral valve after a clip has gone in, you basically need to use sharp dissection, take everything out, but you may not have a lot of leaflet tissue left. The only one that I was able to repair was within the first week, and I was able to actually undo the lock mechanism and open the clip, and then repair a little bit of the free margin. But that's only if you have an early failure. I think uniformly you're getting a tissue valve.
Maybe what we'll do is we'll stop here. Thanks a lot, Vince. We'll stop for a little nutrition break. We'll maybe kind of shorten it down to 10 minutes to kind of get us back onto schedule. Make sure that you fill out your evaluations in the event guide to give us feedback. So for further symposiums, but we'll meet back at 11:10.
Perfect. Thanks, everyone. Good morning, and thank you, David, for that kind introduction. It's a pleasure to spend a few minutes with all of you talking about aortic valve repair. I have no financial conflicts of interest to disclose. My only conflict of interest, I suppose, is that I am an advocate for aortic valve repair. So I'll present sort of my perspective on where the field is at today. The first comment I would make is that aortic valve repair is now 3 decades old. You know, if you imagine when the story sort of began, it was in the early 1990s that pioneers in aortic and aortic valve surgery embarked on this idea that aortic valve could actually be repaired. We'll talk today a little bit about how that story has evolved from preserving the valve to actually repairing regurgitant valves. We'll talk a little bit about why we want to repair aortic valves and some of the current challenges and opportunities. So the story began really with a patient like this. This is a 26-year-old patient with Marfan syndrome, has an aortic root aneurysm. That's the primary reason why they need surgery, because they have a risk of aortic dissection and complications from that. But they have essentially a normal looking valve. The valve is not leaking, it's not stenotic. And if you turn the clock back to before aortic valve preserving surgery came about, the typical operation this patient would get is a mechanical valved conduit. So something that would replace both the valve and the aorta, even though the valve was functioning perfectly fine. And if you look at the outcomes with that kind of an operation over the long term, particularly in a young patient, we think of valve-related complications of thromboembolism, 1 to 2% per patient year, major bleeding, 1 to 2% per patient year, and endocarditis, 0.3% per patient year. And so what that implies for this 26-year-old male patient is that in 5 years, they're probably going to have anywhere between 12 to 20% risk of one of these bad things happening. If you go 10 years, 15 years, 20 years, which is, you know, that's when this patient would be 46 years old, there's a substantial probability that they would have some sort of adverse event related to having treatment of their aneurysm. This is also a study which was published in the early 2000s, but using data from the 1990s, from that era, that suggested that if you look at the middle curve, patients who are between 18 to 70 years old having a mechanical prosthesis, this is from one of the Scandinavian countries where they followed all patients with mechanical valves, that there's a steady attrition in terms of mortality for these relatively young patient population. And so there was this clear unmet need to say, you know, you're going to fix one problem, but if you replace it with a prosthetic mechanical valve, you're actually burdening the patient with another type of disease. And it's in this environment that valve sparing operations first came about. And there are 2 schools of thought that emerged. One is what's called on the left, the reimplantation procedure, the idea that you can replace the aorta with a Dacron graft while preserving the valve, but anchoring this graft to a region below the valve. So that's one distinction with the reimplantation technique. On the other end, there is this remodeling technique, which means you stay above the level of the valve and you kind of follow the curved shape of the aortic annulus to replace the aortic root, leaving behind a well-functioning aortic valve. And these were coined respectively by the pioneers that kind of came up with these concepts, Dr. David in Toronto, Dr. Yacoub in Britain. I'm going to take you through how we manage this type of problem. So this is that patient with 26-year-old Marfan syndrome. And you look at the valve looks actually pretty healthy. There are 3 leaflets to this aortic valve, which coap reasonably well. I'm going to run through some portions of this procedure to give you a sense of, I hope I can navigate through this. But the idea here is that we're going to be separating the aortic root from the surrounding structures of the heart, and being basically allowing us to access the entirety of the aortic root structure, including the annulus of the aortic valve, which then allows us to put a Dacron graft around the aortic valve, preserving it, and then In addition, as needed, we do leaflet repair. So in this particular case, some of that dissection has occurred, and now we are resecting one of the sinuses, the non-coronary sinus of Valsalva. We then harvest the coronary buttons. This is the right coronary ostium that's being harvested. Allows us to then further deepen our dissection down to the level of the aortic annulus. This is the region where we hit the membranous septum, an area where the electrical system of the heart runs, which we're particularly careful about not injuring or damaging. And then we continue our dissection under the right coronary ostium, so in the right coronary cusp region. This is the left coronary ostium, where the left main and the LAD and circumflex come off. We remove that. We then carry our dissection further deeper down to the level of the aortic annulus. And finally, we'll go to this region between the right and the left commissure. And I'll show this in a little bit of detail because I think it sets the stage for what we're able to do when it comes to aortic valve repair, because it allows us to really access the region of the aortic root where the aortic valve leaflets themselves are anchored. You can see that that's not something that's naturally accessible. It requires us to do a fairly deep dissection around the aortic root. But once we've done that, this entire aortic valve is accessible. It's fully open and dissected free. And we check again to see this valve has 3 normally functioning leaflets, and it's operating quite well. I'm going to move on from this because I don't think I can control the where we are in the video. Is there a way, I don't know if the AV team can help me control sort of where we are in the video? There's usually a bar at the bottom that'll enable me to kind of move it forward. While we think about that solution, I'll just present a couple more minutes. I think we've gone to the next slide. Maybe if you could get me out of presentation mode, that might be a way to do it. Yeah, just do it. Okay, perfect. I think I just want to complete this story by showing you outside of presentation mode. This is the Dacron graph that we're using to place around the aortic root. Oh, you don't see my slides. Okay. Do you see, okay, you see it here. Okay, perfect. Now I'm able to actually control the video. So that's, I'll take us back to where we were. We've done our dissection here. We're now placing sutures below the valve annulus, and I won't go into a lot of the surgical details, but to show you that this is the Dacron graft that's used to replace the aortic root in this case. We'll go fast forward a little bit to say this valve is now implanted within this Dacron graft. We add another suture line to reimplant the U-shaped structure of the aortic annulus. I'll show you briefly what this will look like once. So this is the final product, so to speak. The entire root has now been replaced. The native aortic valve is left intact. And following this, we do some testing of the valve, we pressurize it. We then reimplant the coronary ostia, coronary buttons that I'd mentioned that we had detached. And finally, we reattach this Dacron graft to the native aorta, and this is the final result. The entire root has been replaced, but the valve is left intact. That was the operation for that patient with normal aortic valve. But as we did these operations, we learned a lot about what makes the aortic valve function and what is it that actually makes aortic valves leak. And so the story went on from valve preservation to repair of aortic valves. And the way things started is that we started to see patients with root aneurysms as a primary reason for surgery, but also associated aortic valve insufficiency. And we learned how cusps also needed to be repaired. We started to address bicuspid aortic valves, which are abnormal leaflets by definition, and enabling repairs for that population. And we've now are at a point where we can look at isolated aortic insufficiency, so no root pathology at all, but primary cusp disease, which also allows us to enable a repair. It's important to say, what are we not talking about? So we're not talking about patients who have mixed aortic valve disease but associated severe AI. That's not the population. And we're not talking about predominant severe AI in patients who have calcified valves. In effect, for aortic valve repair, calcium is our enemy. We are talking about valves that have predominant severe AI. They can sometimes have mild, maybe moderate aortic stenosis that can be dealt with, but without heavy calcification of the valve. And I'll restrict my discussion today to valves that don't involve the uncommon configurations of unicuspid or quadricuspid aortic valves. One of the main learnings has been, just like the mitral valve, we talk about the Carpentier classification of aortic insufficiency, of mitral insufficiency. We similarly talk about the classification of aortic valve insufficiency, and that's given us a lot of insight into what's causing the aortic insufficiency and what we need to do to fix it. And in this classification, similar to the mitral valve, there's type 1 disease, which is abnormalities associated with normal leaflet motion. So annular dilatation either at the level of the sinotubular junction or at the level of the ventricular aortic junction or the entire root. In some cases with endocarditis, a perforation in the leaflet, but with normal leaflet motion. Type 2 disease that talks about cusp prolapse, excessive cusp motion, and type 3, which is restricted cusp motion leading to AI. And this is the subset that tend not to do as well or tend not to be repairable in general. We've learned that many patients, over a third of patients, have multiple mechanisms contributing to aortic insufficiency, that over 50% have some degree of annular pathology. So you can't just fix the cusps. You also have to address the annulus. And the most common reason for cusp problems is actually a prolapse or excessive movement of the cusps. So these lessons have now enabled us to repair more complex valves. So this is a case where I'll demonstrate some of those techniques. This is a patient that is 54-year-old male with multiple risk factors, previous type B dissection, referred with severe AI, congestive heart failure, some abnormalities in LV function. And when we look at this valve, the root is maybe mildly dilated, but not significantly. There's severe complex aortic insufficiency jet. Looks to me like multiple mechanisms just by looking at the echo. You see there's some sclerosis and thickenings of the leaflet margins. Here are some dimensions that say, mild root dilatation at 4.1 centimeters, but not something that would meet criteria for root intervention normally. In contrast to the valve I showed you earlier, this valve is a bit more thickened. You can see the leaflet edges are rolled up, fibrotic, and you can see why they might not coapt completely and close. We will show in a few seconds that there's evidence of prolapse right here. When you look at this left coronary cusp, you can kind of push it down and appreciate that with diastolic pressure, this might be a reason why this valve is leaking. I'm going to walk you through a few elements of what we do. We measure heights of the leaflet to understand whether we have enough tissue to work with. First thing we have to do now is remodel the leaflets. We have to remove the excess fibrotic tissue from the leaflets to enable them to coapt normally. Often this fibrosis has occurred due to chronic, long-standing aortic insufficiency, and the leaflet margins are thickened. So this requires kind of sharp dissection and removal of some of this tissue. And you'll notice that once this is done, the leaflet mobility is better. The leaflets are more able to come together and coapt. In this particular case, we ended up replacing the root because the annulus, where the leaflets insert, was quite dilated. And the one good way of addressing it is by replacing the aortic root. So similar to the operation I showed you earlier, we detach our coronary buttons. We do our dissection that takes us all the way down to the leaflet insertion. I won't repeat that here. We do a similar sort of suture line to anchor a graft, which you'll see in a second, similar Dacron graft that is going to be going around the valve. In this case, we have to do certain manipulations. There's some asymmetry in this valve, and we therefore re-implant it also in an asymmetric manner in our Dacron graft. I just want to show you some of the finished product of what this valve looks like. This valve has now been re-implanted within this Dacron graft. We now have some tools available to us to help us decide whether a particular leaflet is prolapsing or not. This is an effective height caliper that we can intraoperatively use to decide whether there's prolapse and whether something needs to be repaired. We now have added some sutures to repair the cusp that was prolapsing, in this case that I showed earlier. And when we do repair of excess free margin, basically what we're doing, if you imagine a sagging clothesline, we're actually just removing some of that free margin in order to enable us to have higher coaptation of this leaflet, bringing it up. Again, the coronary arteries are then re-implanted in this case, and we'll get to the sort of the end result here. Some additional maneuvers in this case were done to try and get coaptation. You can see this valve looks a lot different than what we started with. It's now coapting quite well, and you'll see a short image of the echocardiogram in a second. So this is a valve that was severely regurgitant, now has a zero leak with a normal size aortic root, a normal annulus, excellent low gradients after this. So this is a demonstration basically where we started in the 90s preserving normal valves to now where we are today in terms of replacing complex leaflet pathology. It helped me. Oh, there you go. Okay. The next question comes up. Okay, so technically we have had a lot of advancements. Why should we do aortic valve repair? What really is the benefit? Over the past 3 decades, data has emerged from a number of primarily single center, high volume, often single surgeon series that suggests that aortic valve repair can be performed with a low mortality, so less than 1% mortality, even though these operations are complex involving the aortic root. The reoperation risk tends to be about 10% at 10 years, so 90% freedom from reoperation in most of the larger series. Having said that, we don't have as robust data beyond the second decade, beyond 20 years. Recurrent AI or reoperation, if you combine those two together, that risk is approximately 15% at 10 years. Bleeding risk is excessively low because after this operation, patients don't require any anticoagulation. Thromboembolic risk is also quite low, and in particular, endocarditis risk is quite low because there's very little prosthetic material that's exposed to the circulation. A lot of other questions have been asked. What about bicuspid valves versus tricuspid valves? In fact, the durability appears to be very close at the 10 to 15 year time frame. And severity of preoperative aortic insufficiency does not seem to impact the future fate of this valve. So whether you start off with severe AI or start off with moderate AI, actually series have shown that if you repair the valve normally, that's what's the better determinant of durability. We've learned that if you don't treat the annular dilatation aggressively, that's a risk factor for future recurrence of aortic valve insufficiency. The question then becomes, well, yes, we can repair the valves. These are the technical things that we can do. Does it actually improve patient outcome and survival? There's been very little data on this. There's one study that has done a propensity match comparison, small study of 44 pairs, which said that, essentially if you compare patients with severe AI, the survival is better with repair versus replacement, and replacements here included a mix of mechanical and biologic valves. When you look at outcome beyond the first decade, this is data from Dr. David, who is one of the first pioneers to do this operation. And over 20 years, you can see that the durability persists, although there's a slow decline over time in terms of recurrence. This is data from actually our center. We looked at a propensity match cohort of 70 matched pairs of repair versus replacement and looking at valve-related events. And we found that valve-related events of thromboembolism, bleeding, endocarditis are less common in repair versus replacement. So some data is starting to emerge that you can actually have a better outcome in patients. So my final slide to say that, in the last 30 years, what we've learned is being able to go from preserving normal valves to fairly complex pathologies of aortic insufficiency, and that we're starting to show some of the benefits of aortic valve repair versus replacement, but a lot needs to be done. Some of the challenges are that the techniques still need to be standardized and disseminated so that they can be performed in a uniform manner across centers. Right now, it's still very much dependent on surgeon and center expertise. There are new techniques and technologies like annuloplasty rings and bands, some of which we've seen for mitral valve that are now emerging for aortic valve. And there is definitely a need for systematic long-term evaluation of outcomes in comparison to replacement. Aortic valve repair is feasible in many patients with aortic valve insufficiency if they don't have significant leaflet calcifications. We at our center and at certain select centers have demonstrated good durability, and standardization of techniques and improvements will further increase the scope of aortic valve repair. Thank you for the opportunity for presenting today.
Thank you, Munir, for this very nice presentation. I don't know if we have a question from the audience or from the chat. Not yet. Two questions. In your experience, Hans, when you select the appropriate candidate, what is the approximative rate of repair? And the question related to that, we see that more and more for patients with mitral regurgitation, we don't wait for LV enlargement symptoms. I had the case on Monday, patient with severe aeration, bicuspid, very active, no symptoms. Are we ready to start doing early intervention in patient with AR when rate of repair is high?
Great. Two very topical questions in this space. So answer to the first question would be, how do you select patients? So, there are patient considerations and then there are anatomic valvular considerations. So patient considerations, I think we can all imagine, the younger the patient is, the more likely they're to derive long-term benefit from a reparative approach versus prosthetic replacement. We have pushed the envelope here where we've repaired anatomically suitable valves even in the older population, and had actually good durable results with that. I told you calcium is our enemy. That's one of the reasons why we would select replacement over repair. The other enemy that we have are fenestrations in the valve. So major gaps, big gaps, ruptured fenestrations. Those are ones where we think twice or three times about trying to repair this valve because we just don't know what the durability of that situation will be. So we tend to replace. If you had to ask me as a surgeon personally, of how many patients that are referred to me get repaired, my number would be 80 to 90%. I had looked at this data early in my practice when we did our first 100 cases, and it was around 85% at that time. But actually, I recently looked at a data from one of my cardiology colleagues. They looked at center-wide data. Said of all AI patients, how many get repaired, and the number drops to 50. And the reason is, I think that we don't funnel all our expertise. All of the AI patients don't land in the same bucket. And so they're treated differentially because surgeon experience, surgeon expertise are actually different even in our own institution. Last, second point to a question, should we operate early? We don't have guideline directed indications to do so, but I think we have common sense. So I think when we see patients who show progressive left ventricular dilatation, haven't met the threshold, and they're active and they're young, I would suggest we should at least consider repair and have a frank and honest conversation with the patient. The mortality risk is low and the durability is actually quite good. But if you had to ask me, do we at the population level want to move the needle? I don't think we have the data yet. I think we have to wait for that.
Question, yeah.
Munir, things like decalcification of valve leaflets, like what's the state there? Like what can you remove? What value is there? Like who gets this? Can you make a comment?
Yeah, for sure. So a decalcification is feasible in a minority of cases, I would say. When we think of calcification of leaflets, you can have calcification that either involves one-sided leaflet or the other-sided leaflet, or it's through and through. When the calcification is full thickness in the leaflet, we tend not to decalcify because you lose a portion of the leaflet in trying to remove the calcium. And so in those cases, I think replacement is the better option. When calcium is restricted to only one side of the leaflet, we see that often in bicuspid aortic valves where raphe is calcified, but the calcium doesn't go below the leaflet. And in those cases, you can almost completely decalcify the leaflet and leave behind a very intact valve. I think that's very reasonable to do, especially in younger patients. The challenge there is you don't know when it'll come back. You know, patient obviously manifested with some calcium. Will it take 5 years, 10 years, 15 years, 20 years? Or maybe you've altered the hemodynamics of this valve so that the nidus for calcification, the reason for calcification no longer occurs because, you know, the hemodynamics are better. And I think the jury is still out on that. In my personal practice, what do? I will err towards decalcification in younger patients, not in older ones. You know, only localized areas of calcium. To give you a sense of what is the outcome of this, you know, we in our entire aortic valve repair database of you know 350 or 400 patients, I've had only one patient who's come back for an open surgery because of recalcification and stenosis, and one patient who underwent TAVI because of bicuspid valve ongoing calcification and treatment. So it's not like people are coming back in droves with calcification as the primary problem.
Question from Jadon. Jan Hassan.
Thank you, Munir. Fascinating talk. In isolated AI with normal roots, when do you consider a ROS procedures? And what is like the clinical profile that prompts us to refer a patient for ROS specifically?
Great question. So that's a competing treatment. For those in the audience that don't know, ROS procedure is where we take the pulmonic valve and we switch it and put it in the aortic position, and we typically use a replacement like a homograph for the pulmonic side. And that's gaining popularity in younger adults. Our preferred strategy always is repair because it's durable and it preserves the ROS option for young patients who might need an intervention in the future. So we're talking now about the 20-year-old or the 30-year-old or 40-year-old and thinking about their lifetime planning of valvular disease. So let's say they have AI, but the valve is not repairable and they are young enough to benefit from the long-term impact of the ROS. That's when the ROS comes in. For me, that age is under the age of 50. If the patients are over 50, I think we can map out a strategy for them where they can have a bioprosthetic valve followed by a TAVI, potentially another intervention in the future, and still live out their lives without a progressive kind of increase in mortality and valve-related complications.
Thank you. Calcium is a middle problem. Is there anything that a healthy person can do to minimize that risk, or is it purely body physiology?
Yeah, that's a great question. I don't have an answer, and maybe there are others in the room who have something to say about this, but we don't really know exactly why valves calcify, and some do and some don't. One of the mechanisms in my mind and in the literature is, maybe this is a question of inappropriate or turbulent hemodynamics through a valve that leads to repeated micro injury and then healing. As we know, valves are living systems. So they have valvular cells that are involved in healing, and so over time, calcium deposition may be an impact of long-term turbulent flow and healing. Can we stop it? I don't really know of any therapies that allow us to do that.
The only preventive strategy would be to have a good control of cardiovascular risk factors.
Thank you.
Thank you. Thanks, Munir.
Thanks a lot. It's my pleasure to introduce the next speaker, Dr. Talal Al-Atassi, who I believe is going to be in the virtual world here. He's a surgeon at the Division of Cardiology and assistant professor of medicine at the University of Ottawa. He's a unique individual in that he's actually a cardiac surgeon who completed a structural heart fellowship. So that's definitely an unusual path. He did that at Emory University, and he's been working here since I think it's 2017. currently serves as the program director of the Cardiac Surgery Residency Training Program and is an active member of the TAVI team. Dr. Eltassi has been tasked with the topic TAVI in 2023, Indications and Challenges. So if we can get him up here, that would be great.
Thanks, Ian, for the introduction. Do you hear me?
Do we have IT here for a little help?
Do you see my presentation?
I can see it here. I just don't see it.
Maybe I'll start to say, thanks, Ian.
Talal, are you there?
Yeah, do you hear me?
You're on mute. No.
Talal, I think you need to turn your mic on.
Yeah, and my mic is on. Do you hear me?
So, Bert?
Yeah, hello, my mic is on. Do you guys hear me now?
We hear a little bit of something.
It's, just here.
Hello? Do you hear me now?
Already.
Perfect. You can hear me now?
Just in the laptop.
Yeah. Do you hear me?
Yeah.
We've got you now. Can you hear me?
Yes, perfect.
Excellent. You're good to go.
Thanks, Ian, for the introduction, and thanks to the organizing committee for inviting me. I apologize. I just gave a talk in Toronto on heart teams, so I couldn't be in two places at once. So I apologize for doing this virtually. Now, I've been tasked to cover a pretty broad topic, TAVI in 2023, so I'll try to cover as much as possible and include all the highlights in the next 15 to 20 minutes. So this is the outline of what we'll try to cover today. Basically, TAVI is now celebrating his 21st birthday. April 16, 2002 was the first TAVI implant in man. But really, the idea started about 40 years ago with the patents and work on animal models. And only in the last decade have we seen FDA and Health Canada approval to use these transcatheter heart valves in a commercial setting outside of research. We've seen now TAVI surpassing SAVR as the predominant treatment modality for most patient populations with aortic stenosis. And that's really thanks to improved devices by industry, smaller sheaths, allowing transfemoral access, improved technique, and better patient selection. And this is, of course, based on really rigorous, for the first time, randomized trials in the valve world, addressing patients in all risk groups. And really now we have data to be able to use TAVI in pretty much all patient populations. That being said, all of those randomized trials don't address the real patient population in the real world, and there are a lot of exclusions. You have bicuspid valves, severe calcifications, or complex coronary disease. All of those were excluded from those trials. So we still sort of have to tailor the therapy to each patient when we see them in our clinics. If we look at the American guidelines, high or prohibitive surgical risk, if someone has more than a 1 year life expectancy, they sort of go to the TAVI world. And if they don't have 1 year life expectancy, then they probably get medical therapy and palliative care. If we look at the very young patients, less than 50 or 50 to 65, they enter the world of what Munir has presented, whether it's valve repair, Ross procedure, or mechanical valves, and more we're seeing bioprosthetic valves in the 50 to 65-year-olds. In terms of the 65 to 80, or probably 65 to 75, that's the most challenging patient population, and that's where a lot of discussion happens in terms of what are the treatment options and the lifetime management of aortic stenosis. So it could be SAVR, it could be TAVI, depending on the patient and the comorbidities and the anatomy. The European guidelines have had a different cutoff of 75. Anyone less than 75, low risk for surgery, they tend to go surgery. Anyone over 75 with straightforward TAVI tends to get TAVI, and anything in between is really dependent on patient preference as well as the heart team discussion. This is a really interesting slide where you can really look at, instead of just risk of a patient, you have to look as well as the life expectancy. So if you get, for example, a 75-year-old, which is maybe why the European guidelines have it more accurate, and their life expectancy, they may have more than 10 years of life ahead of them. So you either have to select a valve that will outlast the patient, or if you're not, then you really have to start thinking about the second intervention and at times third intervention in a younger patient. So in the first look at durability of THV valves back in 2016, mind you, this is earlier generation valves, our first learning curve in TAVI, the degeneration at 7 to 8 years of about 50%. If we compare that to surgical bioprosthesis, in some studies, you can see here 65 years old, they have 16 years before half the patients come back, and that's the median sort of time before SVD in a bioprosthetic valve. Now, if we look at all the different studies out there for surgical bioprosthesis, probably the average sits around between 12 to 15 years in a patient who is 60 to 70 years old. Now, let's come to something more robust of data. That's a randomized trial looking out for TAVIs at about 8 years is the latest we have. And so far, the data is quite good. Mind you, the definition of structural valve degeneration for the surgical studies were mostly about re-intervention and re-operation. And the definitions have changed to more of an increased in gradients. Whether, which one is more relevant to the patient, it's still debatable, and which is more important. But so far, we have some data out to 8 years. Mind you, the number of patients in those trials become quite small, 50 in this NOTION trial. In the CoreValve Evolute trial, we looked as well at smaller annular diameters, and the TAVI valves tended to do better compared to surgical valves, at least 5 years out. There's a difference there in terms of hemodynamics and degeneration. That doesn't pan out for larger annular diameters, so there's no difference, at least at 5 years down the road. Let's talk briefly about bicuspid aortic valves. There's a greater representation in the younger population, and we know they have a higher calcium load. So they tend to be elliptical and have asymmetrical leaflets, which presents a sizing challenge for TAVIs. They have eccentric and bulky calcifications and calcified raphe, and they have associated aortopathy, all of which present challenges both procedurally and in terms of natural history of the aortopathy, which we don't know how it will behave after the valve is fixed. Although some studies have shown that there's no difference between TAVI and a bicuspid and tricuspid valve, if we look at all the cohorts and the different center studies, it's a busy slide, I won't get in details there, but we can probably have a few themes that emerge from that. So, in a very selected patient population with bicuspid aortic valve, it may be feasible and safe. The 1-year mortality is similar to surgery in tricuspid aortic valve TAVI. And we know that there's better results with the newer generation devices. If we look at some of the things that are increased with the bicuspid TAVI, stroke tends to be one. Pacemaker implantation is slightly higher with the bicuspid TAVI. And there's a small but increased risk of annular rupture, although we're learning more about CT sizing and trying to avoid and mitigate those risks. What about aortic valve calcification? We know that it correlates with the severity of stenosis, but we also know procedurally, very calcified valves have a higher rate of paravalvular regurgitation. They also increase the risk of conduction abnormalities, certainly increase the risk of rupture if we're not mindful of the sizing. And there's also a risk of coronary osteocclusion, and that, if there's a bulky calcification that gets thrown off towards the ostium, you could sort of do a CT scan analysis and see whether that will predict whether that would happen. And of course, anytime there's a lot of calcium, there's an increased risk of strokes. And we have devices now to try to mitigate that risk by protecting the cerebral circulation. So where is the cutoff for safe or optimal TAVI in a calcified valve? We sort of started getting nervous when the calcium score is over 5,000, especially in a low-risk surgical patient that could go for surgery. What about the calcium distribution or the shape? Does that affect the results? It probably does. And will artificial intelligence play a predictive role in the future in terms of how the valve will behave when we implant a TAVI? Moving on to pure aortic regurgitation or insufficiency, it's still in the guidelines, the realm of surgery in all patient populations. We've done a few cases of pure aortic regurgitation. This is off-label with the current THV devices we have. And it's largely because of the anatomy. So there's insufficient anchoring. Calcium, Munir said, is the enemy for aortic valve repair. It's actually our friend for TAVI. You need something to anchor the valve. So you're going to get more embolizations for pure AI. The large annuli provides limitations in which valve sizes you can use, and you may get more paravalvular leaks. And you have concomitant aortic dilatation with possible aortic complications, and we don't know the behavior and the natural history of that aorta down the road if we fix the valve. We have some THV devices coming through the pipeline. This Jenna valve, for example, is currently used in Europe and the States. We will probably get to use this in Canada in 2024. So we'll get more dedicated devices for AI, which I think will expand the indications for TAVI in the future. We still think about 50% of the patients or half the patients, but there's still another half of the patients that won't be best served with a TAVI and probably should go to surgery or other modalities and other therapies. Valve in valve, in valve in valve in valve. This is sort of, kind of going to occur more and more as we put TAVIs in younger patients. We know that the mechanism of surgical valve failure, if it's stenosis or if it's a small surgical valve that was implanted the first time, these are negative prognostic markers for valve-in-valve TAVI. Not all surgical valves are the same. Some have internally mounted leaflets, some have externally mounted leaflets, and some are stentless altogether. So we know that challenges procedurally, for example, for stentless valves, they don't have fluoroscopic markers, so they're tough to visualize when you implant a TAVI. The mode of failure is more regurgitation. There is more chance of malposition because of that. They tend to come in with paravalvular, they tend to have more paravalvular leakage and coronary obstruction when you implant a TAVI within the stentless valve. For stented valves, they come in more with stenosis, but because of that, the TAVI valve-in-valve tends to keep more residual stenosis and higher gradients, which predisposes the patient to prosthesis-patient mismatch. Some of the procedural complications with stented valves include device malposition. We talked about coronary obstruction, and sometimes we have to use a second THV device because of that movement of the first valve compared to stented valves. Interestingly, for coronary obstruction, it tends to be higher with the stented valves that are with externally mounted leaflets. And that's because the leaflets tend to billow out and cover the coronary ostia. And our CT measurements of the valve to coronary, the VTC, tends to be underestimated in externally mounted leaflets because they tend to billow out more so than we would predict. So THV leaflet thrombosis is another hot topic presented a few years ago. We're seeing, more and more of these. It has been observed in all THV valves, in fact, even in surgical valves, although less so. We think valve-in-valve procedures tend to predispose more to valve thrombosis. We know that not all surgical valves are the same. So Mosaic and Hancock valves, for example, have up to 20% valve thrombosis. So we can't treat all surgical valves the same when we bring them in for valve-in-valve procedures. We think the reason for that is something called the neosinus. That's the dead space between the leaflets of the new TAVI valve and the old native valve or the surgical valve. And that space is where we think there is less or more stagnant areas, less flow, and it's a nidus for thrombosis and possibly even endocarditis. We know that supraannular valve-in-valve implantation, it reduces the blood stasis in those neosinuses. It also it makes the volume of the neosinus quite small, and there's more laminar flow into the sinus of Valsalva and the coronaries, and that reduces the risk of thrombosis. You can see here nicely in figure B a supraannular implantation on the right. You can see the blue wedge triangle is quite small. That's the neosinus versus the right. It's an intraannular deployment, and you have a quite large neosinus, and that predisposes to thrombosis and possibly even endocarditis. Coronary reaccess is another hot topic as we move towards TAVR in younger and younger patients. Over 20 or 30 years of their lifetime that's remaining, they may develop de novo coronary artery disease. So if they come in for a STEMI in the middle of the night, coronary reaccess in a patient who had a TAVI becomes possibly an issue. And it's the marriage between the anatomy of the aortic root and the type of the THV device that we use that really dictates how easy or how difficult our interventional cardiologists will find it to access that coronary. And sometimes you have to do that quite emergently. So some of the drawbacks of valve-in-valve include procedural challenges. Some of the early drawbacks include thrombosis and patient-prosthesis mismatch, and coronary access tends to be a new thing now that we have to think about for younger patients. And of course, long-term durability is still in question. So there's a lot of decision making. It's complex. There's a lot of data, lots of things to consider for patients. How do we make a decision? Thanks, to Dr. Misana, our CEO, who was an editor of the Heart Team for Treatment of Cardiovascular Disease. We authored a chapter for TAVI specifically, but I think there are many different Heart Team discussions within that book. But really, it's having the Heart Team discussion. They sit around the table and deliberate. You have different experts, and really the patient is at the center of that discussion in order to improve patient outcomes, patient journey through this process. I think that's what is needed, especially in those complex patients that may go into different avenues and different permutations of treatment. This is a vision I think Dr. Misana and Heart Valve Centers of Excellence will talk about, is having that heart valve clinic and the heart valve team that is being involved in all decisions. And this is sort of the holy grail. This is what we, I think, aim for in all centers of heart valve centers of excellence, is basically having a one-stop shop basically for the patients. They come in, they get their diagnostic workup, they meet with all the different physicians that they, whether it's interventional cardiologist, cardiac surgeon, or even non-interventional cardiologist. And then if they have an indication for, procedure, then they get to meet the anesthesiologist, meet the research nurses, enroll in trials if eligible, and have their consent. It's all done in that heart valve clinic. And I think since we've embarked more and more of that vision and have heart teams, we've seen our TAVI program grow and flourish. We're also been involved, and I've been involved personally in the Benchmark program, which is an educational program that looks at different TAVI programs around the country. And we visited quite a few sites, and we're continuing to visit different sites. And we went through that process of quality improvement and looking at our data and how we can improve. And I'm glad to report that this is just fresh pretty much from a few weeks ago. In the last year, we've become the largest TAVI program in Canada, having done 421 TAVIs. It's become the most efficient TAVI program in Canada. We're trying to share how we do things with other programs. We went from 3 to 5 TAVIs per day, twice a week, finishing at 3 o'clock. And that's thanks to the efficiency and the different stakeholders, the nurses, our administrators, allowing us to facilitate such procedures, whether it's bed availabilities or efficiencies in turnover. And all of this is while maintaining excellent outcomes. So we have low mortality, quite low pacemaker rates, and pretty early discharge after the TAVI procedure. So if we're now thinking about younger patients, we have to talk about lifetime management of aortic stenosis, and there are different pathways they can take. So do you do a SAVR, then a TAVI, and then a TAVI, or do you start with a TAVI, then explant that TAVI in the future, then come back for a valve-in-valve TAVI, or do you just do TAVI and then a second TAVI and a third TAVI? And each one has its own benefits and risks, and it has to be tailored to the patient. We'd certainly need more research to elucidate which of those strategies will be best for different patient populations. We published last year a paper looking at the different permutations. You have the Ross procedure. I didn't put here, but we probably should have put aortic valve repair as well, like Munir has discussed. So there's really a lot of different options, which is great for the patient. It's always good to have a big toolbox, and you can select from it the best tool to use for that patient and tailor it to the therapy to the patient. So this is just a 15, 20-minute presentation. Really, TAVI is still a lot more questions, I think, that needs to be answered in terms of research. And you have to stay tuned. I think in the next few years, we'll see a lot more developments in the TAVI world. Thanks for bearing with me.
Thanks, Talal. Any questions in the audience here?
Oh, yes, sorry.
I just have a casual comment and a serious question. The casual comment is that you mentioned earlier that you cannot be at two places at once. I just suggest that if quantum mechanic technology advances enough, you'll be able to do that. The question then is, you mentioned earlier that the cardiac pacemaker implantation will increase the valve problems. Would you please explain a little bit more on that? Thank you.
Sorry, will the pacemaker do? I didn't catch the last part.
Pacemakers and what's the risk of pacemakers with TAVI versus, let's say, surgical AVR?
Yeah, so that only a few years ago, our pacemaker rate was somewhere between 10 to 15%. As the devices have improved, we've seen a decrease in the number of pacemakers that's needed. On top of that, we think higher implantations of the TAVI valves have also led to a decrease in the pacemaker rate. Now, in the last year, we have a 4.9% rate of pacemaker implantation. I still quote around 5 to 7% for a TAVI. Traditionally, for surgery, we quote a 3% pacemaker implantation, but looking at data, I think contemporary data, my own practice, I quote a patient a 1% risk of needing a pacemaker, because I think we've sort of learned a lot about where the conduction system is and try to avoid deeper bites in that area. So it still is lower with surgery, that's for sure. But I think we've come a long way in decreasing the pacemaker implantation for TAVI by implanting higher and improvements in the THV devices. Mind you, implanting higher presents another challenge because you're now closer to the coronaries. So, there's an advantage, but then there's a drawback of doing that, because if you talk about coronary access, then that may present more of a challenge in a younger patient.
Thanks a lot, Talal. For the sake of time, I think we'll move on to our next speaker.
Thank you.
I'm very pleased to ask Mark Ruel to do the next presentation. So Mark is head of cardiac surgery department here. He's an expert in surgery, minimally invasive surgery, and many other aspects. His CV is long like that. He's also associate editor of Circulation, and he will present an update regarding individualized management for anticoagulation and choice of prosthetic valve.
Well, thank you, David, for the very kind introduction. Ian, Sandra, Cindy, many of you, Vince, presumably as well, have helped put this day together. It's great for the Heart Institute. It's great to be here. I was asked to speak about which prosthetic valve for which patient. It's obviously a very relevant question. I have the following disclosures with regards to this talk and valve corporations. Let's start with a hypothetical patient. 43-year-old woman. Obviously, valve disease in young patients is always a challenge. I think this is one of the gist of what you heard today. So let's say this woman has bicuspid aortic valve and needs to have a valve replacement. So there are a few options. A bit of a simplistic figure. It doesn't give the whole story, but essentially you can see here, going from left to right, a tissue valve, a mechanical valve, a Ross procedure, or a transcatheter valve. They all have their pros and cons with regards to, are they safe to insert? Do they have great hemodynamics? Are they durable? Are they easy to reoperate on? Do they have a low profile? For instance, if someone develops coronary artery disease in the future and needs to have a PCI or surgery. They're not on Zoom. Okay. For now. Okay, great. So, and then are you able to do valve in valve afterwards? Because obviously, if you were to say, for instance, use a tissue valve in a 43-year-old, like the ability to do a valve in valve is very, very important. And we'll talk a little bit about that, about how we can consent patients, especially young patients nowadays around this. The ideal surgical aortic valve prosthesis should be very safely implantable. They should have optimal hemodynamics, no anticoagulation. It should have literally very few or no events. It should be durable, easily removable, would not complicate future interventions, and have a low profile that will allow both valve-in-valve TAVR and minimal invasive implant. So as I can tell you, that ideal surgical aortic prosthesis does not exist. Now we have techniques, as David was alluding to, where we do non-sternotomy aortic valve replacement and mitral valve repair, mitral valve replacement all the time. We've published on this. It's well validated. The beauty is that this technique works for mechanical valves as well as tissue valves. It's not one that would, for instance, use a sutureless valve, and it's something that our patients appreciates. It's a little less invasive than sternotomy. Certainly, there are no restrictions afterwards. Vince Chen, a few years ago, published in Circulation, looking at freedom from reoperation according to age at implantation. And it's interesting that in that data source, you may recall that the heart valve clinic database at the Heart Institute was extremely strong and powerful. We have stopped funding it because we would put close to 6 figures a year as a division into it. And I think the reality has changed, right, with regards to following mechanical and bioprosthetic valves over the long term. Like the impact of doing that has certainly decreased. But at the time, it was there. And one of the interesting papers was looking at the odds of reoperation in patients according to age. And it's interesting to find that once a patient reaches 65 and receives a bioprosthetic valve, there are more patients who will never need a reoperation than patients who will need a reoperation. So interestingly, talking about anticoagulation here, as you know, there's a special mechanical valve, if you will, that's the MCRI, now CryoLife, and then subsequently, very recently in the last year, Artivion, which is a new name for CryoLife. And I had one of the disclosures being on one of the steering committees. But this valve, again, with the caveat, I'm not saying anything that pro or con the valve, has been approved after the initial PROACT trial to be used with an INR of 1.5 to 2 for mechanical valve. So it is the only mechanical valve in the aortic position only that can be used with regards to that. And that came from the PROACT study, which was published in JACC a few years ago. You can see the reference here. It was back in 2018. Basically, there were 2 groups. There was a low-risk group that received Plavix and aspirin, and clearly that group was stopped early because of higher rates of events in the Plavix aspirin group versus Coumadin. And another group that was low-dose warfarin anticoagulation after 3 months versus regular dose. And what came out of this is that the 1.5 to 2 had the same numbers of composite bleeding and thromboembolic events than the patients who were kept on more standard 2 to 3 INR. Now, recently, we just finished this trial of doing the same after mechanical mitral valve replacement. If that's of interest to you, they're not very common operations. For instance, at our institution, we'll do maybe 20, 25, 30 mechanical mitral valve replacements per year, but still something of relevance, especially for a young patient, for instance, who would have ischemic MR or so. So again, a non-inferiority trial. And in this trial, we were not non-inferior. Ultimately, the non-inferiority hypothesis was not satisfied. It's not that it was inferior, but it was not proven to be non-inferior, and therefore the trial was null, was essentially not proving that you should go to a lower INR. And the INR that was tested with the Onyx valve again in this trial was 2 to 2.5 versus the more classic oscillating around 3 range of 2.5 to 3.5, which essentially should be the range that we continue to use for mitral mechanical valve replacement. Maybe I'll say on the side as well that we all have offices and we all get faxes over the weekend of our patients who have low INRs. And one of the caveats around this, there's actually a jurisprudence case in Canada of the CMPA where a lady, it wasn't in Ottawa, I don't exactly remember where it was, but this case was illustrated, was faxed to the main most responsible physician over the weekend with a mitral mechanical valve with an INR of 1.8. And the physician did what many of us perhaps would do, said, well, go up on the Coumadin dose and, repeat an INR in 4 days, etc. During that time, the lady actually thrombosed her mechanical mitral valve. The physician was sued and lost, and the CMPA settled. So I think it's very different. One of the take-home messages, I think if you see a mitral mechanical with an INR less than 2, it means you have to start heparinization of some form, sub-Q heparin or so. Bringing up the Coumadin dose is not enough. It's entirely different than an aortic mechanical valve where, you would probably be okay. And I think the jurisprudence would support you if something was to happen, which is extremely unlikely. But a mechanical is a different animal. So with regards to bioprosthetic AVR, what's the evidence that we have? As you know, the guidelines for years and years will have been recommending 3 months of Coumadin anticoagulation. I find that in cardiac surgery practice, it's often the old surgeons who adhere to that, and the young surgeons kind of give the benefit of the doubt to aspirin alone. I'm not exactly sure which group I'm in, but I still use aspirin alone. I think what happened with the older surgeons, they've seen these 1 or 2 low-risk patients after an uncomplicated bioprosthetic valve replacement come back with a stroke, and that just bite them the wrong way, and they would never want to see it again. So typically in our practice at the time, this is what we were seeing in our division. And Talal, who just presented when he was our resident, this nice open label trial where we looked at mechanistic evidence to support either using anticoagulation or not using it. Again, it was not randomized. It was an open label trial, but we published it in Circulation. It was a good piece in my opinion, and it certainly helped solve the issue around this. So it was a small trial. We had 28 patients of each group, open label. For instance, Dr. Masters and Dr. Bedard at the time would use anticoagulation for 3 months. I wouldn't. And then we would compare the patients and we would look at microembolic signals, both early post-op and then at 1 month. And we found absolutely no difference in terms of microembolic signals and the percentage of patients having them as well as the quantity of them. So this was, if you will, some mechanistic evidence supporting in a small open label trial, not using Coumadin. And as you know, it's estimated that only about 15% of surgeons, despite the guidelines, use it in someone who is in sinus rhythm after bioprosthetic AVR. When I was in my first year of practice, 20 years ago, one of our country's leader came to, some of you may know who it is, and I won't tell you who it is, but he has authorized me to give this story. And he was in his 40s, starting his national leadership career, and needed an aortic valve replacement. I was a little bit, having events in my pants, having to operate on this person. But that's something we did as an institute, and I think it went very well. But the question at the time was whether we would use a mechanical valve, bioprosthetic valve. He traveled extensively, and he chose to have a mechanical Onyx valve. And interestingly, after the 2018 paper was published of the PROACT trial, I called him and congratulated him on the recent achievement, and said, by the way, we could bring your INR down to 1.5 to 2 if you wanted, and the new guideline would support that. And he said, absolutely not. He said, I've been doing great. I'm 2 to 3, and I've not had a single event, and I'm not playing with something that ain't broken. So interesting perspective. So now, to finish on this, you may have heard the PROACT 10A trial, which many of us had put a lot of hope into. There was a trial done many years ago in Hamilton called Realign that John Eichelboom led. And it was a very ambitious trial. It was using essentially DOACs, and at the time it was argatroban, in patients with mechanical valves. Now, with that trial, it was started very early on, like the non-Coumadin regimen, if you will, was started a few weeks after operation. There were a bunch of mitral mechanical valves. There were a number of things which, when you read with the content expertise that we all have, like you would not design a trial like this. So we really had a lot of hope that with PROACT Xa, which we designed from scratch, we would only keep patients in sinus rhythm. We would take on the aortic valve patients. We would start at 3 months afterwards. We would put them on apixaban, which is a better DOAC in terms of aggregation in vitro, and probably the best one we could find. So we kind of aligned everything, and we put a lot of hope on the trial. We tried to get the trial done in Canada, and Health Canada never agreed for a number of procedural reasons around SUSARs and side effect reportings all around the world to get into it. And frankly, you know, even though I was frustrated at the time, they were right, because the trial ended up being terminated early. And will be presented next week in Los Angeles. I can't exactly tell you why it was terminated early, but stay tuned, and you will see the reason why. So all I'll say is that overall it was disappointing to many. So trial was terminated, and I think, what would we suggest to a 43-year-old patient? I think a stented tissue valve, unless she accepts to have a mechanical, depending on pregnancy wishes, smoking, whether she likes to do sports, what type of meds, and typically, you know, tissue in both mechanical valves are not as bad as depicted. It's okay to use a bioprosthesis the first time. It doesn't mean you're stuck with bioprosthesis all the time. You can put a tissue valve in a 35-year-old, and then say when you come back at 48 or at 44, we'll then put a mechanical valve. There's nothing that prevents you from crossing over. And typically, what I will often put in my own consents with my patients, and I'll stop on this, is that for a young patient, I'll say, well, if I feel I can give you a 23 or larger, ideally 25 for easy valve and valve later, we'll use a tissue valve. Yet if I come in and your root is really small and we're stuck in size 21 or something like that, where valve and valve TAVI is not going to be that good for you, then please allow me to use a mechanical valve. It's very rare that we have to do that, because it's rare that we put a site smaller than 23. But I find this resolves the issue fairly well. So I'll stop here, and I would like to thank the organizers for putting together such a wonderful day.
You have time for one question? No.
Oh.
Sure. So you mentioned the size of the annulus, which I agree is very important, but you have a age threshold when you advise tissue or mechanical. Sometimes patients say, you explain what the advantages, disadvantages, and the patient is telling me, choose what is best for me.
Yeah, no, absolutely. That's a great question. And I usually finish with always with the same line. I said, if you're worried more about the eventuality of a reoperation in 10, 15 years, then you are worried about the annoyance of taking an extra drug every day and having your blood checked, you know, on a regular basis, then, you know, choose a mechanical valve, and it's vice versa, choose a tissue valve. So I think it depends on the level of anxiety versus reoperation versus the annoyance of being on warfarin every day. And we know now that warfarin is not going away with mechanical valves. It's going to stick around for probably a foreseeable future. I think future we'll all be retired before we have a non-Coumadin solution to mechanical valves.
No question, but I've got a question, Mark. So in the young patients, like there was survival data for a benefit of mechanical aortic valves. Like now with the possibility of TAVI, is that just like, who cares about the survival? Because, you know, we're not going to reoperate. We'll give you a TAVI. So let's just go with bioprosthetic valves, because we put so few mechanical aortic valves in now.
I agree. I don't believe it, Ian. I think I know it was in the New England Journal. The paper you're referring to is Andrew Goldstone. looking at the California database, doing a comparative effectiveness study between mechanical and tissue valves. We had done the same at the Heart Institute. We published in Circulation before, very long-term outcomes, 20 years outcomes in patients at a mean age of 40 years old. So you might be on the paper, Professor, you can correct me if you are or not, but at the time we got our heads together and we didn't see any difference. But it really depends. Comparative effectiveness doesn't work. Like you cannot take two cohorts who receive two different therapies for very specific reasons that are, as you know, are always missing from the paper. And I think the world is shying away from them. So, you know, that particular paper made it to the New England and showed that, but I just don't believe it. I think there's reasons why people get a mechanical valve, and obviously that has to be associated with their survival potential versus people who don't. Maybe not every time, but certainly a significant proportion of the time, right? So bias at inception, there's no amount of modeling that will account for them post hoc.
Aspirin.
Okay, it's for a mechanical AVR. Yeah, so it's a great question. The range, really, the valve we use here is the Artivion Onyx valve in all cases. So that's the only valve that you will see from a patient at the Heart Institute. So after 3 months, that patient can now progress to initially an INR of 2 to 3, and then progress 1.5 to 2.5, or even 1.5 to 2 is fine after 3 months, based on the results of the PROACT trial. Now, that being said, if that patient has coronary artery disease or AFib or other reasons that would make it more risky, I would stay away from the 1.5 to 2 range. I would stay in 2 to 3, and I would add aspirin, especially this coronary artery disease.
But it's 1.5 aspirin.
Yes.
Mark, what about tissue valves? So do we really need to use aspirin? You know, we give them all baby aspirin. What's your feeling about that? I mean, that's kind of what the guidelines say, but I mean, I must say, do we really need to?
Yeah, it's a great question. You know, there are still events with bioprosthetic valves. And when you really go deep into it, the big difference in terms of thromboembolic events, especially not in the mitral position, but in the aortic position, is not huge between a well anticoagulated mechanical valve and a bioprosthetic tissue valve. So the main difference is really with regards to bleeding events, especially in young, chronic, stable patients. So there are events that, to me, you know, I don't think we have the data formally, but I think aspirin makes a lot of sense.
Coumadin for young patients who are planning on pregnancy in the future?
It's a great question. Yeah, it's a headache for many young mothers, right, and couples and families. It is doable, as you know. It is doable to deliver a child. There's many protocols. One of the ones I know the most is the Hammersmith protocol, right, where you want to avoid warfarin early on, and you want to avoid it obviously around the time of delivery. But in second trimester, for instance, it's okay to use it. There's obviously side effects from this, but many babies have been delivered from mothers who had mechanical valves. Again, you have a bit more flex if it's an aortic valve than a mechanical valve. I would say, you know, say you have a 32-year-old who needs a mitral valve replacement. I would probably advise to use a tissue valve, knowing what we know, and it's not that field has evolved at all. So your question is well taken. I think it is feasible, but it needs a lot of attention, a lot of heads put together to make it happen safely. Thanks so much.
So our next speaker is Ms. Kate Kellerman. Ms. Kellerman is the structural heart nurse specialist working in the Center for Valvular Heart Disease at the University of Ottawa. She's previously held many important positions at the Heart Institute. She's worked in the Rapid Intervention Clinic and the Cardiac Amyloid Clinic, and as the Heart Failure Transitional Care Nurse at the Heart Institute. Ms. Kelman will discuss the role of the valve clinic nurse as well as new community initiatives in valvular heart disease. Okay.
Okay, hi everyone. Thank you so much for inviting me to speak today. I was asked to discuss the role of the nurse in our clinic. So I just wanted to take a moment to acknowledge the land that we are living on and work on. An overview for today. So I'll touch base on the objectives of the clinic, the referral process, the role of the nurse, and ongoing projects that we have at CVHD. This is our team and it's growing. So we started off small, but we're growing every day. So for the objectives of our clinic, we want to enhance early diagnosis. For example, we're encouraging family members, first-degree relatives, screening for BAV patients, and treatment of valvular disease with prompt referrals and interventions during that optimal window. We are limited with guideline-directed medical therapy specifically for valvular disease. However, during each visit, we address pertinent risk factors and, of course, treating if they also have heart failure or any other cardiac conditions. We also optimize pathways for multidisciplinary assessments. Because we follow these patients so closely, we're able to screen and refer to them to appropriate disciplines such as geriatrics, respirology, social work prior to the point in their disease progression where they require that surgical intervention. Our goals is also to expedite access to providers. So we're actually in partnership with Northern Communities, and I'll touch base on this a little bit further to give access to everyone in Canada to our care. And we also expedite access to testing with same-day echoes and patient visits, which I'll touch base on later in this presentation. We continue to follow patients long-term as well, as long as they don't have another cardiologist. And CVHD is involved in several research studies, and through these studies, patients have the opportunity to trial new medications and treatment options. So we can see patients once for a second opinion or for complete evaluations, management, and follow-up. And here's kind of our guideline for referrals. Our referral process, so we've really had a climb in our referrals, but we're able for new routine referrals to see the patients around in 3 to 4 months. For urgent referrals, they can actually get seen by our nurse and testing done within 2 weeks or a week even. So you can refer to us by fax or through Epic as well. So this is kind of the patient's journey for same-day testing. We're able to get the patient, a lot of them are elderly, so the nurse or another staff member from CVHD clinic will greet them, will organize blood work, ECG, echo, sometimes stress test and CT as well. And the research coordinator will be there as well to approach them with research opportunities. And for Dr. Masika's patients, we're able to also, he will interpret the echocardiogram, write the report, and have the consult in the same day. If it is divided into 2 days or the 1 day, patients are really appreciative of this because it means they don't have to drive to the city, parking, everything in multiple visits. So it's really putting the patient first and ensuring we're providing patient-centered care. These are our numbers from 2019. However, our center really has grown, and in 2022, we had about 1,500 patients and we had 1,700 visits. But with the influx in referrals, we're doing more and more. So the nurse's role at CVHD, it's critical really to have a nurse triaging all of the incoming referrals because we can assess the severity of the disease. The nurse will look at the echo report, the med list. Are they already started on a diuretic? What are their significant risk factors? Were they referred by a cardiologist who is able to follow them closely, or is it their primary care provider that has referred them? Nurses will work off medical directives in order to order echo, CT, blood work, ECG, and we collaborate with our admins to make sure patients can come in on the best time for them in same-day testing. We also play an important role with follow-ups. As the nurse, we are often following up on blood work, following up on symptoms. We want to catch that optimal window, so patients will be calling us frequently if they do have a change in their symptoms. If follow-up isn't for a year, that doesn't mean that they won't call us earlier. So then we have clinic days for each doctor every day of the week. The nurse is present during every clinic to assist and support the physician. The nurse also sees her own patients in clinic on testing days. And the purpose of these clinics is to serve as an opportunity to educate the patient and prepare them for their visit with their cardiologist. Future implications for the role of the nurse would be to see stable post-intervention and stable patients with valvular disease under the supervision of the cardiologist. So it's part of the nurse's role to give an individualized patient teaching plan. This includes endocarditis prevention for our post-op patients, anticoagulant teaching, heart failure education, etc. We are in the process of creating new tools for patients, including a valve booklet, endocarditis booklet, and a BAV information card to make sure that patients are being screened appropriately for bicuspid aortic valve. We also will be creating educational videos for our patients and other patients that are followed from other centers so they're able to access this information. We are also in the process of creating a support group for our patients where they will not only receive support from their peers, but from the nurse. And during these group sessions, they'll be offered educational series as well, led by the nurse. Future implications for the nurse would be to offer education and in-house teaching to nurses and allied healthcare professionals about valvular disease. That's a bit on a different level from the physician's perspective. The nurse will also be providing each patient with a risk factor profile sheet and follow an algorithm to address each risk factor. You know, it's not enough that we tell our patients to lose weight or to have better blood glucose control. As the nurse, we really need to be setting them up with the appropriate resources, referring them to community support so that we can optimize their cardiovascular risk factors and capitalize on that opportunity. And the goal for this is to improve patients' clinical outcomes, promote patient engagement and buy-in, and lessen the burden on the cardiologist and healthcare system in the future while considering a holistic approach to care. So one of the projects that we're working on is a partnership with Dr. Rick Davies and OSNI to help facilitate patients living in small communities in Northern Canada. And part of the nurse's role is to help coordinate their flight down and that all of the testing, including dental care and evaluation by their cardiologist, all to be done within the week that they're here, so that if they do have to go back up north whenever they come back for their surgery, everything's kind of in a bow and ready to go. And there's no loose ends because of the limited resources that they do have up north in certain communities. So another big part of the nurse's role is research. So we currently have almost 800 patients in our biobank, focusing primarily on aortic stenosis and mitral regurgitation. We will be hiring a new research nurse to help facilitate the multiple studies that we are offering. And the nurse does play a large role in the screening process for eligible patients. So there's so much public knowledge about cancer, about heart attacks, about stroke, but little publicity about valve disease. So part of the nurse's goal going forward is to establish really a communication program and a social media platform so we can raise awareness about valvular heart disease. So we have done a HVD stethoscope check. We've done 2 of them so far. Early detection with stethoscopes checks are essential, yet not enough primary care providers, as Dr. Masika mentioned, are using their stethoscopes. So we had these 2 days and they were very successful in, and we did this in collaboration with Heart Valve Voice, and they were very successful in raising awareness, and we identified quite a few murmurs that day. So this is kind of Dr. Masika's project, but we're thrilled that we will start our mobile clinics this spring, where we will have a nurse and an echo tech visit nursing homes in regions around Ottawa and underserved communities, as well as Native reserves. And the aim would be to see 4 patients an hour for 8 hours. The program will roll out in phases with the hope to have the funds for an actual mobile unit in the future, and to have going further than just Ottawa. During these visits, the nurse will do vitals, an assessment, and a cardiovascular risk factor screening, including point of care testing for HbA1c and lipid profile. The patient would then undergo a POCUS by our echo techs, and at the end of the visit, the patient will receive a visit summary, including the POCUS results and the risk factor assessment, as well as our recommendations. At 6 months, the nurse will then contact the patient to see if the recommendations have been followed up on. So with this program, we anticipate 3 findings. For situation 1, a request for a formal TE will be ordered in Epic, as well as a referral to the UHI Center for Valvular Heart Disease. For situation 2, participants will be advised to consult their GP or a walk-in clinic, unless findings are urgent, of course, or semi-urgent. Action is required, such as severe left ventricle dysfunction or pericardial effusion, at which point they will be referred to the UOHI Rapid Access Clinic. If needed, a direct referral to the emergency department will be made, and this will be done in collaboration and with the support of the supervising cardiologist. For situation 3, participants will be given out brochures, and we will follow the same kind of algorithm as we do in our clinic to make sure that the pertinent risk factors are addressed. And we will advise them to consult their primary care provider to make sure that their hypertension or diabetes or lipids are followed up with appropriately. Whoops. We are hiring. So with the expansion of so many centers, with the expansion of so many programs, we are looking for a clerk and a research nurse. So if anyone wants to join our team, please reach out to us. And in summary, we are very excited with the upcoming projects we have on the go. There's so many opportunities for growth and innovative research and improving our patient care, and the nurse can really help play an essential role in all of these projects. Thank you so much for your time.
Thanks a lot, Kate. Any questions at all from the audience? Definitely, Kate and David are great people to work with. So if you want a job.
We have a nice team. So thanks, Kate. So Kate is the pillar of the CVHD with Cindy, Ellie, and Donna. I don't know, she left. So without them, nothing would have been done.
Kate, the educational initiatives, like you're creating pamphlets, are you, that patients will get? Because it's so important, that educational aspect.
Yeah, and we often see that during their 15 or 30-minute appointment with the cardiologist, so much information gets said and it can be quite overwhelming. So I get phone calls from patients saying, you know, like, okay, my family member has to get an ECG to rule out bicuspid. And I'm like, no, it's an echocardiogram. Oh, what's that? So it's really helpful to give our patients tangible, appropriate resources so they know where to find that information. Yeah.
Is this something that maybe will be put on the Heart Institute website that other people can access it and use it in their communities? Yeah.
Definitely.
Excellent.
All right. Well, thank you so much for your time, everyone.
David, do you want to word?
Well, thank you everyone for joining today. I think we had a very nice, I really enjoyed the meeting today. Thanks for all the speakers for this nice presentation. We had some technical issues, but we faced that. We'd like to thank Sandra and her team for organizing the meeting, our sponsor Abbott and Novartis for helping us for this study. Jan, my co-moderators, the CVHD team again, Kate, Cindy, Donna, and Eddie. I think I forgot no one. I think you have to, I forgot my form, but you have, if you can please fill the survey, and it's already online on the chat. If you do so, I think you can win some gift cards. So it's an incentive for doing that. We have a small break for the lunch, and the second part will start at 1:10 on heart failure. Thank you again. Bye-bye.
Go? Yeah. All right. Well, welcome back, everybody. And welcome back to the people online. Sorry that you weren't able to join us for lunch this afternoon. So we'll get started with the second half of the presentation now. My name is Lisa Melnichuk. I'm one of the cardiologists here at the Heart Institute and the director of the Advanced Heart Disease Program. And so for the next few hours, we are going to be talking about my favorite topic, which is heart failure. I'm really excited to see some of the topics that we're going to cover this afternoon. What we've tried to do is to really focus on what's relevant in 2023 in managing these patients that we all know are so complex. And so although we are going to talk about heart failure, we're going to talk about heart failure as it lives in certain cardiac and non-cardiac comorbidities, which is really the challenge for these patients. Before we get started, I just want to thank the Heart Institute for putting on this symposium today. Thanks to our sponsors, Novartis and Abbott, for their unrestricted funding for this. And a particular thank you to all of you guys for coming out here on a Friday and giving up some time to share some discussion with us. So without further ado, I will welcome our virtual care team to the stage, and I think they are going to talk about telehome monitoring and IVR and heart failure, and I will see you again shortly. Thank you.
There, Donna's just going to come up and join me. Marianne's going to sit. So I'm Cynthia. A couple of our staff members couldn't be here today, unfortunately. This is Donna. Want to thank you for inviting me today. I've worked in cardiac virtual care since 2008. The program did start in 2005, and I joined the team after that. Donna's been with us a decade, I think now. So I'll just get the slide here. So for us, our mission in cardiac virtual care is just to improve access to the specialized cardiac care services using technology for patients who transition either from the inpatient world or if they come to the clinics, we follow those patients from the onset. So to explain briefly what telehome monitoring does, we do medication management, fluid volume regulation. We do this with vital signs monitoring, and we give self-care education to the patients. So with all of this, we determine what the patient's requiring and follow through with that. Some just need the fluid volume, some medical management. So the problem that we're trying to solve is for patients with poor compliance that with the treatment plans. We want to prevent hospital readmissions, poor patient outcomes, and improve goal-directed medical therapies to attain, if possible, the maximum dose a patient can tolerate without delay. So as everyone knows, it's hard sometimes to get appointments in. We're very full and backlogged. And so if you're waiting your months and months to see your patients, up titrating these medications is a challenge. So for us, we do this in between with the information that we get from the patients and with directives or orders from the physician. We can safely and quickly up titrate these medications in order to do that. This is the telehome monitoring equipment here, and of note, this is the new equipment that we're actually getting. We're right in transition right now to switching programs and companies. So as you can see, there's a scale, blood pressure cuff, and a tablet. And these are provided and sent home with the patient for them to send in their daily vital signs to us. A little bit of a busy slide, but this is the web-based platform. So we get all the information in there with their vital signs each day. We get alerts, we set alerts, so it'll tell us, you know, if someone's above or below their programmed numbers that we've set. In the end, we really treat every patient, whether there's alert or not. We give every patient every day the same time frame to review whether they need to be called or not. So how does it work? And I'll start with our automated calling system because we have different technologies. For some of you who know, we refer to it as IVR. It's the Interactive Voice Response System. This is a system that will call patients at regular intervals to ensure ongoing education support. The calls are made day 2, 7, and then every 2 weeks until week 12. They can just answer yes or no, or press the pad on their phone to answer it. This system provides education on medication and symptoms as well. If they answer something of a concern, it will flag the system and a nurse here at the Heart Institute will call them back. So some of the questions are, have you gained 2 pounds in a day, 5 pounds in a week? It'll ask them if they'd like to know about their the medication bisoprolol. They hit yes, the system kind of spells out what it is. And so they get some education that way. If it'll ask them if they have shortness of breath or swelling. If there is a yes answer, the nurse will call back and review everything and can direct the patient what to do with that. The telehome monitoring system is for patients that require more daily monitoring, and that's the one that they get the scale and blood pressure cuff. So with the new system, the patients will go home from here with the equipment or come pick it up, and the company will call them to help them troubleshoot any of the technology issues now. This gives us more time freed up to do more education with our patients instead of troubleshooting any equipment problems that we have. The vital signs are transmitted automatically to us. We ask for a morning weight so that we get a dry weight from the patient. It comes to the Heart Institute, and one of us nurses in the office review those, and then we call them as needed for further assessment or intervention. And then we contact the patients if required, but in between, we just manage the patients as we've been asked to, whether it's titrating or keeping them dry, whatever the direction has been given for them. This is for the automated call systems. It's just how it works. There's a database entry. The information's entered into the database. The system calls the patient, captures a response. It's either flagged and it's done by an internet-based system. Who should be referred to telehome monitoring? So for patients who are at high risk for requiring acute intervention, titration, and transitioning. So if a patient is going back into the community and is at risk of readmission, they will be flagged to us, and we decide which perhaps technology is required for them. So we'll pick either the IVR or the telehome monitoring based on the patient, whether they meet the criteria and what needs to be done. So in order to be considered for telehome monitoring, there is criteria. over the years, of course, we've learned what works and what doesn't work and how to be successful in this. We have at times been at capacity, and so choosing our patients when we're at capacity and giving equipment out is key at that time to ensure that we're successful in giving equipment that's going to get used properly. Not everybody wants to be followed by us. Or is successful in using the equipment. So the patient must consent and agree to the conditions of the program as explained to us. They have to have a physician that will be the main contact for them. That would mean that during the program, when we follow someone on the average of 2 to 3 months, we could go to that physician at that time for any directions. So if they were ordered blood work going home from the hospital for a one-time follow-up, I need to go to that doctor later for something else. That's the physician, that's the main responsible person during that time frame. The patient must have the ability to use the equipment independently and be able to follow the instructions. So they have to be able to stand on the scale, use a blood pressure cuff, cognitively take our instruction and speak to us, or be living with someone who can take on that role for them and agrees to during that time. So if the patient's either living at home or an independent setting with a caregiver that can do that, that's fine. And they must be responsible for taking their own medications. Some people are in retirement living and their medications are given by the nurse at the facility, and we are unable to change any of those as we are a nurse-run clinic. And so that's not a successful situation because we are unable to change those. If they're giving their own, we can adjust any medications that need to be done. And then also we have to be able to communicate with the patient in either French or English or have an interpreter who lives with them and available. So we've also encountered those complications. We have patients who speak different languages, but their caregiver, family member lives with them. So if we're calling them during the day to ask why their weight's up 4 pounds or their blood pressure's 90 on 60 and that's low for them, and we want to just discuss why there's a change, we have to be able to speak to someone at that time because maybe an intervention is required. So the son who is, 4 blocks over and at work can't call me back till later that night and interpret for me. That makes it an unsuccessful situation. So the exclusion criteria based on that is the language barriers, dialysis patients, physical limitations. And so it goes down here, all those things that I've touched on. And palliative care patients as well, we generally don't follow. Our patients have transitioned that we're following to palliative care. But generally, once that happens, the palliative team does take over. So the data collected during this time is just the personal information, drug information, and vital signs outcomes. We collect all this data on the patient. We also have questions for symptom management that the machine asks the patients, and as you can see here, we program and choose what they are. So if a patient, say perhaps is starting a new medication that might cause dizziness from the lowering of the blood pressure, we'll put that in. If developing a cough might be something that we put in if we start the ACE, but we choose those based on what needs to be added there. Every patient's asked weekly if their doctor has changed or deleted any medications, and that prompts us to call because many times patients go elsewhere, we're unaware of it, and their medications get changed. We need to be on top of their medications if we're titrating them, and we need to let their cardiologist know when they go see them what the medication list is to the best of our knowledge. So of course, in the average 90 days that we follow them, this is the amount of data that we collect, just to show you on the average of that time that we would call people up to 3 times a week. Some people get only 2 to 3 times a week calls. But a minimum, we call our patients every week, even if they're doing well, just to do a check-in. And during the end of our program, that's really where we should be at, that we're able to just check in on them once a week for the last few weeks, because we've been successful in titrating everything. They're feeling better, and have their self-education done, and are able to transition off the program. So this was after the original onset of our program. Originally in 2005, they did a study to show how the readmission rates that were changed from this new program. And really, in the end, that's not, those numbers will have changed. Many times, the very first few weeks of following them, that's when we find them very high at risk. They've not gone to the pharmacy. The prescription never arrived. They're taking the medications incorrectly. The amount of information given at discharge or at a clinic, they don't maybe take in. And so we catch a lot of errors right at the beginning. That would have been an admission for sure, had it not have been found out right away. So virtual care gives us the eyes on the patient post-discharge or clinic medication changes, and gives us a lot of substantial data on patient behavior. We get to know our patients very well in the clinic, and we're able to pass that on to the cardiologist, the nuances that you can't collect in a 20-minute visit. We'll let the physicians know what's gone on. We find the challenges for patients that they may not tell you. They're not taking their medications. They're not compliant. Maybe there's financial issues at hand, and so they didn't, follow the proper diet, because, eating healthy is expensive. We really go over lots of diet. We cover everything with the patient and spend a lot of time educating them. And we have the benefit of doing that. And in that short period of time, hope it sets them up moving forward to follow all of these directions that they've encountered with us. So I want to thank you for your time and joining us today. Great, you can.
Just wanted to say thank you to a wonderful group of nurses that work in the telehome monitoring. You really put out a lot of fires and save a lot of admissions to the emergency room. Does anybody have any questions in the audience? So I have a question. Okay. So what are the biggest complications you find, or the biggest things that you have to go to the doctor to kind of correct when you have the patients on?
And it would be probably medications. So when we titrate, we also follow up with blood work. So we work with medical directives, as I mentioned, for most of the physicians. And so the blood work requisitions sent home with the patient and their standing orders. And so if there's a titration done and the blood work comes in and there's a high creatinine, a high potassium, maybe they didn't tolerate that medication. Maybe it's a blood pressure that's low because of it. So we find that titrating can be very difficult at times. Some of the patients are quite sick, and so you have to kind of base when you're going to do these changes and make them safe so that they're successful. So those things kind of come into play a lot, that the patient has been non-compliant as well. So we do have to let the physicians know that these things have taken place, and we try and correct them, and then we'll try again. Even like sometimes blister plaques come into play in confusion. Those kind of things happen for all of those reasons. But non-compliance can be a huge one, or a misunderstanding. It's not always non-compliance, right? That the patient took it wrong.
So on average, are they usually just monitored for the 90 days? Or do you have any that's...
we put that out there. We say an average of 90 days. We have some people who are monitored for 2 months. Some people are monitored for 6 to 8 months, depending on the situation. Those are our sicker patients that sometimes it takes you a second go around trying to titrate. So you don't want to give up, because for us, we know why they didn't tolerate the medication. And we think if we just kind of come back, correct that problem and try it again, because we want them at their maximum medication. We see improvement in EF. It's very satisfying when you follow them for 3 months and see the EF go from, 20, we have people at 10, and the next thing you know, like they're at 40 and
they're adding extra heart failure medications as far as GDMT, so that, now recently they've added SGLT2 for up titration, so it just extends that time
Yeah.
longer.
And then when the Entresto came, the same idea, right? There's just more to put on there. And the patients, when they tell you they feel better, like right away, you can tell when you're titrating them. And so that's very satisfying to know. So it's good for that. Thanks.
So much for giving us the rundown of what you guys do in that little room down the hall. Would you guys answer one more question in the chat? I missed it. Do your patients often come from community GPs or from hospital post-discharge?
So we do follow patients in the community, and there is equipment in outlying areas, and we do get referrals, and the equipment is given to the patient there. And again, with the transition, we're just switching that over, that we will be providing the equipment, but we will follow if a family doctor or hospitalist out there, and we've done it in the past, they refer to us. They can send us a fax. We will follow those patients as long, again, as we have an order from a physician that we can follow up with. And so many of our patients have been in the outlying communities. We actually follow quite a few in the Manchester area right now. I have quite a few out there, but they also are followed here at the Heart Institute and in that area as well. So we do double up on giving out the information to the patients. So for us, right now we're doing like the Ottawa Lynn area, and our hospitals that have equipment right now are that we're switching, but Winchester, Hawkesbury, Cornwall, Pembroke, Renfrew, and we have taken referrals from there. That equipment that they have presently is being phased out, and our new stuff's actually coming next week, and we will be processing how we'll be handing that out. But the referrals can still come from there. Yeah, it's helpful.
Thank you so much, Cynthia, and the cardiac virtual department. Much appreciated. I'm going to introduce our next speaker, Dr. Nina Ghosh. She is a cardiologist with expertise in cardiovascular MRI. Her research interest includes cardio-oncology, advanced heart disease, and heart failure. She divides her practice and expertise within the Ottawa region at the Maryville Cardiovascular Consultants, the Queensway Hospital, as well as here at the Heart Institute as well. So Dr. Ghosh will be sharing about imaging within heart failure and cardiac amyloid. So welcome, Dr. Ghosh.
Hi, everyone. Thank you for the opportunity to speak today, and thank you for sticking around on one of the few beautiful Friday afternoons we've had in a while. So I'm going to get right into the meat of things just because there's not a lot of time and it's a huge topic. The first part of the talk will be on imaging and heart failure in general. And the second part will be the role of imaging in cardiac amyloidosis. So the four imaging modalities I'll focus on are what are available to us in this region, including echo, nuclear imaging, cardiac MRI, and cardiac CT. So what is the utility of imaging in heart failure? It can help with the diagnosis, and I'll get more into that. There are prognostic markers in imaging, predicting response to treatment. So fortunately, we have help such as with a telehealth monitoring program to get people on the right doses of goal-directed medical therapy, device therapy, and response to specialized treatment in certain conditions. And so once they're started on treatment, imaging is important to help monitor response to treatment. So it's important to understand that imaging is generally not sufficient to diagnose clinical congestive heart failure or the state of decompensation or compensation of the patient. That relies on history and physical. So we have several imaging modalities available to us, all with their pros and cons, which I'll get into during the talk. And really, this slide is busy. It's not meant for you to read every word, but it's meant to show where echocardiography falls into the workup of heart failure. And once you have a clinical history, physical examination, certain basic tests like chest X-ray, metabolic parameters, all patients who have suspected heart failure should undergo echocardiography. And it can be used in conjunction with biomarkers such as BNP. But at one point, if you're suspecting heart failure, an echo is important. And accordingly, the CCS guidelines suggest that all patients who have suspected heart failure get an echo because it provides important information in cardiac structure, function, quantification of systolic function, and for planning and monitoring of treatment, and for prognostic stratification. In conjunction with ECG testing, history and physical, adding echocardiogram allows us to diagnose more of the common etiologies. And most importantly, it allows us to stratify patients into their categories based on ejection fraction. So in heart failure with reduced ejection fraction, as we know, is consistent with LVEF of less than 40%. Patients with mildly reduced ejection fraction or mid-range ejection fraction can have EF up to 49%. Patients with heart failure with preserved ejection fraction are defined by EFs of greater than 50%. And then we can define other issues such as anatomical problems related to congenital heart disease or pericardial disease that can cause heart failure-like symptoms. So why is echo so useful? Number one, it's low in cost, it's portable, widely available, and there's no radiation. And it allows us to assess the myocardium, the size of the myocardium, the thickness, and as I mentioned, the ejection fraction, valvular heart disease. And I feel like out of all the imaging modalities, echo still remains gold standard for valvular heart disease. It gives us hints as to whether it's an ischemic etiology because it allows us to look for segmental dysfunction. As I mentioned, abnormal anatomy consistent with congenital heart disease, pericardial disease, and different causes of left ventricular hypertrophy, including infiltrative heart disease and hypertension. It allows us also to assess diastolic function. So I'll just give you some provide some examples. I don't think the videos are working in the slideshow mode. So I'm wondering if I can get it off of the slideshow mode. Oh, maybe they are working. Okay. Oh, here we go. So this is an example of non-ischemic cardiomyopathy for those who aren't familiar with echo. This is a 4-chamber view, and the big chamber that I'm pointing to is I don't know if the cursor is the left ventricle, and what we see is the left ventricle is not moving well, and the walls are globally down. Here is a color image showing that the patient has, this is the mitral valve, mitral regurgitation, just a little bit, but that's likely related to the LV being dilated and functional mitral regurgitation. So I'll show you an example of how echo can identify clues to ischemic cardiomyopathy. So what we see here is segmental dysfunction. Sorry, there's a little bit of a lag between. Here we see that the LV, again, that's LV is severely down, but I don't know if you can appreciate that here, there's a segment that's kind of very thin walled and not really moving at all. That's an akinetic segment. And it's the inferior wall of the LV which goes along with RCA infarction. So that's a hint that this is an ischemic etiology. Here is a patient with preserved EF, but does anybody notice anything about the walls? Again, this is the left ventricle, something called the parasternal long axis view. And what you can glean here is the walls are quite thick, and the walls have a speckle type of appearance, and that's consistent with infiltrative heart disease. This is a person with normal EF, but you might notice this is the mitral valve, that one part of the mitral valve is going into this part of the heart, which it's not supposed to, which is the left atrium, and that's a flail mitral valve leaflet. And what you see here is that all this red stuff is the blood going back into the left atrium. That's severe mitral regurgitation, which we needed to diagnose with the echo. Here's another example of preserved EF, but what we see here, this is the aortic valve. It's supposed to be opening much more widely, and we see that it's not opening well at all, and that's severe aortic stenosis. And here are the Doppler measurements showing that the gradients are quite elevated. So you see that echo is the bread and butter and gives us the diagnoses where we need them. There are some advanced techniques that help us, but not all labs may have available to them. One is speckle tracking imaging, which allows us to detect certain types of systolic dysfunction even before there is a reduction in LVEF. And there are certain patterns of reduction in speckle tracking parameters that are specific to certain conditions. This is an example of a cherry on the top where it's red at the top, consistent with cardiac amyloidosis, where the apical contraction is preserved compared to the basal. There are some limitations to EF assessment with 2D assessment, and 3D echo can be a little bit more accurate than 2D LV assessment for LVEF. So once we have the echo and have identified more common etiologies, where do the other modalities fit in? So currently, the CCS guidelines suggest cardiac MRI can be used when echo imaging is not diagnostic, or to help elucidate less common etiologies. And why is echo so useful? MRI so useful in this regard? The images are quite high quality and can be taken in any imaging plane without making geometrical assumptions. So echo, as you can see, we were taking in certain planes, whereas MRI we can take in any plane. There's no ionizing radiation, and because of these attributes, it's the gold standard for assessing cardiac anatomy. It also has the unique capability of tissue characterization, and I'll explain to you what that means. Cons, of course, it's not cheap. It's contraindicated when there's MR unsafe metallic implants and devices. And in patients with advanced renal dysfunction, gadolinium-based agents, gadolinium is a contrast that's used, poses a small risk of nephrogenic systemic fibrosis, which is a severe skin condition. And the scan times can be quite long, 45 minutes. So if a patient is not compensated from a heart failure standpoint, lying for 45 minutes in a small tube may not be well tolerated. So MRI uses the ECG to gate the imaging. And so in patients with cardiac arrhythmias, which a lot of our heart failure patients have, the quality may be degraded severely. And of course, in patients with claustrophobia, they may not tolerate the procedure and may require pre-medication. But if you can get a patient into the tube, it can provide a lot of information and provide what we can refer to as a one-stop shop for structure, function, perfusion, and tissue characterization. And here's images speak 1,000 words. Sorry, I don't know where. And this is an echo MRI of a patient with Takotsubo cardiomyopathy. This is the LV, and what we see is that you can see the endocardial border very well. These are the long axis planes in this moving image. Sorry about that sound. I think I took this video with my kids in the background watching Dino Dan. And this is in the short axis plane. We can trace and contour the LV and the RV exactly how it looks without making some geometric assumptions about the shape. So it's high spatial resolution, low signal to noise, and no geometric assumptions. we can assess perfusion. So once in the first pass of the contrast infusion, what we see here is when the gadolinium is going in, we see a defect. That defect actually corresponds to reduction in perfusion during stress in the LED territory. So that's the anterior wall of the LV. What we see at stress, that there's a dark spot. At rest, there's no dark spot. And there's no scar when we look at the LGE. So that's an area of ischemia. And when compared to nuclear imaging, there's comparable diagnostic accuracy. I think tissue characterization, so actually assessing what the myocardium comprises in terms of tissue, is one of the unique strengths. So based on the physical characteristics of the hydrogen ions, we can get T1 weighted, T2 weighted imaging. That all sounds like a foreign language, but what it means is that based on what's in the myocardium, we can change the sequences to bring out the different aspects of the tissue. So T1 weighted images allows us to look at fat, gives us anatomical information. T2 weighted images in patients who have an acute inflammatory condition allows us to look for edema, so an acute infarct or myocarditis. After you, late gadolinium enhancement goes to areas of also inflammation, but also areas of scar. T1 mapping, so mapping techniques allow us to look at individual aspects of the myocardium even in the absence of gadolinium, and accounts for more diffuse disease, which might not allow us to see segmental issues diffusely. So this is an example of acute myocarditis. The T2 weighted images, remember I said, expose myocardial edema. So those bright spots that you see are the areas of acute inflammation. The bottom images correspond to late gadolinium enhancement, and in those same areas of inflammation, we see gadolinium enhancement. If you take it a few months later, the T2 weighted imaging should normalize, but there may be residual LGE corresponding to residual scar. I'm going to skip a few slides because I think I'm going to run out of time. So MRI is about pattern recognition. When we look at what we call late gadolinium enhancement, the patterns of late gadolinium enhancement give us hints as to what's going on. So if you have ischemic heart disease, because the subendocardium is affected first, that the pattern of LG in a subendocardial and then involving the whole wall is more characteristic of ischemic heart disease. But there are other conditions such as amyloidosis that may have subendocardial disease, but in less segmental patterns. In non-ischemic cardiomyopathy, you may have mid-wall involvement more so than subendocardial and RV insertion point. And in other conditions, you might have epicardial involvement, which is less characteristic of ischemic heart disease. Here is an example of ischemic heart disease. So the first image shows us inferior wall subendocardial enhancement consistent with an infarct in the RCA distribution, and subendocardial enhancement in the yellow arrow in the LAD territory, the anterior wall and apex, and that shows us LAD territory myocardial infarction. This is an interesting case. This is the LV, and it was thought because the LV function on echo was globally reduced, thought it was more likely to be a non-ischemic cardiomyopathy, but what MRI revealed is that there's a diffuse subendocardial pattern with thin walls, and the patient ended up having ischemic cardiomyopathy with severe triple vessel disease. So it can give information over and above what we've gleaned from echo. Here's an example of non-ischemic cardiomyopathy, and you can see that line in the middle of the wall. That's the typical linear mid-wall pattern. And this is an example of the utility of MRI in distinguishing different causes of LVH. So the top images, remember I mentioned that not very easy to see, but in cardiac amyloidosis, you may have diffuse transmural LGE, whereas in LVH related to hypertrophic cardiomyopathy, the bottom panel, you see where the arrows are pointing, where the scar is more in areas of greatest wall thickening or the RV insertion points. And myocardial viability is also a potential strength of MRI. So the more transmurality the LGE has, so greater than 50% transmural extent, is associated with a lesser likelihood of recovery post-revascularization theoretically speaking, but we won't get into utility of viability unless you have a specific question in this talk, because we're running out of time. How about nuclear imaging? So Ottawa is one of the world-renowned places for nuclear imaging, and we have all of these tests available to us, including SPECT and PET scan for ischemia testing, SPECT and PET scanning for viability testing. Nuclear imaging can be quite important for assessment of LV and RV systolic function, and nuclear imaging for inflammatory conditions can be instituted. So this is an example. So basically, when you're looking at nuclear imaging, this is the top row is a short axis slicing through the heart. You should see a whole donut. And here you see a bite and half of that donut missing. And when you look at the heart sideways, you see that there's only a line at the bottom. So the anterior wall, which is at the top, and the apex is missing. So in this heart failure patient, what we see is lack of perfusion, both at stress. So the top rows are rest and the bottom are stress. Both at stress and rest are gone, which means there's some sort of, it seems like there's a scar or an infarct in that territory. If you employ metabolic imaging with FDG PET, if you compare those the top section of the LED territory to the bottom two rows, which is the FDG row, you'll see that there's uptake, and FDG is a glucose analog, which will be taken up by viable myocardium. So that's an example where you think it's a scar based on SPECT, but there is viable tissue because it is taking up this radioactive glucose analog, and that's an example of FDG PET viability imaging. We often order a MUGA scan. I think, and when do you use it? A MUGA scan is basically a gated, an image that looks at the volume of the LV and the RV. And it's more accurate because it uses volume rather than the chamber area for LV and RV function, or potentially more accurate. And because it looks at this actual measurement, it's operator independent and reproducible rather than relying just on the observer. And it's a good alternative in patients who have poor echo windows. And it may be a good alternative to patients who may not tolerate a cardiac MRI, or in patients who have an arrhythmia. So this is an example of utility of inflammation imaging. So this is the use of FDG PET again. It's a glucose analog, but a different protocol than for viability imaging. So areas that are inflamed, such as granulomas and cardiac sarcoidosis, may be quite avid to FDG. So this is an example of patient with cardiac amyloidosis, and we see that there's a perfusion defect that corresponds to an area of granuloma. But when you look at the metabolism images, there's uptake of FDG, and that suggests that there's active inflammation in that area. And we use FDG sarcoid protocol to both diagnose cardiac sarcoidosis, but also to assess responsiveness to treatment. And what we see here is a patient who, sorry, sir. You can't see my cursor, that's the problem, right? The top panel on the left side, we see that the patient with active inflammation before steroid therapy, that went down quite a bit after steroid therapy in the bottom panel of the left image, sorry, of the right image. I won't get into much detail about cardiac CT, but it can have significant utility in heart failure, particularly in the evaluation of coronary disease. What we know in patients with low to intermediate risk of coronary disease, if you do just a calcium score without doing the actual angiography, a calcium score of 0 is associated with 100% specificity in multiple trials for excluding high-risk anatomy, such as left main stenosis or stenosis in 2 or more major arteries. It can have utility in looking at LV mass and valvular heart disease, but not the main modality we go to. So that was part one. Part two, I'll be as brief as possible. But I think, I don't know how many people who's seen a case of cardiac amyloidosis before. Who knows what that is? Can raise your hand, yes or no? So it's more common than we think. Basically, amyloid proteins and amyloidosis is a group of heterogeneous disorders in which misfolded proteins assemble and they deposit into the myocardium. There are many different types of amyloid type of proteins, but the two main precursor proteins that lead to cardiac amyloidosis are immunoglobulin light chains, which are seen in plasma cell dyscrasias, such as multiple myeloma, or a liver-derived transport protein called TTR, which when it turns into the amyloid configuration is called ATTR. And on tissue biopsy, the classic finding is this apple green birefringence. I'm going to skip this, but there's a very useful document that was that came out in 2020 that was quite helpful and informative that you can go to that looks at how you can diagnose and evaluate these patients and treat them. When do you order imaging in cardiac amyloidosis? Well, first you have to suspect cardiac amyloidosis, and there are certain features that make us quite suspicious. Heart failure, of course, atrial fibrillation, but in our patient population, many do. But atrial fibrillation, that's slow, so patients who have concomitant conduction system disease, and aortic stenosis with low flow and low gradient. That might alert you to this entity. And also look at extracardiac hints. So in a patient, elderly, who has peripheral sensory motor neuropathies, such as a dysautonomia, severe orthostatic hypotension, carpal tunnel syndrome, or lumbar spinal stenosis, may be at risk. So the 4 imaging modalities we use include echocardiography, cardiac MRI, and something called technetium pyrophosphate nuclear scans. So patient with heart failure, you suspect they might have infiltrative cardiomyopathy. You do an echo, but also do the monoclonal gammopathy testing. I'll get into that. And here what we see is, I showed you another example of the echo showing increased LV wall thickness. LVH greater than 1.2, they'll have small LV cavity size, biatrial enlargement, thickened valves, thickened intraatrial septum, but they also may have pericardial effusion, restrictive filling, although that may be a late finding, and then on speckle tracking imaging, that cherry on top finding that we talked about. And a statement from in JNC also shows that there are certain criteria that are strongly suggestive. I won't get into the nitty gritty since you don't read, some of you may not read echoes. The next modality that may be quite useful is cardiac MRI. And because we've gone through the background of what MRI can offer, as you can imagine, morphologically, you may see the similar findings as in echo on MRI on the cine images, with a thick wall, small LV cavity. But what MRI allows us to see is that typical late gadolinium pattern. Sometimes it's so diffuse you may not even see significant segmental LGE, and that's when mapping may be important. So native T1 mapping is something that we can utilize in patients with advanced renal dysfunction. And what we see are quite high values in these patients. And because the amyloid protein infiltration is associated with increased extracellular volume in the myocardium, when we look at that index of extracellular volume, it's quite high compared to other causes of LVH, such as hypertensive heart disease or even hypertrophic cardiomyopathy. Can a cardiac MRI allow us to distinguish between AL and TTR amyloid? There are some subtle findings, but it's not sufficient, and neither is echo. And why do we need to distinguish between TTR amyloidosis and AL? It's mainly because the treatment differs significantly. So as I mentioned, AL amyloidosis is related to abnormal proteins made in the bone marrow. And so that treatment would involve treating whatever underlying bone marrow condition with chemotherapeutic agents, whereas TTR amyloidosis is a specific treatment called tafamidis that targets the the transthyretin protein. So what imaging modality can we use to distinguish between the two? And this is where bone-seeking agent, nuclear agents, and the one that we have in Ottawa is technetium pyrophosphate can be quite useful. So what we found is that myocardial imaging with technetium pyrophosphate is highly sensitive to diagnosed TTR amyloidosis. And here's an example of a scan. So basically those arrows are pointing to the heart. It's not a very clear image, but what we see that is in the grade 2 and 3 section, there's uptake quite a bit more related relative to the rib uptake. And that's what signals that there may be cardiac amyloidosis and specifically TTR related cardiac amyloidosis. So how can we use technetium pyrophosphate imaging to potentially bypass the need, importantly, for tissue diagnosis? Because we want to avoid or spare patients of needing a heart biopsy as much as possible, as you can imagine. So if you do have grade 2 to 3 uptake, you still need to make sure the patient does not have free light chains or some sort of gammopathy by doing SPEP, UPEP, immunofixation, and light chain. If they have none of those, then you can assume that their amyloidosis is due to TTR, referring them to an amyloid clinic that may be able to offer tafamidis and to send them for genetic testing if needed. But if you do have evidence of a gammopathy, then you may need to do tissue biopsy or refer them on to a hematologist or amyloid amyloid clinic to distinguish between the two. So generally, in the presence of grade 2 or 3 positive technetium pyrophosphate scanning without evidence of monoclonal proteins in the blood or urine, you can make the diagnosis without needing a biopsy. I won't get into the role of cardiac CT or PET because currently we're not using it clinically, but there's a lot of potential, and I'm running out of time, so I'll skip all of these slides and just kind of highlight some of the take-home points. So as you see, imaging is a very important tool in many aspects of heart failure, but it should not be relied upon to diagnose congestion or the patient's state of decompensation or compensation that requires a history in the physical. Echocardiography is the backbone of heart failure imaging, and all patients with suspected heart failure should get an echo. If there's any missing information, you could consider CMR because it provides excellent structural, functional information and allows for tissue characterization. And nuclear imaging can be an important tool for assessing multitude of aspects of heart failure, including ischemia, viability, and inflammatory conditions such as cardiac sarcoidosis, and infiltrative conditions such as cardiac amyloidosis. Cardiac amyloidosis is something that should be suspected, and you need a high index of suspicion in patients with heart failure and preserved EF if they have unexplained LV wall thickness, if they have carpal tunnel syndrome, which can sometimes precede the cardiac involvement by years, patients with low flow, low gradient aortic stenosis, or patients who have concomitant plasma cell dyscrasia. And we talked about some of the echo features, cardiac MRI features, and the role of PYP technetium scanning in these patients. And that's it. Thank you. And sorry about the long presentation. I didn't go too much over. Happy to accept questions.
Are there any questions for Dr. Ghosh? Feel free to just raise your hand. If not, I have a question for you, Dr. Ghosh. In the workup of ischemic etiology of heart failure, what would influence your choice of going directly to cardiac catheterization versus non-invasive modality for imaging?
That's an excellent question. And I think as cardiologists or internists, we face this conundrum. Severe LV dysfunction, does the patient need cath? I think, and guidelines also recommend that in a patient with angina, symptoms suggestive of coronary disease, then cardiac catheterization is recommended. In patients who are high pretest probability due to their risk factors, then it would be reasonable. Sometimes we use both cardiac catheterization. So if the patient has high risk anatomy, we may decide on revascularization based on nuclear stress testing and the presence of ischemia, plus minus viability, but again, viability may or may not be important. So I think in patients who are high pretest probability, and definitely those patients who have angina type symptoms and there are no contraindications, I would have low threshold to move on to cath.
And then one last question. If both echo and cardiac MRI are highly suggestive of cardiac amyloidosis, is there any utility to proceeding with the pyrophosphate scan that you were talking about?
Yeah, so as I mentioned, both echocardiogram isn't that helpful in distinguishing. MRI can differentiate a few features, but the pyrophosphate imaging is much more specific, sensitive to TTR amyloidosis. But to reiterate again, even patients who have AL amyloid may have uptake. And so I think to distinguish, particularly in patients who have negative proteins, negative immune chain testing, but probably most patients with suspected amyloidosis without clear AL amyloid should get the scan if possible, or if it'll change management. Thank you.
Our next speaker is going to be Dr. Lisa Melnichuk, but unfortunately she hasn't arrived back yet. She was to come in a couple of minutes. So if we can just hang on, we'll get started with her. You have break after Dr. Melnichuk's presentation around 2:30, 2:45. Sorry, she snuck in. So I just want to introduce Dr. Melnichuk. She is an associate professor of medicine at the University of Ottawa and a cardiologist and clinical investigator at the University of Ottawa Heart Institute. She is currently the director of our heart failure program and medical director of the Pulmonary Hypertension Clinic. Dr. Melnichuk also co-leads the Ottawa Region Strategic Research Innovation Cluster on heart failure, and she will be discussing options in heart failure therapy with us today.
All right. Sorry, I'm a little bit late. I'm on service, so you know how that unpredictable that goes. So here are my disclosures. I have the pleasure of talking this afternoon about the real world of heart failure management and what to do when guidelines let us down. So I'm going to talk a little bit about foundational therapy and why foundational therapy doesn't always work. I'm going to talk a little bit about some tricks to help us to address that, and talk a little bit more about what to do next when we've done everything we can and our patients are still symptomatic. As a way of introduction, we all understand this to be true from our 2021 guidelines and from anyone who's done clinical practice in heart failure with reduced ejection fraction. These are really the cornerstones of management and what I explain to my new heart failure patients, the most important treatment management decisions that we're going to make. And the evidence supports that, right? If you go from being on no therapy to being on these 4 cornerstone therapies, your two-year mortality can be cut, by 70% with substantial improvements in your morbidity. And we can look at this in many different ways. And there was a really nice systematic review done out of Boston a couple of years ago that did comparative analysis. And so what they did is they looked at your event-free survival if you were on traditional therapy with beta blockers and RAS inhibitor therapy, and they compared it to your event-free survival if you were on those 4 cornerstone therapies. And you can see from the graphs that your life saved is actually quite substantial. So compared to what we would have thought to be good heart failure therapy 10 years ago, With the four cornerstones in therapy, you can improve, if you're a 55-year-old patient, improve your overall survival by 6 years and your event-free survival, so death or hospitalization, by 8 years. And even as we get up into our 7th and 8th decade of life, you can see significant improvement measured in years for most patients. And lots of work has been done to try to understand this, and different combinations of medications looked at to see the predictive benefit with respect to mortality. And you can see that, at the top in terms of hazard ratio or reduction in hazard ratio are these four cornerstone therapies. And so any way you look at it, this is really the next generation of heart failure management. But as Louis Litt likes to say in one of my favorite shows, sometimes good isn't good enough. And we all see this in heart failure treatment. I look after heart failure patients all the time, and many times when I see new heart failure patients, they are not on those 4 cornerstone drugs, or maybe they're on them, but they're on them at very low doses. And this registry of heart failure patients in the United States showed that less than 1% of patients were actually on the top doses of all 4 therapies. And you can see from the numbers on the table there, the majority of patients who don't have obvious contraindications are actually not on some of these therapies. And this has been shown in other ways too. This is a study looking at patients enrolled in GUIDED, basically a management trial for heart failure patients. And patients enrolled in this trial were looked after by heart failure physicians like myself, people who should have good experience with this. And you can see, in fact, that many patients were not on optimal goal-directed medical therapy. And when they asked the investigators why, you see a smattering of results, including, well, patients don't tolerate it, or I thought they were doing okay. So there's really a gap there. And even my friend, Dr. Annick Ducharme from Montreal, did a study in her own clinic, and she looked to see and saw that even in her own clinic, if you look at the sort of 4 arms of foundational therapy and newer drugs like ivabradine, anywhere from 10 to 40 or 50% of patients were undertreated. And this was after she looked at all the reasons why these patients may not be treated. And so we all have to do this every day when we see our heart failure patients. We have to weigh the risks and the benefits of changing therapy. Now, I've already told you about the benefits, right? We're going to help our patients feel better and live longer. But it doesn't come without a cost. And intolerance to these drugs are not small. And although we love to sort of portray the average 55-year-old HFrEF healthy patient getting on 4 drugs, and those are really fun patients to treat, the reality is that the average HFrEF patient is probably in their 7th or 8th decade. And they have comorbidities, and they have frailty, and they have things that are really going to complicate our ability to use these treatments. This is one of my favorite studies that showed just how real this problem is. And this, in fact, was a compilation of 3 international registries in the UK, the US, and in Sweden. And what they looked at is they took treatment-naive heart failure patients who had never been exposed to these drugs. They were put on the therapies in hospital, and they followed them over a year to say what happened. And it's a bit of a busy slide, but I'll call your attention to a few things. In green are the percentage of patients that stop the treatment at 1 year. In red are the percentage of patients that stop the treatment at 1 year. And so you can see things like MRA, 40% of people stopped it at 1 year. 27% of people stopped the ARNI. A substantial number of people stopped other medications. So we know that this is a problem. And some people have tried to understand it further. And this was a really nice study that looked at potential eligibility in a heart failure clinic. And they used SGLT2 inhibitors as an example. And they looked at their whole patient population and then their HFrEF patient population. Because at the time the study was done, we were only using SGLT2s in HFrEF patients. And they looked at all the reasons why patients may not be able to be on these medications. And at the end of it, they said, well, in fact, just over half of their patients would actually be eligible for SGLT2 inhibitor use. And this study out of Japan did the same thing. They looked at their HFrEF cohort, and they said that actually, if you use the data of inclusion from Paradigm and DAPA, so an ARNI and SGLT2 study, only 62% of patients would be eligible for those drugs. So again, we're seeing this 30 to 50% patient population that can't get on these cornerstone therapies, these ones that we've already said are so important. So why is that, and what are we going to do about it? Well, let's talk about the two most common reasons our patients can't get on cornerstone therapy. And you and me and everyone else hate hyperkalemia, right? This is one of my biggest struggles in my HFrEF patients. And just like you, hyperkalemia is not uncommon. We see it in HFpEF and we see it in HFrEF. And depending on how you define the potassium problem, the incidence can be anywhere from 10 to 25%. We see this in men, older men. We obviously see it in reduced renal function, and we clearly see it in patients who are on cornerstone foundational HFrEF therapy. And we also know this to be true, right? Not only is hyperkalemia a problem for us because we have to manage it, but it's also a problem for the patient. And there's a very nice U-shaped curve in terms of relationship between outcome and potassium, such that if your potassium is less than 3, you are not going to do very well, right? Hypokalemia is just as bad as hyperkalemia. And if your potassium gets over that sort of 5.56 mark, whether you look at it from clinical trials or whether you look at it in registries such as the Swedish Heart Failure Registry, higher potassium is a marker of worse prognosis. So how do we resolve that when the drugs that we need to use are so important for heart failure and cause hyperkalemia? Now, this was a study from Emphasis, which was an MRA, a eplerenone treatment in heart failure patients with ischemic heart disease. And you can see that there's no doubt in your mind, right? The patients on the MRA had much more hyperkalemia than the patients who didn't get the therapy. However, over here are all the risk factors for hyperkalemia. And you can see that in any of these cohorts, if you were on eplerenone, you did better than if you weren't on eplerenone. And this is an important message, right? What this suggests is, yes, we have to be aware of hyperkalemia, but just because they're at risk for it doesn't mean we shouldn't try introducing the therapy when the benefits are well documented. And the same exact thing was seen from rails. You've probably seen this really nice slide before that looks at relationship between outcome and potassium. And you can see that at almost any level of potassium, patients who got on spironolactone did better than patients who were on placebo. Where is the point of diminishing returns? Well, it's probably around a potassium of 6. If you get up that high, then your mortality is actually worse than if you weren't on the spironolactone. Now, I get this question asked all the time. My patients got hyperkalemia on an ARNI. Should I switch them over to an ACE inhibitor? And in fact, that's the opposite answer. If you look at sub-study analysis from the Paradigm study, you can see that, in fact, it was patients on the ACE inhibitor that had more hyperkalemia than patients on the ARNI. And when you look at the comparison of MRA therapy plus either ARNI or ACE inhibitor, the cohort with the highest potassium was the MRA and ACE inhibitor arm. And the yellow arms are the group that were on the ARNI, and they had much less hyperkalemia. What about SGLT2 inhibitors? Do those cause hyperkalemia? They don't. So if you've got a patient who's really predisposed to hyperkalemia, and you're not yet sure what to do, think of the SGLT2 inhibitor. Push that one up ahead in your therapy plan because they don't cause hyperkalemia. So how do I address all of this? Well, I'm not going to talk a little about hypokalemia, but happy to address questions. But really the question is, what do I do when the potassium level is high? The first thing I do is I really try to have the patients follow a low potassium diet. I really do try that. That's not easy, but I try. I reduce the spironolactone or the eplerenone when I need to keep their potassium below 5. And if that still doesn't work and they're on a RAS inhibitor, that would be a reason to switch to an ARNI. Now, if their potassium goes much above 5.5, I stop the ARNI or the RAS inhibitor, unfortunately. As most of us know, there are some really new exciting potassium binders on the field right now, much safer than SPS or Kxalate, which is what we used in the past. And there certainly may be a role for these new potassium binders to help to treat potassium issues and keep us on GDMT. And there's a clinical trial ongoing right now that's looking at that exact same strategy. So let's talk about my second biggest bee in my bonnet when I'm titrating GDMT, and that's low blood pressure. And we all know that the more advanced our heart failure patients are, the more likely they are to have very little blood pressure to work with. And so how do we decide how to get them on those 4 pillars when they don't have any blood pressure to work with? Well, we know this to be true as well. Just like with potassium, there is a U-shaped curve with blood pressure. The lower your blood pressure is, if you have heart failure, particularly if you have severe or very dilated ventricles, the worse your prognosis is. And if you've got HFrEF, this was a nice study that looked at just ambulatory blood pressure in a HFrEF patient population. In fact, there was an increase in outcome or a reduction in mortality for every 10 millimeter mercury systolic blood pressure increase. So the higher the blood pressure, the better the outcomes. That only holds true in our HFrEF patient population. So how are we going to do this? We're going to put patients on drugs that are going to lower their blood pressure, and low blood pressure is a problem. And this is not a small problem. We saw, this is data from the Paradigm study that looked at the relationship between blood pressure and outcome in patients randomized either to ARNI or to enalapril. And in fact, just like the potassium story, for most people, regardless of your blood pressure, you did better on the ARNI than the ACE inhibitor, right? The data is very consistent. However, you had more hypotension on the ARNI. And just to give you a sense, if you look down here, patients, the percentage of patients that had to either stop or discontinue the drug, when they had a blood pressure of less than 110, this is really hard to see, the rate of discontinuation there was 20%. I think that's probably pretty close to real world, right? And this was in the context of a clinical trial, that if you're starting with a blood pressure of 110 or less, you got to be prepared that there's about a 20 or 30% chance that patients aren't going to tolerate it. Does it mean not to try? No, just means be prepared. Well, what about SGLT2 inhibitors? Let's go back to them again. They don't cause hypokalemia or hyperkalemia, but do they cause hypotension? And in fact, they don't. If you look at all the trials that have looked at SGLT2 inhibitors recently, the average drop in systolic blood pressure is about 1 millimeter of mercury. Now, they certainly can cause hypotension if you have a volume depletion event, right? But that's not really the same thing. If you're explaining sick day management to your patients and helping them to understand them well, they shouldn't get hypotensive without significant effect, but the drug is well tolerated otherwise. So how do I address low blood pressure and heart failure when I'm trying to titrate up GDMT? The first thing I ask myself is, are they symptomatic, right? Because patients will come in and they'll say, my blood pressure was 90 and I'm really worried that's too low, so I didn't take my medication. Well, I'm not worried about a blood pressure of 90 if my patients aren't symptomatic. But if they are symptomatic, I look at their medications. I stop everything that I can possibly stop that's not actually contributing to improvements in outcome for heart failure. And sometimes you'd be surprised that there's quite a few things that we can actually stop and give the patients back a little blood pressure. If I'm still struggling with low blood pressure, unfortunately, sometimes I have to switch the ARNI to an ACE inhibitor. And the data shows that low-dose ACE inhibitor is less likely to cause hypotension. But the trade-off there is the benefit you lose from the ARNI. If I'm really stuck with blood pressure, I use drugs that really don't affect blood pressure. So I optimize my SGLT2 inhibitor use. MRA therapy can cause hypotension, but at low doses, I tend to get by with it. And then I try to do tricky things, right? I try to give the drugs once a day at night. I try not to give 2 drugs at once. I sometimes move within different classes to look at tolerance. So there's, little things you can try to help to get those medications on board. So we've talked a little bit about why we can't use this medical therapy, but let's talk about what happens if we've used this medical therapy and we still have problems. And this is just a summary of some recent contemporary heart failure trials in the literature. And what you can see is the event rates in standard care versus patients enrolled into the active treatment at 1 year. And so even when patients are on foundational therapy, the residual risk is high, right? We're talking about lower risk studies like Paradigm to higher risk inpatient studies like Soloist or Affirm that have anywhere from 15 to 40% repeat heart failure hospitalization or death in 1 year. And so we know that heart failure is a very high-risk condition, and everyone is quite familiar with the 2021 guidelines that talk about foundational therapy. And so what I'd like to do in the next few minutes is talk about what do we do after you've laid the foundation, right? That's the second row on this guideline, and I tell people this is what I call the personalization phase, where I look at things and I personalize additional drugs to different phenotypes. So one important phenotype is the phenotype of worsening heart failure. And we all see this in our clinical patients. And we all know that heart failure begets heart failure. And there's good data to suggest not only does your mortality increase with subsequent hospitalizations, but even just the days you're out of hospital decrease with every hospitalization you get. And worsening heart failure can be can be thought of in many ways. It can be thought of as an admission to hospital, clearly. But even a trip to the rapid intervention clinic would be worsening heart failure. Even just outpatient escalation in diuretics can be considered worsening heart failure. And so this is a very vulnerable time for our patients where their risks are very high. And however you define worsening heart failure, whether it's intensifying therapy, going to the ER, or being admitted, you can see, and this is data from Paradigm, that there's an increased risk of cardiac events in the next 1 year. And so there was a trial called Victoria that looked at these high-risk patients with worsening heart failure and randomized them to either standard care or standard care plus vericiguat, a novel drug in heart failure therapy that is an SGC stimulator, helps to increase bioavailability of SGC and nitric oxide. And it has a number of physiological favorable effects, but also had a significant reduction in the primary endpoint of heart failure hospitalization or death. Now, the drug is for use in the United States, and it's likely to be available shortly in Canada as well. And however you defined your heart failure hospitalization event, whether it was an admission or even outpatient worsening, vericiguat had an effect. So very profound data. Another thing that can be used to personalize therapy after laying the foundation is heart rate. And we all understand how important heart rate is to prognosis. Not only is it likely a risk marker of a patient who's going to do worse, but it also has pathophysiologic effects that are negative for the heart as well. And we know from the SHIFT trial done many years ago now that compared to standard care with placebo, ivabradine had a significant reduction in heart failure hospitalization. We also know that if your heart rate is very high, above 77, the drug can actually improve your mortality and have an even more substantial impact on your rate of hospitalization. But it also helps patients feel better. So it's a really good drug to use. And multiple subsequent systematic reviews with pooled outcome estimates said, yeah, actually, guys, this drug works. People feel better, they stay out of hospital, and it drops their heart rate. You can see there's no doubt that it does what it does, with a trend, as I said, in all comers of improving mortality, but a clear signal for reducing heart failure hospitalization. But just like some of the other drugs we saw, the real world uptake of this drug is not very high either. And in fact, this was a study done out of Toronto by my friend, Dr. Gordon Moe, and he looked at academic and community hospitals and said that if you break it down, in fact, only 8 to 10% of patients are actually eligible for ivabradine. That being said, I still think that this is an important gap in care for our heart failure patients who have higher heart rates, and I encourage you to consider its use. Just for time, I'm going to skip ahead to talk about another drug in our box to consider in personalizing therapy after foundation, and that's digoxin. Now, digoxin really is, there's no more interesting debate about digoxin than in heart failure, right? You can look at studies that say digoxin's a great drug, it's going to help you feel better, and you can look at studies that are going to say digoxin's a terrible drug, it's going to kill you. And so where do we sit on this drug? One thing we do know is that people are using less and less digoxin over time. And this was a really nice study that showed over a span of about 10 years, the use of digoxin in HFrEF patients has decreased significantly, regardless of sex or age. The use is still greater in patients with atrial fibrillation compared to sinus rhythm. And this was a Swedish heart failure data that showed, you can't see this, but there are a number of predictors of the use of digoxin in HFrEF, and not surprisingly, high on that predictor is the presence of atrial fibrillation. So does atrial fibrillation in HFrEF actually respond to digoxin therapy? And so this came from the Swedish Heart Failure Registry, and on the top are the AF patients, in the bottom are the non-AF patients. And what you saw was an important treatment interaction. If you did not have atrial fibrillation, you had no benefit from digoxin. And in fact, there was a suggestion that your risk was even greater with the use of digoxin, even after adjustment for things that increase our risk. If you had atrial fibrillation in an unadjusted way, digoxin probably helped you stay out of hospital and maybe helped you with cardiovascular mortality, but it wasn't significant after you adjust for all the reasons why we put people on digoxin. So I still think there's a role for digoxin in HFrEF, but I would reserve it for my atrial fib patients. And I'm going to skip ahead to one last combination of therapies that we can choose in our bag of tricks for our HFrEF patients, and that's the hydralazine nitrate combination. Now, we know from very old studies like VHEFT, which looked at the role of RAS inhibition in heart failure, most of these patients were on ACE inhibitors, but patients who were Black, who were then also put on isotyl hydralazine, had a very significant treatment effect in terms of survival, something that wasn't seen in patients who were white. And in this followed by another trial called the AHEF trial, which had a combination hydralazine nitrate pill. 97% of these patients were on RAS inhibition. And you can see a very substantial improvement in survival in patients. All these patients were African American, and a substantial improvement in survival and hospitalization with the use of this combination. So this is a very important consideration in HFrEF patients, particularly who are Black. And yet, despite that, again, we see this lack of uptake of a potentially very good therapy. If you look at Black patients who were eligible for the therapy, very few of them were on it. And the patients being able to tolerate high dose was very, very low, 2%. And similarly, if not greater, in the non-Black population. Now, I'm not surprised at this at all. Yes, this is a great option for our HFrEF patients, but if you go back and look at the studies and see what kind of doses of vasodilator therapy the patients had to be on in these clinical trials, they were enormous, very, very high. And so for that reason, I'm not at all surprised that patients can't tolerate it. And then the last thing I'm just going to mention, and my friend Dr. McGinty is going to talk to you about this further, but when you have a HFrEF patient and you're stuck, you can't get them on RAS inhibitor therapy because of their potassium. You're pulling off all of the important heart failure foundational therapy because of your blood pressure. You've got a sick patient. You've got a patient who's not going to do very well in the next 6 months to 1 year. And so they're transitioning to what we call advanced or end stage disease. And what do we do then? And I'm going to leave that for Dr. McGinty to talk about very soon. So what do I recommend? How do we put it all together when we're titrating GDMT? We have to personalize it, right? Precision-based medicine is critical. And so there are different ways we can do this. If we think the patient is worsening clinically, we want to optimize their treatment, and maybe vericiguat is going to be an option. If we think that their heart rate is high and they're in sinus rhythm, I encourage you to use things like ivabradine. I still think there's a role for digoxin, and I haven't even talked about device therapy like resynchronization, but absolutely in the right patient, this is a good choice. But I think it's always important in the real world to take a step back. If they come to you and they say they haven't been able to tolerate those 4 drugs, maybe that's true, but always ask yourself, is there still room to try or try again? Ask yourself if they're a candidate for advanced therapies, if they really are starting to progress down that slide of end-stage heart failure, and ask patients what's meaningful for them. What do they want? Because sometimes in end-stage heart failure, these foundations are actually not consistent with the patient's goals of care. And they would much rather feel better and be on less therapy than feel worse and burdened by the symptoms of these drugs to have what would likely be for them not a substantial improvement in mortality. So in summary, key things to remember today is that the care gaps exist. We see it in all levels of heart failure management. And ask yourself, have I done everything I can to optimize heart failure therapy? Recognizing underuse exists. You can think of some of the pearls I've tried to share with you today about hyperkalemia and hypotension. And really, most importantly, I think if you've tried and tried and tried again and you're still not getting anywhere, goals of care is a very important discussion and thinking of advanced therapies. And that's going to be my segue to Dr. McGinty's presentation later this afternoon. So thanks very much and happy to take questions.
Thank you so much, Dr. Milchuk. Does anybody have any questions in the audience?
Thank you. You mentioned the heart rate has an important effect on heart failure. How do you vary heart rates?
How do I vary heart
Yeah,
rate?
can you vary heart rates in order to, you're saying increase heart rate? Is it?
Yeah. So if I understand the question, I generally don't increase heart rate. Is that what you're, I'm not sure I follow the
How
question.
do you increase it? Can you actually vary the heart rate?
Yeah, so a drug like ivabradine, by inhibiting the sinus node, will reduce the heart rate, and it can reduce the heart rate quite significantly, 6 to 10 beats per minute. And so it is a very effective drug and certainly indicated for use in patients who have a resting heart rate over 75. So we bring down the heart rate. I typically don't bring up the heart rate. That's generally not advisable. It is part of how we maintain compensation for sure. I think the one trick about heart rate is that there is a risk in reducing heart rate too much, particularly in the acute setting. And we certainly see this not infrequently at all with a patient with decompensated heart failure who is made worse by rapid escalation of beta blockers because their heart rate is too high. That patient requires their heart rate, of course, to maintain compensation and to maintain cardiac output when they've got limited stroke volume. So that's a very unique situation where I let the heart rate ride high until I can stabilize them. But in general, the recommendation is as best as we can. We do know that patients who can maintain stability at lower heart rates would generally do better.
Yeah. This leads to the some sort of hypothetical thought that I have.
Yeah.
Your atrial fibrillation could be caused by low heart rate also. Now here, I'm speaking hypothetically now that we're now emphasizing on drugs. Why don't we think about devices? And devices doesn't have too much side effect, and it can effectively alter the heart rate, such as a pacemaker.
Yeah, no, it's a great consideration. It's particularly in my line of work in patients with pulmonary hypertension who have RV dysfunction. They are very sensitive to low heart rate and tend to do better when their heart rates are a little bit higher. So I think there are certain phenotypes or examples where I think pacemaking would definitely be of benefit to protect from bradycardia for one reason or another, outside of the other sort of routine or standard indications for pacemakers. I think it's a very important point.
So in the current practice, what percentage of the patient with heart failure is recommended for pacemaker implantation?
In heart failure literature?
Well, in your practice of treating heart failure patients.
Oh, I mean, it depends on the indication, right? So I guess there are the obvious indications of, complete heart block, syncope, distal conduction disease, all of those things that would give indications for pacemakers. There's indications for cardiac resynchronization, indications for defibrillators. But outside of all of those indications, which are clearly evidence-based, do I refer people for pacemakers without indication? I have occasionally, particularly in patients in whom I'm unable to get them on beta blocker therapy because they have a history of bradycardia. So if their EF is somewhat borderline and I think they're going to be a candidate for a defibrillator anyway, I might refer them earlier on for a pacemaker. Or if they're a candidate for a CRT, I might refer them on early on so I have that protective effect of the pacemaker. Doesn't happen very often, but yes, certainly.
Thank you.
I do have one question in the chat. It's kind of a statement and a question. Sometimes I worry that starting one of the big four, like an ACE or a Spiro, will drop the creatinine clearance or GFR low enough that other parts won't be eligible.
Yep.
Which one of the big four are most important?
Yeah, that's such a great question. And I stayed away from it today because there's so many ways you can do this. I can only give you my sort of 2 cents worth. I personalize the therapy to the patient's clinical situation. So if they're a little bit decompensated or their hemodynamic status is of any question at all, I will tell you right away, the beta blocker is the last drug I add. I add it way at the end when they're good and ambulatory. The first drugs I typically start, if I don't have a lot of blood pressure to use, would be drugs, like I said, that aren't going to affect blood pressure. So SGLT2 inhibitors or MRA therapy. You're going to get some diuretic effect. You're not going to get a hypotensive effect. So the question though was, what do you do when your GFR is like 30 to 40? Where are you going to start? There's really no good answer, right? Because you know the SGLT2 inhibitors are going to get a hit to your GFR, but it's a transient hit. It will recover. So you have to be careful of that. I typically would start RAS inhibition therapy first. I follow their creatinine very, very closely. The incidence of acute kidney injury with RAS inhibition is the same as with ARNI. There's no suggestion that one is worse than the other, but you start what you feel most comfortable with and follow their creatinine very, very closely. If you can keep their GFR above 30, they don't develop significant AKI, then I'm a mixer, so I'll add in a little bit of MRA therapy as opposed to going up on the RAS inhibitor therapy. So I'd rather see my patient on low doses of all 4 therapies than get them on moderate or high doses of the RAS inhibitor or the ARNI, and now their potassium is 5, their GFR is 30, and I'm stuck. I can't go further. So that would be my recommendation for that. But that's those are tough situations.
2 questions actually. The first one being that with spironolactone, we can get into problems with hyperkalemia. And is it okay to try the non-steroidal MRA for that?
Yeah.
It seems to be less.
Yeah, it's a great question. It hasn't ever been studied in heart failure patients. So I from an evidence-based perspective, I don't know that it would have the same effect as spironolactone. That being said, we use a lot of spironolactone, with only one study done many, many, many years ago in patients who were barely on any heart failure therapy. So I think if that's all you have, that's reasonable. Now, I will put a sort of the suggestion out there that your comment is a very good one, because there's a new non-steroidal MRA that's called finerenone, and finerenone is being used in renal disease and it's being used in hypertension, and there are limited studies in heart failure, but it's a great one because it causes much less hyperkalemia. So when we start to get more experience with that in heart failure, I suspect that would be a very good way to go.
And the second question, this may have been from Dr. Gosh's presentation, was that there was a number of fundamental tests that one should do, with ECG and echo and so on and so forth, and some lab work, which was CBC, electrolytes, creatinine, and ferritin. Why the ferritin?
Presumably the ferritin, I guess 2 reasons I could suggest. One is screening for hemochromatosis if they have iron overload, which is not very, very common, but that would be one. And then the other, and I don't know, I missed Dr. Gosh's presentation, but from a diagnostic perspective, hemochromatosis would rise to the top of my list. From a therapeutic standpoint, we do know that patients with iron deficiency anemia are, when given iron supplementation, have an improvement in their quality of life. So it is a new target of treatment that we're addressing more. So I think there are two good reasons to consider it.
Okay, is there any other questions in the audience? Well, then I think it's a good time for a break. We're going to take a 15-minute break. So we'll be back here, I guess, just before 3. There are refreshment stacks for the afternoon break as well. Chemistry at McGill with research on the effects of dietary lipids on the neurohormonal regulator of body weight. She then studied medicine at University of Ottawa, doing her residency and fellowship in internal medicine, focusing on cardiometabolic medicine. Dr. Heshka currently works at the Ottawa Cardiovascular Centre, where she runs the Heart Failure Optimization Clinic and practices general cardiology and cardiac risk management in high-risk patients, including diabetics. She is heavily involved in education in the community and with the University of Ottawa residents, and loves working towards optimizing cardiac care in the community, in particular bridging hospital-based and community care on all levels. So we welcome Dr. Heshka this afternoon.
Okay, thank you very much for the introduction and thank you for having me. I was thinking about what I could bring to the discussion today, because I know you're getting lots and lots of amazing information from your expert cardiologists here on heart failure management. And so I thought, well, you don't really need me to talk about heart failure per se. So what can I add? And so I thought, well, I can maybe hopefully encourage you or show you how you can potentially rethink diabetes management. So what we're going to talk about today, I'm going to briefly, because we don't have a lot of time and this is a big subject, we're going to briefly review the epidemiology and pathophysiology of diabetes and heart failure. I'll touch on the current guidelines and what information is available to help us manage these patients. We'll look at the medical management of diabetes, but I really want to focus more on some practical aspects of diabetes management rather than heart failure management per se. Dr. Melnichuk just gave you an amazing talk on that already. And as I mentioned, I want you to really think about or rethink about how you're managing patients who have both diabetes and heart failure. Okay, this is not news to anybody, I don't think. Diabetes is bad for the heart. Diabetes specifically increases heart failure risk. 1 in 5 diabetic patients will develop heart failure. In men, from the Framingham Heart Study, we saw that there was a 2.4-fold increased risk of heart failure. This was double in women. So women had a 5-fold increased risk of heart failure. After adjustment for age and sex, each 1% increase in hemoglobin A1C was associated with a 12% increased risk of heart failure. We don't really understand well the discrepancy between diabetes and heart failure outcomes in men and women, but we do know that irregardless, even when we control for coronary artery disease, hypertension, atrial fibrillation, other common comorbidities or risk factors for heart failure, this increased risk of heart failure in diabetes persists. And it was because of this noted increased risk of heart failure that wasn't explained by traditional risk factors that the term diabetic cardiomyopathy was coined now more than 40 years ago. And it was coined to describe the vulnerability of the myocardium and the body as a whole to heart failure that persisted with hyperglycemia or with insulin resistance despite controlling for other risk factors. Studies have been very clear and have shown a continuous relationship between any blood glucose abnormality and heart failure risk and prognosis. There have been some recent studies that have come out, a few meta-analyses, some new data that have all consistently shown that insulin resistance, even without meeting the current diagnosis of diabetes, insulin resistance and hyperglycemia correlates strongly with risk of heart failure, and insulin resistance is highly prevalent in heart failure patients who aren't diagnosed yet, perhaps with either prediabetes or diabetes. So not only does dysglycemia increase heart failure risk, but of course, the longer you have diabetes, the more at risk of developing heart failure you are. One trial recently showed that every 5 years you have either prediabetes or diabetes is associated with upwards of a 17% risk of developing heart failure down the road. And again, this effect of duration and increased heart failure risk is independent of age, it's independent of glycemic control or other factors such as coronary artery disease. And again, unfortunately, this association is stronger among women and stronger among those patients with poor glycemic control. We don't fully understand why patients with diabetes are more likely to get heart failure. Of course, you know that diabetes is associated with an increased risk of atherosclerotic heart disease, so you're more likely to have a heart attack or you're more likely to have microvascular disease. We also know that diabetes is associated with increased risk of hypertension, and atherosclerotic cardiovascular disease and hypertension cause cardiomyopathy on their own. Yet, aside from that, we know that hyperglycemia, insulin resistance, hyperinsulinemia is associated with significant metabolic disturbances, disturbed cellular function, structural alterations, autonomic neuropathy, and excess RAS activation that all together may play a role in causing more heart failure among these patients. Women with diabetes have more endothelial abnormalities, more microvascular abnormalities, and are more prone to diastolic dysfunction. Whether this is what explains their increased risk, we don't know. I won't go into this in detail, but it is important to remember that not all heart failure is the same. There's heart failure with reduced ejection fraction, EF below 40%, and heart failure with preserved, and these can overlap, of course. 40% of patients with heart failure, be it HFpEF or HFrEF, will have diabetes. And of course, HFrEF represents a continuum, the same way that diabetes or prediabetes represent a continuum. So in heart failure, there's a continuum of structural, metabolic, and cellular abnormalities. These abnormalities can exist in both types of heart failure and can overlap to differing degrees. Historically, we've always sort of associated diabetes with heart failure with preserved ejection fraction. But as you know, diabetic patients often have both, although there is a growing epidemic of diabetes, obesity, and heart failure. Because of this growing epidemic, and because of the fact that we know that structural and metabolic changes can occur very early on in diabetes and very early on in heart failure, it becomes really important that we focus on early stages of disease. In the States, the American College of Cardiology recently moved beyond simply having NYHA classes to having the stages of heart failure. And it was really to address the fact that by the time someone has NYHA class symptoms, they're already likely at stage C or even worse heart failure. Yet we know that there are earlier stages where there are abnormalities. And if we can possibly target those earlier stages or diagnose them earlier, we may be better at preventing heart failure or improving heart failure outcomes. Stage A, diabetes, is rapidly becoming referred to as almost pre-heart failure. A lot of experts in diabetes and heart failure globally say that diabetes should be considered early onset heart failure. You can take that or leave it as you will, but certainly it's clear that the risk is there. One of the things that we can do that we don't do a lot of, but something that's very, very easy in our diabetic patients is checking NT-proBNP levels. So for those of you who are managing diabetic patients on a regular basis, you know we're routinely doing blood work to check A1C, ACR, creatinine, et cetera, et cetera. It's easy to add an NT-proBNP. It may not necessarily change how you manage that patient, but it at least gives you an idea where they are on that heart failure spectrum. So I mentioned that there are guidelines that exist to help guide us with these patients. Diabetes Canada, of course, is what we use here in Canada. We have our CCS HFrEF guidelines, which Dr. Melnichuk just went through, highlighting foundational therapy and ways we can go to personalized therapy beyond that. And recently, literally in the last few weeks, the American College of Cardiology expert consensus document was published. And this is the first document that has been published to give us guidance on how to manage HFpEF. So Diabetes Canada and other guidelines around the world really do encourage us to target a hemoglobin A1C of 6.5 to 7% or lower in most patients. So these are patients who have perhaps lower comorbidities, are less fragile when it comes to heart failure. They have a lower risk of hypoglycemia. You'll remember that initially intensive glycemic control from ACCORD and ADVANCE was actually associated with adverse cardiac outcomes. You need to remember that a lot of those patients were treated aggressively with insulin therapy, and we now have newer medications on the market that allow us to get really good glycemic control without the risk of hypoglycemia. So we now are in a position where we can get much more aggressive with hemoglobin A1C. We'll target a higher hemoglobin A1C in patients who are, not surprisingly, those that are very, very frail, have significant comorbidities, or have a high risk of hyperglycemia or of hypoglycemia. So now more than ever, we really need to think beyond the hemoglobin A1C. Hemoglobin A1C is one aspect of diabetic control among many others. And we need to be looking at all of them. And now we really also need to be thinking about what medications we use to treat diabetes. Metformin is still our first line gold standard. The data over the years has sort of come and gone in terms of, yes, metformin's good. No, maybe it doesn't do anything. But more and more studies have recently come out showing that metformin is safe in these patients. It has a relevant mechanism of action. So it does things in the body that have clear benefit when it comes to cardiac function. There can be a weight benefit, or at least weight neutrality, which is important in HFpEF patients. It's cheap. It's readily available. There are a number of trials underway that are going to specifically address the question of, or the role of metformin in heart failure management, and some of them are listed there. But suffice to say, metformin is first line in patients with type 2 diabetes. Of course, with patients who have type 1 diabetes, we're using insulin. SGLT2s, I won't go into detail here. I've spoken to you guys before about SGLT2 inhibitors, and Dr. Melnichuk went through this. There are large clinical trials that have clearly documented the benefit of SGLT2s in reducing heart failure risk, reducing hospitalization for heart failure, and that's why it's one of our 4 foundational therapies for HFrEF, and why it is now considered the first line therapy for patients with HFpEF. GLP-1s. So I find I often get asked, what's the role of GLP-1s? Can you use them along with SGLT2s? Should we be using them in heart failure patients? Well, presently, if you look just at the evidence, we don't have any clear evidence of a direct heart failure benefit. But keep this in mind. Type 2 diabetes is one of the major drivers of heart failure with preserved ejection fraction. And in 90 to 95% of patients with type 2 diabetes, obesity is the driving factor of their diabetes. So it makes sense that whatever we can do to get weight down, improve glycemic control, can potentially have significant impact on HFpEF outcomes. Aside from that, GLP-1s are excellent medications when it comes to not just lowering weight, but lowering hyperglycemia. They do have MACE and renal benefits. We saw that from cardiovascular outcome trials done with GLP-1s. They can be used in type 1 diabetics. It is still considered off-label use, but there have been a number of studies published showing that they're safe, they can reduce glycemic variability, and they can help with obesity in patients with type 1 diabetes. You can also use these down to a low eGFR, unlike many of our other anti-hyperglycemic agents. So you can really use these down to dialysis. This was a nice meta-analysis that was recently published in Diabetes, Obesity, Metabolism not too long ago. And this study looked at some of the old heart failure trials. So you can see Leader, Excel, Harmonies there using GLP-1s. And we saw a clear reduction in a composite of heart failure and cardiovascular death when they actually looked specifically at heart failure itself. There wasn't a statistically significant improvement, but as you can see to the right of the screen there, the trend was in the correct direction. And there are still ongoing studies specifically looking at the role of GLP-1s with heart failure. And so hopefully in the next few years, we'll have more information on that. DPP4s, so these are the sitagliptins, all the different gliptins. They're likely okay. I just want to remind you that there have been trials showing increased heart failure risk. That was in SABRE-TIMI, which used saxagliptin, and in post-hoc analyses with Examine using alogliptin. We don't really use those here much in Canada. I think the ones that I see all the time are sitagliptin and linagliptin, and there's no increased risk of heart failure that we know of with those medications. But keep in mind, DPP4s and GLP-1s work on the same pathway. GLP-1s have cardiorenal benefits, weight benefit, are better glucose lowering agents. So I really think we should be looking at putting GLP-1s higher in our management list above DPP4s. What should we be avoiding or minimizing? So sulfonylureas. Unfortunately, these are a very common go-to for managing hyperglycemia. They're cheap, they're covered, they are readily available. We've used them for decades, and yet they have been associated with increased heart failure, hospitalization, and increased mortality. Conversely, in this particular trial, they looked at heart failure patients and with type 2 diabetes who were newly prescribed metformin or SU. And in contrast to the SU, metformin actually was associated with a significant reduction in mortality and hospitalization for heart failure. So they still remain in our toolbox, but again, they should be down the algorithm in terms of management. What should we not be using? TZDs. I don't think we really prescribe these anymore, the thiazolidinediones. These clearly increase heart failure risk. They cause salt and water reabsorption, increase pedal pulmonary edema, increase BNP and NT-proBNP levels. So if you are seeing a patient with heart failure and they are on one of these medications, absolutely, you should be stopping it. Or if you're not the one managing the diabetes, send a note to the person who is and say, we need to get them off this medication. And insulin falls in the we have no choice category. For type 1s, obviously, we have no choice. And for patients who with type 2 diabetes who have absolute or relative insulin deficiency, again, we don't really have any choice, but we know from many trials, including a recent a meta-analysis looking at some of the older heart failure trials, that insulin is associated with sodium and water retention, and it is associated with increased death and hospitalization for heart failure. What we can do, rather than throwing insulin at patients, is we can really try to optimize non-pharmacologic management for type 2 diabetics and drugs that have benefits such as SGLT2s and GLP-1s. So Diabetes Canada, of course, strongly recommends that any patient with heart failure and type 2 diabetes should be on an SGLT2 inhibitor. SGLT2s are also indicated for patients with chronic kidney disease. GLP-1s are a close second. Skip over this. Of course, these are our own Canadian HFrEF guidelines, which Dr. Melnichuk went through. I won't go back through this in detail. Suffice to say, these therapies are just as efficacious in patients with or without diabetes. And so I mentioned that we recently saw the first HFpEF set of guidelines, if you will, at least the first set of comprehensive review trying to help guide us with managing these patients. And again, you see there that type 2 diabetes is right up at the top of HFpEF comorbidities, so is obesity and other conditions that we tend to see in diabetic patients: chronic kidney disease, coronary artery disease, atrial fibrillation, sleep apnea, hypertension. So we really need to emphasize early diagnosis of diabetes, early diagnosis of this predisposition to heart failure, and get on top of it. SGLT2s are first-line therapy for HFpEF, after which options include loops, MRAs, ARNIs, ARBs, depending on the specific patient. And then finally, I won't go through this a lot in detail. Dr. Melnichuk did talk about this. We used to be really worried about hypotension with SGLT2s. We know now when we use them appropriately, it's not such a big deal. Yes, they do cause or normally cause a few millimeters of mercury reduction in blood pressure, which most patients have room for, which is why it is often a lot easier to add an SGLT2 before it is adding RAS inhibition or escalating RAS inhibition. I think the key message here is still, you do need to be aware of patients who are hypovolemic or hypotensive. That really is just a sign that probably their overall management needs to be reassessed. We need to back off on blood pressure medications, get rid of ones that might not be adding something like thiazides. And if patients are clearly quite volume contracted, optimize the volume status before we look at adding an SGLT2 inhibitor. The patients that really are at risk of adverse outcomes with SGLT2 initiation are those who are on really, really big doses of diuretics, and the diuretics don't get adjusted when we start the SGLT2, big doses of MRAs, and those who have quite severe kidney disease. This, I think, is probably where I get a lot of questions from my cardiology colleagues. They'll often come to me and they say, well, I want to add the SGLT2, but I'm not really sure what to do with the rest of the meds, the diabetic meds. So it's actually not as complicated as you might think. So the first question is, ask yourself, are they on an anti-hyperglycemic agent that is known to directly cause hypoglycemia? So this is insulin or sulfonylurea. If they are, then you ask yourself, well, what's their glycemic control like? If the glycemic control is good or relatively good, so an A1C below 8 or 8.5%, it's best to make some adjustments. The SU, you can either cut in half or stop, depending on the dose. If they're on a lower medium dose, I would just stop it. If they're on a high dose, cut it in half. If they're on insulin, and that can be mealtime or basal insulin, reduce it by 20%. If the diabetes control is quite suboptimal, so an A1C over 8.5%, you can be pretty comfortable that they're going to be just fine with you adding an SGLT2 inhibitor without any adjustment. And then, of course, if they are on medications that are not known to cause hypoglycemia, so metformin, incretin-based therapies, you can go ahead and add the SGLT2 inhibitor. The risk of hypoglycemia is very, very low. DKA remains something that we need to really worry about. I think we've all gotten quite comfortable with the notion that when people are sick, when they're vomiting, when they have diarrhea, when there's a risk of significant renal impairment, volume contraction, you put it on hold. They can restart when they're over their illness. Where I see diabetic ketoacidosis popping up now is in people who actually need insulin that we don't see need insulin. So who are these people? These are people such as ones that have a very high hemoglobin A1C. So an A1C typically around 9% or higher. I would be worried that they actually might need insulin if they're not already on it. Patients who have had diabetes for a really, really long period of time. Patients, of course, who have had prior DKA as a concern. Ketogenic diets, actually, that in combination with an SGLT2 can cause DKA. Those are probably the ones that we really see. So I think, you know, what I'm often telling my diabetic colleagues or my cardiology colleagues is that if you see somebody who has a high A1C, hold off on starting the SGLT2, talk to their MRP managing the diabetes and tell them, hey, the control needs to improve so that we can go ahead and add the SGLT2, whether that's with insulin or whatever else. And of course, educating patients is really key. So to summarize what I think are really the key take-home messages, heart failure remains a very common and still often under-recognized and underdiagnosed complication of diabetes. You could say diabetes is almost pre-heart failure stage A heart failure, whatever you want to call it, but these patients are very, very high risk. Women in particular are more likely to get heart failure with a 5-fold increased risk compared to non-diabetic women. We should be treating diabetes as stage A heart failure and managing it that way, which means we're talking about managing all the other comorbidities, either with pharmacologic or non-pharmacologic therapies. We're following patients closely. We're checking BNPs to see, are they progressing on that heart failure spectrum, moving on to getting echocardiograms as required, etc. Earlier and more aggressive treatment of diabetes before they need multiple therapies, particularly therapies that might actually increase their risk of heart failure, such as SUs and insulin, is going to be key to help reducing heart failure incidence and progression rates. SGLT2s and GLP-1s should be first line in patients with diabetes and heart failure after metformin. Our foundational therapies and the other therapies such as ivabradine and vericiguat remain just as good in diabetics as they are in non-diabetics. And SGLT2s can be used easily and safely if you just take a step back and give it a little bit of thought before you initiate the medication, particularly with respect to volume and what other medications they're on, be they diuretics, blood pressure medications, or in particular, anti-hyperglycemic agents. So I'll stop there and I'll see if anyone has any questions.
Is there any questions in the audience? Oh.
Great talk, Jody. So I was just wondering what your thought is in continuing a patient's SGLT2 and GLP-1 in hospital.
Absolutely, that's a good question because that's obviously coming up all the time. With the SGLT2, there has been some growing evidence supporting continuing use. I think of it this way, and I explain it to patients this way. You get admitted to hospital for, let's say, decompensated heart failure. You're short of breath, you've got pulmonary edema, your creatinine goes up. First of all, we know that that rise in creatinine is not a reflection of more kidney disease. It's a reflection of the kidney responding to what's happening, right? What do we do in hospital? We blast them with Lasix. We stop their Entresto. We stop their SGLT2 inhibitor. And then we wonder why, upon discharge, a week or two later, they're bouncing back and emerge. We have removed the therapy that is actually helping their heart and their kidneys, which provides a feedback loop to protecting the heart. That being said, there are situations where we do need to put SGLT2s on hold, and these are situations where patients are critically unwell. So those in the ICU are having big shifts in volume, big shifts in renal function. Those who are, in for severe gastroenteritis, et cetera, obviously those should not be on SGLT2s. But the guy coming in for the elective hip, he can continue. In terms of GLP-1s, a little bit different because they have a different mechanism of action. GLP-1s typically can be continued, no problem, during a hospitalization, with the exception that, of course, if the patient's being hospitalized for an illness that is reducing intake, putting them at risk of malnutrition, then I would put the GLP-1 on hold. So patients, cancer patients undergoing aggressive chemotherapy who just aren't eating, that sort of thing. But it's nice to be able to use the GLP-1 in hospital because, again, it can minimize insulin requirements. So it can minimize the need for rapid acting on the ward and that sort of stuff. And it maintains that smooth sort of degree of glycemic control.
Thank you. The A1C is an indicator of heart failure, and 1% increase is equal to 12% increase in heart failure. That's very high. Now, I was just wondering, if you lower A1C by drugs alone, such as metformin, does the rest without treating the root cause of diabetes?
Yeah, it's actually, that's a really good question because we have not necessarily seen that the lowering of the hemoglobin A1C is what explains fully the benefit. So just like we know that a high A1C, even though it is associated with significant increases in heart failure risk, high hemoglobin A1C alone does not explain the totality of risk. So you're absolutely right. Getting the A1C down is important, but there are many other factors that we need to look at. When we look at diabetes control per se, we look at the A1C, we look at time and target range, which we can measure easily now with all the devices available. We look at glycemic variability. So those are all important, but equally important, more important perhaps, are all the other things we do to help manage the comorbidities, to help get patients moving, to help get them to eat well, achieve a healthy body weight. All of those things are just as important, perhaps even more so.
Yeah, so you did mention that education is very important.
Absolutely.
One good source that I personally know about is on Ministry of Health Ontario actually have a program which is free for everybody on diabetes, and it's very well put up as well.
Absolutely, absolutely. You know what? The sad thing is, there are tons of resources available. In the community where I'm practicing, we use the Community Diabetes Education Program of Ottawa. It's free. If you have pre-diabetes or diabetes, it's free. They'll call you, they'll Zoom with you. You know, why do we not use these resources more? You know what it comes down to? We just don't have time to tell people.
Exactly, and I think this is where they could hardly ever. I didn't know about them, but once I get into it, I thought, wow, this is a world.
Oh yeah, the patient with diabetes who has the best control is the one who's best educated.
And so we do have one question that's in the chat. Is there capacity in the system from a cost benefit to support echocardiograms for all of our diabetic patients in primary care? Is this something that will be part of future guidelines?
Yeah, that's a really good question. You know, honestly, cost analysis, I don't know. When you think of the cost of an echocardiogram compared to the cost of heart failure admissions, I would think this is a no-brainer, but I'll admit I have not done the numbers, so I don't know. It is a really good option, and I think we don't use echocardiograms enough in patients who have symptoms, and probably a lot of us who are doing diabetes management maybe don't even ask enough about symptoms, exercise tolerance, breathing, you know, tendency towards fluid retention, that sort of thing. So we, number one, should be using echoes more. But even more than that, I think biomarkers are something that are cheap and easy to get. So certainly a good start would be to just make sure that we're doing annual biomarkers on patients with diabetes. And if they're elevated, you know, then further exploring a possibility of heart failure with an echocardiogram, or at least measuring these BNPs and following them would be a start.
Hi, thank you. Correct me if I'm wrong, but currently Diabetes Canada does not recommend the use of GLP-1s for pre-diabetes. But as you discussed, that's a huge, obesity is a huge risk factor for diabetes. Do you see that changing?
Hopefully, yeah. You know, GLP-1s are now becoming more and more available. We've got Ozempic, of course, which is covered on formulary. We have an oral option now for a GLP-1, which is covered by private insurance. We have GLP-1s where the indication is for weight management, irrespective of diabetes status. So that's liraglutide, Saxenda, semaglutide was recently approved by Health Canada for weight management. So the line between weight and diabetes is quite blurred. And so really you can get away with using a GLP-1 across the spectrum pretty much. I certainly do. You know, if I see somebody who's pre-diabetic, that's a discussion that we have quickly, is getting them on a GLP-1. I don't know if that answered your question. Sometimes I lose track of what I'm saying. I think diet, yeah. Yep. And I'm hopeful that that will come. You know, some of the key people behind the guidelines, you know, Dr. Alice Chang down in Toronto is a very, you know, broad thinker. And so I think now with monitoring, we've learned a lot more about diabetes, and the A1C is not necessarily all where it's at. So we need to think beyond that.
Great presentation. Thanks.
Thank you.
Heshka.
Thank you very much, Dr. Heshka. I'm here to introduce Dr. Redpath. Dr. Callum Redpath is a clinical scientist and staff cardiologist in the Department of Electrophysiology at the University of Ottawa Heart Institute. He's also an associate professor in the Division of Cardiology, Department of Medicine at the University of Ottawa. Dr. Redpath's practice focuses on prevention, detection, and treatment of all arrhythmia-related disorders. And he's going to give us a talk today about heart failure patients who also have atrial fibrillation. So it'll be a great topic to do. Welcome, Dr. Redpath.
Hello, good afternoon. How are you? I would really like to take a little bit of time to talk to you about atrial fibrillation, but really what I want to do is get my oar in early. So what is atrial fibrillation in heart failure? So there's no doubt that there's a subgroup of people who develop heart failure directly as a result of their atrial fibrillation. And so those are generally not patients that you'll see because they tend to present acutely unwell, and they tend to come straight into an EP service, whether it be through cardiology or the emergency room. The other history to give you for the heart failure guidelines, why I don't know why this is automatically going forward, is that atrial fibrillation can itself produce an atrial cardiomyopathy and is caused by an atrial cardiomyopathy. And I'll come back to that later. For those of you like me over the age of 50, yes, I know, but I am, is that we're losing 1% of our atrial myocytes on an annual basis, and those are being replaced by fibrotic cells, fibroblasts. And one of the most common reasons, particularly in diabetic patients, for them to develop atrial fibrillation younger is that that process is accelerated. The person who makes a drug to stop that fibrotic process will be rich beyond their wildest dreams. Now, the other thing to say is that the H in CHADS, and we'll see here later when we talk about preserved ejection fraction heart failure. Yeah, I think I'm going to have to be fighting this all day. Is that the H in CHADS was from congestion or an echo that demonstrated they had an EF less than 40. So you'll see in the AF guidelines, we have to use the data from the studies, and if the studies qualify patients as having an EF above or beneath a certain value, then clearly when we manage the atrial fibrillation, we have to do the same. Oh, someone's taking control. This is going to be a problem because every time I look down, all my slides should be looking the same so that they're emblematic. So quickly then, reduced ejection fraction heart failure, that should be an inflection point in their management, right? So this is where patients who have established heart failure and something changes, then those patients are the ones that you're going to see, and those are the ones where you're going to think about referring to us.
Change the slides.
See, I haven't touched anything. I'd like to tell you all that I'm a go-getting, forward-looking guy, so it's no wonder my slides keep advancing. But I'd be telling fibs.
No, you can change, you can do
No,
that.
it's advancing automatically. That's the problem.
I click the mouse to change this, to change the slides. Yes, you're you're controlling.
I haven't advanced the slide yet, though. I haven't done it.
Advance the slides? You want to automatically clear your slides? Or you change by the slides?
So I would normally manually do it myself.
Yeah.
For some reason, it seems to be automatically advancing.
No, it's not. So right now, so I click it, it change. I click back, it changed to the previous slides. Yeah.
We shall see what happens. I haven't advanced my slides yet.
No, I don't think so.
No, that's what I'm telling you. I haven't advanced my slides yet, and we're on slide 4. You think I can't handle PowerPoint? You should see me in the EP lab. Okay, back to slide 2. So the big problem we have in electrophysiology is we're playing catch up to the heart failure with preserved ejection fraction. And so therefore, what has traditionally happened in electrophysiology is patients who have symptoms consistent with heart failure are often included because their ejection fraction is above 40 in all comers. So I'm going to share with you that data in a second. So getting back to it, really heart failure is a very complex syndrome because I like simple things. I did EP. And so we need to confirm the presence of heart failure with symptoms and signs and something new like biomarkers. And you'll see that in the RAF study, we have moved to doing that. Historically, my predecessors were smarter than me and that they included congestion. So the H in CHADS was for congestion as well as an EF less than 40. So there's the slides going forward again without me touching them. Okay. As I've said, heart failure in EP is defined traditionally as EF less than 40. That, of course, has now changed because we're playing catch up. Traditionally, you've been asked to manage atrial fibrillation in heart failure patients with amiodarone. And again, traditionally, even though we're asked to implant CRT all the time in patients with heart failure and atrial fibrillation, unless we do AVJ ablation, that's ablating the AV junction or the AV node to force biventricular pacing, the data is extremely weak, even although CRT is one of the most impressive interventions in all of human medicine. So this was supposed to be an earlier, I wanted to grab your attention with this. So that's it advancing again. An EF less than 40 is now considered in my world as the impetus to intervene in atrial fibrillation. What we mean by intervene is rhythm control. In Canada, because of the resource constrictions, so I'm not advancing my slides, they're going automatically. That's amiodarone in the interim. Whilst you're on the wait list for an intervention, amiodarone. And then we will intervene with either pace and ablate or an ablation. And I'm going to share with you the data that supports that. In heart failure with preserved ejection fraction, that's a moving target. We've only really cottoned on to that. And of course, trials take time to do. And of course, they require follow-up. And if we're looking for hard endpoints such as mortality, that's going to take years. Atrial fibrillation doesn't kill you quickly. And that was supposed to be, since Lisa asked me to talk today, that was supposed to be the inverted commas guidelines that aren't guidelines yet because no one's asked us. So in 2020, which are the current Canadian AF guidelines, you can see that essentially all the good bread and butter medicine that we should all be doing at all times, identifying precipitants, anticoagulate where appropriate, decide with a shared understanding of the patient whether they'd like rate control or rhythm control and what are the pros and cons of either. That's partly what I'm hoping to do with today's talk. And then modify risk factors. And that's really crucial because even in arrhythmia medicine, we have demonstrated that modifying your risk factors will reduce the likelihood of AF recurrence, whether you have an ablation or are on antiarrhythmic drugs. So these are the routine bread and butter things that we should all be doing at all times, addressing alcohol and tobacco misuse, encouraging our patients to exercise. You know, when I was a resident, we were very worried about patients overdoing things in atrial fibrillation. The truth is, the more exercise, the better. Jennifer here has done a great job in improving and expanding the indications for exercise prescription in patients with atrial fibrillation. Managing diabetes, managing blood pressure, and something that bores my patients silly is that every single time I'll talk to them about their weight. And unfortunately, I did electrophysiology so that I could get away from talking to people about diet and exercise. But unfortunately, it's caught up even in arrhythmia medicine. Diet and exercise is extremely important. And with that comes sleep apnea. So what do we do if you want rate control? It's pretty simple. Again, you can see that we've split patients into two groups according to the ejection fraction. And that's really because we know that non-dihydropyridine calcium channel blockers are bad for patients who have poor systolic function. And essentially, it's a beta blocker plus digoxin if you can't get there. Obviously, we can add amiodarone, and you can see that there they've talked about using AVG ablation. But at that point, there wasn't much in the way of data to support that. It was just a common sense bailout. If you want to use rhythm control, of course, that's where we come in. And again, you can see that we've split the population into two groups, whether you have heart failure with an EF that's low or above 40. Again, we are behind you in our classification, but the problem is these studies, particularly when it comes to ablation, cost millions and millions of dollars to do and anywhere between 3 and 5 years to perform. So it's unlikely that a lot of this work is going to be repeated. What will happen is, as I'm going to show you, there'll be several meta-analyses or systematic reviews looking to parse out the differences, and I'll show you that data in a second. So you can see in 2020, we felt that the first line catheter ablation was only in highly symptomatic patients or in those patients where it was felt that tachycardiomyopathy was present. So that's rapid atrial fibrillation causing the heart failure. Eliminate the atrial fibrillation, you have eliminated the precipitant for heart failure, and the patient will have a preserved ejection fraction and their congestion will not recur. If you want to use rhythm control and the patient has an ejection fraction less than 40, the only drug licensed for use is amiodarone. Since most patients don't like taking amiodarone, we have moved to using atrial fibrillation ablation as a first line. So here are several studies placed together in a meta-analysis very recently. This has all come out in the last 2 or 3 years, where patients have been aggressively managed, some as quick as 3 weeks from emergency room presentation, first atrial fibrillation documentation. That's not something likely we can recreate in Canada, and certainly not here in Ottawa. But the point that I'm trying to make here is that the earlier you intervene, the better at least the arrhythmia outcomes are. And if we take that further forward, not only do we reduce symptoms, reduce emergency room visits and hospitalizations for heart failure, but our patients don't have to take amiodarone. Why am I talking about amiodarone? Because the complications of an intervention, like an AF ablation, are essentially a short-term problem for 30 days. If you tell someone that they've got to have amiodarone indefinitely, they're going to take that drug for an indefinite period, usually months or years. And if they're taking a high dose, anything between 20 and 30% of those patients will have adverse events. And if you look here, on the left-hand side, you can see comparing adverse events and arrhythmia suppression. And here, once you add long-term events on amiodarone, patients are actually better to have an ablation up front in terms of adverse events and complications. That's not something that's widely accepted outside the EP community. So catheter ablation in reduced ejection fraction, we know that compared to drugs, drugs are fairly useless in the long run, that catheter ablation in the short to medium term is more effective, and that there's no significant difference in complications. This is only major adverse complications. The previous slide I showed you demonstrated the long-term risks of amiodarone. Here we can see catheter ablation reducing arrhythmia occurrence and heart failure hospitalizations in all heart failure studies, and then even in patients where they have persistent atrial fibrillation, where we know that AF ablation isn't as effective, it still reduces symptoms, reduces recurrence, reduces heart failure. And here is yet another of these meta-analyses. So believe it or not, there was 8 published in 2 years in various journals. Here we can see that we have an improvement in ejection fraction. We have an improvement in 6-minute walk test, reduction in their Minnesota Living with Heart Failure score. And this was surprising to us, but this suggests that there is a reduction in mortality. So we weren't expecting that, because how do you, if mortality acutely in atrial fibrillation is low, how can you expect to reduce that even further? So heart failure with reduced ejection fraction, rhythm control early, being aggressive, seems to be the way to go since our 2020 guidelines. However, what about preserved ejection fraction? Well, these are all comers in the EP literature. So to give you some idea, paroxysmal AF, if you have an RF ablation, 75% are arrhythmia free with 5 or 10% requiring a repeat procedure. So what I mean by that is that within a year, the patient has had no more than 30 seconds of atrial fibrillation. If you have 31 seconds of atrial fibrillation in the middle of the night and you don't even know it, and that's the only if you have in a year, that goes in my failure box. But essentially, they've had a 99.9% reduction in their atrial fibrillation. So biologically, that doesn't make sense, but we're held to that high bar because, of course, this is an expensive procedure, 2 to 4 hours on general anesthetic with real risks. So we have to demonstrate that actually it does what it says in the tin. AF ablation eliminates temporarily, for a period of years, atrial fibrillation recurrence. And that's what drives everything else. If we actually get rid of the AF, will getting rid of the AF allow the other things to improve? And of course, that's the difference between 75% success, but only 5 or 7% of patients having a second ablation, because it's only 5 or 7% have ongoing symptoms. So from the patient's perspective, it's a 90+% success rate. But in an arrhythmia perspective, it's about 75. Cryoballoon, which is quicker and cheaper, isn't quite as effective. When you look at all the studies put together, when they were placed head to head, they are equivalent procedures, but they do have a higher repeat ablation because they're slightly less effective. And I'm able to say that because that study is Girish Nair's that we did here at the Heart Institute. So where does RAFT AF and Cabana come in? So if those of you who are familiar with the AF data, these were the two modern studies deliberately designed to try and establish what's the difference between lone AF or AF in the absence of heart failure, atrial fibrillation associated with HFpEF versus atrial fibrillation with HFrEF. And the problem is, I'm sure I'll be able to laugh about this later. The problem is that because those studies were done to look at hard outcomes like mortality, we were determined to enroll patients and keep them down one track. The issue is, at least, and these are AF ablation, RAFT AF is a Canadian study, Cabana is a study performed in the United States, which is a pragmatic study. We couldn't enroll patients into RAFT AF, and then COVID hit. And why couldn't we enroll them? Because patients were referred to us for an ablation, and then we would say, stop. We want to know if AF ablation is actually going to, improve hard outcomes. We want to randomize you to the very drug you've already told your referring doctor you don't want to take anymore. You want an ablation. So funnily enough, we screened several hundred patients and admitted 4 patients into the study. And so the study was stopped early because, of course, in Canada and COVID, we stopped performing AF ablation, or at least we dramatically reduced the amount of AF ablation we were doing. So even acknowledging that the studies was stopped early, there was still a difference. Now the p-value is 0.06, so as Dr. Wells continually hits me over the head with a hammer, it's a non-significant. But he also tells me that if we had 2 more patients, it's likely that it would have been a positive study. So the problem is, how do we interpret this data? So the only way we can do that is systematic review and meta-analysis. So that is coming. I obviously don't know what the results of that will be once RAFT-AF is added into the other studies. And then Cabana, which overall was a negative study because for the same reason, patients were randomized to ablation versus drugs, and patients didn't want to take drugs. So after a period of time, the 75% of patients in the drug arm crossed over to ablation. So of course, we don't know. But even in heart failure patients, we can see that there's superiority of ablation over drug therapy for what they called heart failure patients. So there were, I believe, if I remember rightly, 250 patients were designated as heart failure by their clinicians in each arm, and 9 of them had an ejection fraction documented to less than 40%. So that's a HFpEF study. So those are patients who in America who told their doctors that they had breathlessness and they were diagnosed with clinically heart failure, HFpEF. We don't have echoes. I don't understand why we don't have the echoes to look at it, but those are all-comer patients or heart failure with preserved ejection fraction patients. So perhaps in the next 2 or 3 years, when we get some more information, we also will want to intervene earlier on patients with preserved ejection fraction heart failure. So why might this all come together in one unholy mess for our patients? Well, if you look here, this is from the Canadian guidelines, you can see that there's obviously non-modifiable substrate. So I told those of you who are as young as me in their 50s that we're losing 1% of our myocytes to fibrous tissue a year. And obviously that can be accelerated. It's rare that I ever want to modify patients' age. Try not to do that. But the modifiable risk factors like hypertension, obesity, and so on, those are exactly the same, whether you think of them as confounding or colliding factors in HFpEF. These are the things we need to do in order to improve their substrate. And the ablation really is so far only proven to eliminate their triggers. And so, of course, look at the Canadian registry for AF data telling us who is most likely to develop atrial fibrillation, and when they do develop atrial fibrillation, will go on to persistent AF, hypertension, you've heard of that, age we can't modify, previous strokes I accept may not be directly related to HFpEF, COPD, but if you're breathless, that's a major, you need to have BNP before you can say that how much of the breathlessness is COPD and how much of it is heart failure, and then heart failure itself. So then we looked and say, okay, if we don't know that we definitely should be ablating all these people, what do we do? So from my end of the desk, what we are looking at is to say, how long has someone been in atrial fibrillation? How big is their left atrium? Do they have valvular heart disease that I clearly can't help with a catheter? And this DR flash score is a way of determining how much of that atrial fibrosis is present. And so what I'm looking at here is, okay, how successful am I going to be at actually eliminating this patient's atrial fibrillation for a period of time? Because for me to perform an AF ablation, I need to believe that I'm going to get rid of the AF long enough that the other things that we're trying to achieve can actually happen. So in HFpEF, they're more likely to have persistent atrial fibrillation where the success rates are lower. So that's why at the minute, in the absence of really hard data, we will be reluctant to be too aggressive, because remember, atrial fibrillation ablation does have complications, and we need to be aware of that for our patients in order to protect them from the procedure. Because remember, if you give a man a hammer, all he sees is nails. So if AF ablation isn't the answer, is rate control the least worst option? Well, every time rate control has been compared, it has been found to be inferior in heart failure patients, or the direct side effects of the amiodarone or the dofetilide, which are the two drugs that have been used in the last decade, have caused real harm. So this data from PACE and ABLATE, I've called it the get out of jail free card, because historically that's how it's been seen. These patients have had devices for other reasons. So they've had sick sinus syndrome and symptomatic sinus pauses, or they have developed bradycardia on treatment that they require for their tachycardia. About 20% of those patients will go on to develop atrial fibrillation within 5 years. So what was thought at the time was, let's see if we can force BiV pacing and ablate the AVJ, and that way they can get off the drugs that are giving them side effects, and we will regularize and slow down their heart based on the lower rate limit of the pacemaker. And we expected an improvement in symptoms. We expected an improvement in ejection fraction. But what we didn't expect was an improvement in mortality. And so that gave us the confidence to then test CRT pacing, simply because we're concerned about unopposed right ventricular cardiomyopathy, right ventricular pacing-induced cardiomyopathy. And so the PACE and ABLATE was then used in those highly symptomatic patients for whom AF ablation was either unsuccessful or deemed too high risk or futile. And the data is pretty clear. This is data only published about 18 months ago, and that not only did they feel better, but the outcomes were improved. This is primary composite outcome: death, cardiovascular death, heart failure, hospitalization. And here is mortality. This is pretty huge, right? Now, I know that these patients are sick already, but that's pretty impressive reductions in mortality. Now, this is a very small study. There's only about 100 patients in this study because it was very expensive to do. But this is where I think we may be headed. And now, because we believe that we can have a much simpler, cheaper procedure with conducting system pacing, which is pacing directly in, used to be the HIS bundle, but now we're targeting the left bundle branch. We think that that will give us a cheaper, simpler ability to pace without cardiomyopathy and allow AVJ ablation and rate control for those patients. So I'll leave you with this. I'm sorry if I've gone over because we had to go back and forward with the slides. But here are the three main options that you have for your patients. I think that amiodarone as Rhythm control is only while the patients are on the wait list for some other kind of intervention, because every time it's been assessed, ablation or pace and ablate has been shown to be superior in amiodarone in the long run. If you want rate control, then you know how to do it. There's not going to be any new studies demonstrating how to perform rate control. And here is a little slide showing you which patients should go where in atrial fibrillation management in 2023. The next CCS guidelines for atrial fibrillation will not be available for another 2 years, so I think it's highly likely they'll change. And this is what I recommend you do, at least for us here in Ottawa, in between time. The only problem is, can we keep up with demand? I apologize if we're running, and I'm happy to answer any questions.
Thank you so much, Dr. Redpath. Are there any questions in the room? Or on the chat? Okay, so there's a question.
It's 4 o'clock in the afternoon. I don't blame you.
So there's a question on the chat from Jonah. He says, for rate control, is the heart rate target like all heart rates above 110 or only with exertion? Thinking average or any pulses.
So that's a great question, because that's never been definitively shown. So the more aggressive we are with heart rate lowering, the more likely patients are either to have side effects from the medications or complications. So what is recommended is 70 to 90 beats per minute at rest. On exercise, that's a really difficult question to answer. I've actually stopped advising my patients. I just tell, because of the work that Jennifer has done here, Jennifer Reed. So I tell them to exercise and to not wear their watch and listen to their body. And that's because of the absence of evidence, not of evidence of an absence of harm, but just because exercise is so good for patients with atrial fibrillation. I just want them to listen to themselves and work up slowly and build up their stamina. So really, when it comes to heart rate control, it's heart rate control at rest. That's at least has a modicum of evidence. So 70 to 90 beats per minute.
That's great. I don't see any other questions. Thank you so much, Dr. Red.
Oh, you're welcome. Thanks very much.
Appreciate it.
So now I'd like to introduce our last speaker, Dr. Carolyn McGinty. She's a cardiologist at the University of Ottawa Heart Institute and an associate professor in the Department of Medicine at the University of Ottawa. Dr. McGinty's clinical focus is heart failure and heart transplant. Her research interest is in non-malignant palliative care for patients with end-stage heart disease. She'll be discussing end-stage heart failure with us today. Welcome to Dr. McGinty.
Good afternoon. Thank you for the introduction. Thanks to the organizers for the chance to speak today. I realize I'm the only thing between you and the weekend, so I'm in a very unfortunate position today. And we're already running behind, but I should not go over. So my last talk today is going to be on end-stage heart failure. These are my disclosures. They are not relevant to today's talk, and my acknowledgement is Dr. Steinberg, who is a mentor of mine in Toronto. So the objectives for the symposium today are listed at the top for appropriate treatments and consults for heart failure patients at end stage, but I'm going to be a bit more specific today, looking at clinical indicators for end stage heart failure, symptomatic management of these patients, including LVAD or mechanical circulatory support, and then finally talking a bit about palliative care. So what am I talking about when I refer to end-stage heart failure? So this is a subset of patients with chronic heart failure who continue to progress and develop persistently severe symptoms despite maximal guideline-directed medical therapy. Several terms are used to describe this patient population, including end-stage, advanced heart failure, or refractory heart failure. And so this definition that I have here was developed in 2018 by the European Society of Cardiology, which updated its definition of advanced HF, which really includes these 4 distinct criteria. So patients who have an advanced NYHA class, who have severe cardiac dysfunction as defined by at least one of the criteria listed there, having hospitalizations or unplanned visits in the last 12 months for heart failure or malignant arrhythmias. And finally, they have severe impairment of their exercise capacity with inability to exercise or a peak VO2 that's less than 12 to 14, depending on whether or not the patient is on beta blockers. And so the focus of this new definition is important because it doesn't focus so much on the cardiac function. It more clearly acknowledges advanced heart failure, which can occur in patients who don't have reduced EF, but actually patients who have end-stage heart failure from valvular disease, who can actually have HFpEF in the context of other diseases like amyloid or HCM, or have isolated RV dysfunction. And so how do we recognize these patients? There are many lists out in the guidelines in terms of markers or clinical indicators of advanced heart failure. I like this mnemonic or acronym very much. I need help. It's easy to remember, and we teach it to the residents all the time in terms of when they should be referring to someone like me who looks after advanced heart failure and considers patients for mechanical heart or transplantation. And so I need help stands for the use of inotrope, so either previously in hospital or an ongoing requirement, patients with an advanced NYHA class 3 or 4 or elevated natriuretic peptides, those patients who have end organ dysfunction, particularly liver or renal dysfunction. EF does portend a poor prognosis, so here it's the EF of less than 35%, defibrillator shock, repeated hospitalizations, edema or escalating diuretics, low blood pressure, specifically a systolic less than 90 millimeters of mercury, and prognostic medication. So that's the inability to uptitrate or the need to actually withdraw guideline-directed medical therapy. And one high-risk feature that I do want to highlight is really hospitalization. And this was mentioned by my colleague, Dr. Melnichuk, during her talk. Really, the median survival worsens with each hospitalization, such that after a 4th hospitalization for heart failure, patient's median survival is less than 1 year. And so this is really highlighting a very, very sick population with a very poor prognosis. So what do the Canadian guidelines tell us in terms of what to do with these patients who are defined as end-stage heart failure and have clinical indicators of high-risk disease? Earlier today, we heard from Dr. Melnichuk in terms of the 4 foundational therapies, and so this is so important in this patient population, even at end stage, to try to maintain that therapy. I do highlight here that non-pharmacological therapies and advanced care planning goes throughout the scope of the disease or across the continuum of their disease. But more specifically, when we look at this advanced or end-stage heart failure patient population, we look for then to consider rather referral for advanced heart failure therapy. And so someone like me in an advanced heart function clinic for consideration of mechanical circulatory support or transplant, or referral for supportive or palliative care. Again, someone like me who does cardiac palliative care, but really for those patients, and really the majority of patients who are not eligible for mechanical circulatory support or transplant, that should be the alternative. And timely referral for advanced therapies is really, really crucial. And so this end-stage patient population, if they are not referred in a timely fashion, can really miss their window of opportunity to actually be eligible for things like transplant. And so advanced therapies refers to, as I've mentioned now, heart transplantation and mechanical circulatory support, things like durable LVAD. I'm going to focus today on the durable LVAD, but happy to take any questions about heart transplant. I just, given the time, have not focused on that today. So mechanical circulatory support is a therapeutic option for patients who have advanced HFrEF. So this is not for HFpEF, but for HFrEF, to prolong life and improve functional capacity. And over the last 10 years, there have been significant advancements in durable LVADs that have really allowed patients to live longer and better. It's important that not all patients are eligible for MCS and transplant, and these are some of the contraindications to advanced therapies. They're divided into absolute at the top and then relative in the middle, if you can see here. Oh, my arrow doesn't show. But important in terms of absolute contraindications. So those patients who have irreversible hepatic or renal disease, those patients who are on dialysis, for example, or have significant medical non-adherence are not eligible for advanced therapies. Relative contraindications like age. So in our program, transplant is not available to patients above the age of 70, and we do not consider patients above the age of 75 for destination therapy LVAD. In the US, the guidelines are more lenient in terms of age, and they will use destination LVAD in an older population. Obesity in our program, specifically a BMI of over 35, is a contraindication to transplantation, but is not a contraindication to LVAD therapy. And other things like significant MSK disease that impairs ambulation, patients who have an untreated malignancy, active substance use is a big one, so alcohol misuse, active smoking, or drug use, and a lack of social support, which I'll come back to, but is particularly important in the context of LVAD. And so when it comes to MCS specifically, so not so much transplant, but what do the guidelines suggest when it comes to durable LVADs? And so these should be considered in patients who have NYHA class 4 symptoms, who are either inotrope dependent or who are very symptomatic despite guideline-directed therapy. And so those patients who have refractory or end-stage heart failure. And the magnitude of the survival benefit for durable LVAD has actually progressively improved over the last few years with the different iterations of these devices. And so the 2-year survival now is way over 80%. And so we know that that exceeds the morbidity, or the mortality rather, of patients with end-stage heart failure. This is what the LVADs look like. So these are 3 different devices. So on your far left, A is the HeartMate 2, which is the first, not the first, but the earlier iteration of the contemporary device, which is in B, our HeartMate 3, which is the device that patients have now. And on the right is a device called HeartWare, made by a different company, but is no longer off on the market. It was actually pulled last year. And so we do have patients who have this device implanted, but it's no longer used for implantation. And so a closer look for those who aren't familiar with this device. So it's a device that's implanted with open heart surgery. So the device is actually put inside the left ventricle. There is a pump mechanism, and there is an outflow graft that goes into the aorta, as you can see in this illustration. And then importantly, there's a cable that connects to a control unit that exits from the patient's abdomen and goes out to be connected to the control unit and also to a battery pack. And so, as I was mentioning, we have achieved impressive functional improvements and quality of life improvements in multiple trials for LVAD. So we know that the 1-year survival, as I mentioned, is greater than 80%. The 2-year survival is at least 70%, but likely more. What is important is that there's considerable morbidity and mortality associated with these devices. And so the readmission rate, for example, is at least 1.3 to 2.6 hospitalizations per patient year. And so this is really an important part of quality of life when we're counseling patients about what to expect after LVAD. They do have a significant improvement in heart failure symptoms, however, such that more than 80% will have functional class 1 to 2 symptoms 3 months after implantation, compared to NYHA class 4 typically preceding. And if we look at the landmark trials, but I'd ask you to focus way on the right to Momentum 3, which is the most recent, with HeartMate 3, which is our contemporary device. And so here you see the survival at the bottom at 12 months is approaching 90% at the 6-month mark. And so these are patients who are living longer. There are complications, as I mentioned. And so if you look here, stroke, major bleeding, LVAD driveline infection. So this is pretty significant, and obviously these do impact patient quality of life and add considerable morbidity to patients. The LVAD is associated, as I mentioned, considerable mobility, but really significant lifestyle changes. So patients are tethered to a battery pack or to an external power supply at all times. And so this really does have a significant impact on their lifestyle. And there's a significant need for caregiver support. And so patients have to have at least one identified caregiver, someone who is trained in the device, who can be with them and is able to manage the device with them. And so this, again, is really a big lifestyle change for patients who are used to being more independent. The Intermax registry, which is where we follow all of these patients who get to devices, has shown that patients with LVADs most commonly die from neurological dysfunction. So this is an important thing to understand about the patients who have this implanted, and is that typically it is a neurological death. And very, very importantly, these patients will always have to have the device turned off at some point in time, whether that be when they eventually go to transplant, as the LVAD can sometimes be used as a bridge. But if it's not as a bridge to transplant, then it will ultimately be turned off, either in the context of another disease like a metastatic cancer or a neurological event, as I mentioned, or it can be in the context of the patient wishing to stop LVAD support. And so, and again, a really important piece in terms of the discussion prior to LVAD implantation. And so for those patients who don't go for mechanical support or for transplantation, how do we manage those patients with end-stage heart failure? So in terms of symptomatic management, I tend to look at like this. This is kind of a stepwise approach that's been published a few years ago by Dr. Steinberg and her group in Toronto, but really maximizing guideline-directed medical therapy, the cornerstone therapy that Dr. Melanchuk reviewed earlier this afternoon, still remains the standard of care for these patients. So even as their disease progresses and they become more and more sick, the guideline-directed medical therapy is still what constitutes the best symptom management when it comes to end-stage heart failure. Diuretics should be adjusted as frequently as needed, and that's also allowing creatinine to rise if that's within the patient goals of care. And then once medications are maximized, then there is a role for opioids for refractory dyspnea. Inotropes, which I will touch upon today, can be used for symptom optimization and can be quite beneficial when it comes to overall symptom burden. And then finally, things like daily weights and sodium and fluid restriction are also important if within goals of care. I'm going to touch a little bit more on diuretics. Diuretics are really the mainstay of symptom management for patients with heart failure. They offer no mortality benefit. So loop diuretics, so Lasix or furosemide specifically, has been studied in multiple trials in terms of how to best to dose it or give it to patients. And there's no mortality benefit, but it does decrease dyspnea and overall global status. And so it is the best way to manage volume overload or these acute exacerbations of heart failure. There are some diuretics that can be used as adjuncts, specifically metolazone, which is a thiazide-like diuretic that inhibits sodium reabsorption in the distal tubules, and that can be used in conjunction with Lasix to really potentiate the effect of Lasix. In acute heart failure, there are two recent trials that were published last year looking at both empagliflozin and acetazolamide in a hospital setting and were demonstrated to have benefit. And so these are drugs that can be used or in addition, or rather added on to their therapy for patients coming into hospital with acute exacerbations of heart failure. Given that they're oral drugs, they could potentially be considered in an outpatient setting in patients who really choose to be at home and really kind of adopt a palliative approach to their care. This is from the Heart Institute. This is what we give to patients in terms of their own self-management. And so again, going back to the guidelines in the very first slide, so important to have a lot of self-education and a bit of self-management in terms of the patients recognizing signs and symptoms of their heart failure. And so even at end stage, very important that they be aware of what to look for. And so specifically looking at unrelieved shortness of breath, worsening weight gain, so that patients know when to contact their care providers. There's a very helpful diuretic protocol that was published a few years ago, and it's linked up here, which I realize, I don't know if people online can click on it, but I'm going to go through it quickly in terms of helping to manage diuretic titration, which I find I often get referrals for, particularly in my cardiac palliative clinic. So when patients are presenting with a change in their status, dyspnea, orthopnea, PND, weight gain, they often warrant a history and physical unless you know the patient very well. And so sometimes we can titrate things over the phone. And then, so then what do we do? We say this is, yes, in fact, the heart failure decompensation. And so we can escalate diuresis or monitor depending, but typically we escalate diuresis. And in outpatient setting, we can have either the LIN have increasing RN visits. Sometimes patients come in for a quick nursing assessment and then considering labs, of course, and calling the cardiologist to inform, depending on whether you're primary care or the specialist. And so escalation of oral therapy should be the first step, particularly if you've had success with previous escalation of oral therapy. And a patient who is on high doses of oral therapy, I'll get to that in a few slides, but those patients who are already diuretic resistant probably should go directly to the other arm of this algorithm, which is initiating IV Lasix. And so those patients already on high dose, as I mentioned, should be considered for IV Lasix from the get-go. And so after that, you have to reassess patients for a symptom improvement, generally within 48 to 72 hours. And depending on their response, decide what to do, either going back to oral Lasix if they've improved or escalation of therapy. And ultimately, there are patients who will continue to be refractory to increasing doses of Lasix. And at that time, this may be a flag that you need to transition to end-of-life pathways. And so this is, again, just reiterating what I've gone through, but just in terms of escalation of therapy, I think it is a very helpful table or algorithm to go through for those who may not have the same familiarity or comfort with Lasix dosing. And so it gives the current dose that the patient may be on with a suggested new dose, and then reassessments every few days and escalation as appropriate. And same with intravenous therapy. So here, the dosing, of course, based on your oral dose. I typically use the same dose IV as oral. So if patients come in on 80 of oral Lasix twice a day, I increase it to 80 IV BID and find that that strategy typically is pretty well tolerated. And so moving on to inotropes, we have a program in our own LIN for palliative inotropic support within the home. And so I wanted to mention that today. What is an inotrope? So a positive inotropic agent is a medication given through an IV that increases the contractility of the heart. And it has been associated with an improvement in symptoms at end of life for patients with heart failure. There is a risk of arrhythmia and catheter-related infections because these have to run through a PICC or some sort of central line. But when patients go home on them, it's typically through a PICC line. They are associated with improved functional status, decreased NT-proBNP, and even decreased costs, as demonstrated in some trials in the US when patients are on dobutamine. And so as per the guidelines, they can be considered as a palliative therapy for symptom control and improvement in overall functional status. And so our own protocol, which was developed just a couple of years ago for the LIN, has some stability criteria. So patients do have to be stable in hospital before we send them home on home inotropes. But in doing so, we have actually been able to support patients out of the hospital on home milrinone. So in the US, they tend to use dobutamine, but in Canada, we use milrinone. There was a shortage, as you probably know, up until just recently, which has improved, fortunately. But we have been able to support these patients at home. And the palliative milrinone requires no monitoring. There's no specific blood work. We don't adjust the inotrope dose once it is stable at home. There, of course, has to be an acceptance of a palliative approach to care when patients go home on home milrinone. And typically, patients have their ICDs deactivated with the understanding that there is an increased risk of arrhythmia with the use of an inotrope. And inotropes will eventually be discontinued when either the quality of life decreases or the patient requests it. And so if patients are not eligible for advanced therapies, we have really maximized as much as we can their GDMT and their Lasix or their diuretics, and patients continue to decline, then really here is the role for an integration of palliative care. As I'll say in later slides, I would argue that palliative care belongs much earlier in the heart failure pathway, but often this is kind of the time when patients become are referred. So palliative care, there are many definitions out in the literature. One is that it's defined as patient and family-centered care that optimizes health-related quality of life by anticipating, preventing, and treating suffering. And so again, what did the guidelines say? So the 2022 AHA guidelines and the ESC guidelines, which I'll show in the next slide, have actually been much more prescriptive than our Canadian guidelines in terms of what to do or how to integrate palliative care. And so this really is specifically focusing on high quality communication between the patient, their family, and the healthcare team, the conveyance of prognosis, clarifying their goals of care, shared decision-making, and then focusing on symptom management, of course, and relieving suffering.
And so the same is true in the European guidelines, really this focus on maintaining quality of life as best as possible, frequent assessment of symptoms, looking again for advanced care planning, and making sure that things like deactivation of devices is included in terms of those discussions. I will say that there's quite a challenge with integration. So palliative care, as most of you will know, was developed from an oncology patient population. So it's really, when it comes to heart failure, it's like a square peg in a round hole. We keep trying to use an oncology approach for a non-malignant patient population, and that isn't always appropriate. I would say it's actually rarely appropriate. And from a resource utilization standpoint, in Ontario anyway, palliative care resources are prognostic based. So everything is based on a prognosis. But in heart failure, prognosis really still defies us. So we have a lot of difficulty, despite all of our calculation models, our risk prediction models, to really define how much time a patient has left. And so this limits their ability to access palliative care resources. There's lots of data that there is benefit to the involvement of palliative care in hospital when patients are admitted and at home when patients are at end of life. There's less evidence for palliative care when patients are between all of their exacerbations, and there's even less evidence for when patients are well early on in their clinical course or soon after their diagnosis. But as most of you will have seen this slide before, there is a role, likely very early on, and some of the studies that we have from the last 5 or 10 years would suggest that we can improve quality of life, symptom burden. There's a signal to even less healthcare utilization in patients who do have the introduction of, or the integration rather, of palliative care therapies in terms of their clinical course. And so here you can see at the top is the very typical clinical course of heart failure, which is punctuated by these acute exacerbations. And then at the bottom here, palliative therapies, which can increase in terms of intensity as the patient gets more and more sick. And so I would suggest that the referral should be prognosis independent, meaning that it's based on function and needs rather than the prognosis, to address things like symptom management, advanced care planning. And so we're trying to meet the needs of the patient without giving them a defined timeline. There are significant challenges to the discussion around goals of care. And so this I wanted to highlight mainly because, again, when it comes to the discussion, we have to be careful about the uncertainty. And I acknowledge that when I speak to patients, that there's a lot of uncertainty around prognosis, but that the clinical trajectory is really required to calibrate their expectations and to guide timely decisions. And so really predicting needs, which I've highlighted, rather than the exact prognosis, I think is very important. And so the discussions should focus on the patient's illness understanding the diagnosis of heart failure, the complications of heart failure like cardiorenal syndrome, so that they're actually ready to make decisions at later stages when they do develop those complications. The last piece, just in terms of the goals of care discussion, because I think this is still a very tricky thing, even for cardiologists, is the discussion around device deactivation. So ICDs are often implanted with some discussion around the eventual deactivation of the device, but often patients are not aware or have a lot of misconceptions about how the device functions. And we know from the literature that many end-stage patients will end up with their device function activated even when they end up in hospice. And this is just one example of a survey that showed that patients in almost half the patients in the hospice had only the half had their device shocking functions turned off. Interestingly, when we have looked at the literature, most patients choose to remain, to have devices remain on, which is a bit interesting. But irrespective of this, the discussion really around device deactivation is crucial. And so some of the misconceptions, and one in particular that I try to demystify, is that the ICD functions as a pacemaker, and we do not turn off the pacing function when we deactivate tachytherapies. And so turning off the tachytherapies turns off the shocking function of the device should the patient develop an arrhythmia, but the pacing function will remain. And so patients sometimes have a misconception that we're turning off the pacing function and that they may die immediately, and that's really not at all the case. But what does happen very often in the community is patients don't have it deactivated, and then we apply a magnet at end of life, which looks like this. And so we often tape a magnet over the patient's device to keep it in place for the last few days of life. This is obviously not the most desirable outcome, as ideally patients would have it deactivated in clinic. We do have a collaboration with the LHIN presently to really formalize the mechanism to identify patients with an ICD and try to really formalize the plan in terms of how we get these patients back to clinic for device deactivation, and trying to get magnets out into the community as well. There will be a position statement on ICD deactivation, actually led by Dr. Redpath, who just spoke now. And so that should also help to inform clinical practice. There are some very helpful patient guides that are available. This one from Core Health can be very useful for patients and families when it comes to this discussion, particularly in fast-paced clinics when we don't have a lot of time to go over what is a very time-consuming discussion. So finally, when it comes to the integration of palliative care, I often get asked about the stigma around palliative care and patients don't want to come. And this is a quote from a paper online that just says, we're going to ask a team to come by and see if there's anything they can do to help with you to live as best as you can with heart failure. And that team's called palliative care. So trying to reduce some of the stigma around the integration of palliative care for patients with heart failure. And with that, I will take any questions.
So much. Does anybody in the audience have any questions? Okay.
Just curious with the prevalence of remote deactivation.
Yeah, so very good question. So in Ottawa at this time, it does not exist. It is not available to us, but there is one small pilot study that is happening in Kingston that is looking specifically at that, so remote deactivation. So the technology exists, it's just not widely available, and ultimately that would be the goal, that patients no longer have to come to hospital. We are able to interrogate devices remotely as it stands, and so the technology is there to communicate with devices remotely. It's just not used for deactivation. Yeah, but hopefully in the next few years, which would be great, because I not so infrequently get a frantic call asking for a magnet in the community. And so this would be much, much better.
So question about the LVAD. You said there's some program you can use LVAD as a bridging to heart transplant. In that case, normally how long the patient had to wait and what's the outcome?
Yeah, so great question. So we use the LVAD as a bridge to transplant when patients have a contraindication to transplant, like pulmonary hypertension, for example, and we have to demonstrate that we can bring their pulmonary hypertension down with the LVAD in place. And it can also be in the context of a patient with a recent malignancy where we want them to prove that there's no recurrence of their cancer for several years before committing them to transplantation. And so there are several reasons for a bridge to transplant. The wait depends on a few things. LVADs used to be listed very high on the wait list just by virtue of having an LVAD. And just this year, they were downgraded in terms of their status. The status listing was revised in Ontario, and as a result, we've downgraded LVADs, mainly because they were highly listed, and they were some patients are very stable. And so they were consistently getting hearts ahead of patients who were at home and maybe sicker without an LVAD. So they've now been deprioritized in terms of their listing. And the weight depends on things like the patient's size. So if their body habitus is not average, so very tall or very, very small, those patients at either end tend to wait a little bit longer, and also depends on your blood group. So blood group O patients tend to have the longest wait. So it can be anywhere from a few months to a year. But the LVAD usually would not wait that long. It would only be a few months because of their higher listing. Now that the listing criteria has changed, this has only just happened. We'll see how long they wait, but typically they only wait a few months. We don't implant, I should say that we don't normally list them for transplant until a minimum of 3 months after the LVAD implant, because we allow them time to recover, rehab before we put them back on the list for yet another open heart surgery.